so that there's a better understanding of what we are doing and how to do it better, and using data to drive that process.
O projeto tem fundamentalmente três componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de melhoria de qualidade de dados e uso nos processos de tomada de decisão.
A informação é colhida ao nível da unidade sanitária pela enfermeira e passa depois para o resumo.
Por exemplo, se ela consegue notar que das 100 mulheres que vieram fazer consulta pré-natal, só consegui fazer testagem em 80, porque os testes acabaram. Acabaram porque eu, enfermeira, não pedi, acabaram porque o sistema não tem.
E eles têm essa capacidade de fazer essa análise ao nível local, da unidade sanitária, e constroem os seus gráficos para poderem tomar decisão ao nível local. Depois o resumo é enviado ao serviço distrital, e do serviço distrital essa informação entra numa base de dados que a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Ladies and gentlemen, good morning.
Depois leva à realização.
Have you had a good sleep? Hello? Have you had a good sleep? Yes, I certainly have had a good sleep, thanks to the showers of blessing yesterday. Yesterday we had a good time with plenary sessions and breakout sessions. I was particularly thrilled to join the early career panelists, and I was really happy to listen to the kinds of mistakes that the young scientists are making, and that makes me very, very happy. Because the earlier you make the mistakes, the earlier you learn, and the faster you improve. For some of us, we didn't have that opportunity to learn earlier and make the mistakes earlier. So we are making the mistakes now. So it's good that you had the opportunity to make the mistakes and then have them corrected, and then you can improve. Sam, maybe we should just have somebody to give us an opening prayer and put us in the hands of God. Yes, Mauli? Yes, Mauli will give us the opening prayer to start our day.
Thank you. Shall we please be on our feet this morning? Father, we thank you for such a wonderful opportunity once again, day 2. We pray, we commit everything into your hands. May you bless it and make it a blessing. In Jesus' name we pray thanksgiving. Amen.
Thank you, Mauli, for committing us into the hands of God. But I have not heard any Muslim prayer nor a First Nation religionist prayer. Maybe we are all Christians. So this morning we are going to have a plenary session where we are looking at the Ghana Health Service innovations to strengthen the health systems in Ghana. And we have our very own Professor Bawa, the Director of RIPS, to chair the function. And I would like to find out if the various presenters are already here. Samuel K. Boachi-Boateng. Is Samuel K. Boachi-Boateng, are you in? Or he's arriving? Okay. Are you representing him? Okay. Yes. So Samuel K. Boachi-Boateng is here. Bernard Bedu Bediakon, is he here, or his representative? His rep is here, and you are ready to present. Thank you very much. Please, what's your name? Harry. Mariam Amidou. So Mariam Amidou would step in for Bernard Bedu Bediakon to present. Fred Adomaku Boateng, are you here or is your representative here? Okay, maybe still arriving. Then we have Charity Binka and Asiyi Kwodochi, Amren and Ghana Health Service. Is Charity Binka here and or Asiyi Kwodochi? Okay. So we want to take it the way we did it yesterday. So we are at 9 o'clock on the dot. We would like to invite the first presenter to climb up here and make the first presentation. Thank you very much. Oh, yes. Yeah, you know, I'm sorry about that. Yeah, so please, Mr. Chairman, please put your hands together and welcome the chairman for this panel session. Mr. Chairman, over to you.
I can understand your excitement over yesterday's success. So, good morning to all of you, and welcome to this morning's session. As the MC has already said, this is a plenary and is devoted to Ghana Health Service for them to showcase innovations within the service and to share what has been going on in different parts of the country as far as delivery of health services is concerned. So we are very thrilled this morning to have 4 presentations to be made, and I'm particularly glad that the director of PPMA is leading the pack in this session. So without wasting so much time, I would call on Samuel K. Boateng, who is the director PPMA, to make a presentation titled Implementing NOP Guidelines, Improving the Processing and Submission of National Health Insurance Scheme Claims at Gogu Health Center, Boko West, Upper East. Yes, there's a control. Okay. Let me project it all. Okay. Yeah, good morning. Good morning. Good morning. Exactly. So I'm setting the tone. I'm doing this presentation on behalf of my team. That's Health Systems Innovation, implementing NOP guidelines, improving the processing and submission of NHIS claims at Gogu Health Center in the Boko West District. This will be the outline of the presentation, introduction with some QI issues, the research objectives, data and methods, results and conclusions, and some few recommendations. So on the introduction, it's about networks of practice, which, yes, I said, builds on community-based health planning and services, which we've talked a lot about it. I think basically, when we say network of practice, it's about strengthening the subjects to the health centers so that they can really have proper oversight over the CHIPS and other facilities so that we can actually provide access and quality of care. So CHIPS did very well, but over time, that place was handicapped in terms of infrastructure, human resources, and all that. NHIS, yesterday we talked about it as one of the major pillars for achieving universal health coverage in Ghana. With this introduction, a lot has been achieved. The good thing is already we know that it covers 95% of our conditions, but there are still challenges. And so realize that when you come to especially the northern part of Ghana, Upper East, Upper West, and the rest, most of the people come with insurance. So about 95% of people who access our facilities are on insurance. But despite that, realized that the issues with claims processing was highly challenged. And so it leads to backlog and leads to reduced IGF, which in turn will affect the quality of work we produce at the service in terms of infrastructure and equipment, and will affect demand. So with the end of January 2024, our team, that the region, the district, and the service decided that there was the need to look at claims processing and look at recovery of IGF in the Gogo Health Center. Before I go to the research questions objective briefly, I mean, since it's a quality improvement, some gaps had to be identified in the facility. Issues of poor data management was recognized. There was suboptimal knowledge of staff on reporting formats, and there was no functional community emergency transport system. In fact, for those who are familiar with CHIPS, we call the sets, whereby there is a motoken or pragia, which is either at the facility or in the course of the community, whereby they used to take the pregnant women or people who are sick to health centers or to hospitals. And this one, we didn't have it at Gogo Health Center. And there was no knowledge of staff on claims processing and submission. So, having identified these gaps, there was a need to prioritize. We cannot do everything. And prioritization, there should be a criteria. So, the parameters of variables were one, affordability in terms of time and resources, and then whether the issue they want to address or want to address under our control, we call it scope of influence. Because if something sits with central government, you can't be a Ghana Health and resolve it. Then the ease to achieve it and important to clients. So the measurement was from 1 to 5, where 1 is the least and 5 is the most preferable. So when they rank these gaps, if you look at the poor data management up to low processing of NHIS claim, the last one, low processing NHIS came top 17, 3, 5, 5, and 4. So it means that was where they could focus on. Of course, that will be a digression, but if for those familiar with the Pareto principle, it means that we could focus on this and get optimal results and later deal with the others. Now, when you have identified a challenge, there's a need to do what we call root cause analysis. And there are many ways to do it, tools, 5 by twice, etc., etc. But here we use the fishbone, whereby the red we see is the head of the fish. And you have 4 parameters which we'll be dealing with, which then will lead to the fence. So we have clients, issues of staff, issues of processes and resource and logistics. When it came to the clients, in terms of looking at the root causes, there was issue of expired NHIS cards and low patronage of healthcare services at the facility by clients. In terms of resources and logistics, there was inadequate computer. At the time, there was only 1 laptop. It was not even in good condition. And also inadequate internet data, in fact, poor internet access, which of course is not only peculiar to Gogo area, but it was a challenge. In terms of the staff, at the time they have only 5 staff, you can just imagine. But over time, when they started intervention, they were to attract 4 to make it 9. That's why I have those figures there. And then that's the high workload. And inadequate staff trained on HIS claims. You see, we deal with the NHIS most of the time. Facility managers, directors, we will not take time to make sure they are trained working with the NHIS staff. And on processes, there was poor internet connectivity. And for claim submission, then NHIS have come with what they call claim it software. What is happening, just like happens to our computers, they will give you the update, but you have to download and then install. But because of this, they could not even download and install. So the software they were employing was very outdated. Now, in terms of QA, I'll just brief about this. And looking at all the courses, the team sat down and focused on inadequate staff trained on NHIS claims and inadequate computers for NHIS claims capture and submission. And therefore, they have to do sort of change ideas and some interventions to implement. So for the inadequate staff, they changed ideas to train additional staff on the processing, entry, and submission of claims. Then also, when it came to the PCs, I think the best thing is that they will liaise with the assembly, the region to get additional computers. But they thought that staff had their own PCs, just like we have our own phones we could use for telemedicine. So they engaged the staff so that they could put the claiming software on their PCs for use. And I think they were very successful in that. So the staff were engaged and claiming software was put on their laptops for installation. Now, on the issue of the research question and objective, the research question was, what is the outcome of the NOP intervention on improving NHIS submission at Gogo Health Center. And the objective was to increase NHIS claims from a median of the median value for the whole annual 2023 of 3,980 Ghana cedis to at least a median of 6,505 by close of 2024. In terms of study design, we realized that 2023 was the baseline year, or maybe the pre-intervention. And then 2024, January, the intervention was started, so the intervention year. So the study was actually an implementation study, but the study design principle then was quasi-experimental, which actually is used in public health programs to evaluate interventions. The study setting was in Gogo Health Center in the Boku West District in the Upper East region of Ghana. In data analysis, SPSS 27.0 was used, and a student t-test or independent t-test was used to compare the means of the monthly or mean claims for 2023 and 2024. And the p-value level of precision was 5%. That is, if the p-value they get from this t-test value was less than 0.05, that means that was statistically significant. But if it was more, that means that it was not significant, they had to reject it. It was not causing any improvement. On the findings, if we pay close attention, you realize that for 2023, we have the amount submitted for every month. January 32 now, I won't run through all of them, up to December 3870. And the amount submitted after the intervention in January 2024, January 2024 was 3584. So if you compare to 3291, it's higher. So if you look at it carefully, every month was higher than the corresponding month in the previous year. And that showed that the interventions was really working. If you look at the total claims submitted, it was 51,436 for the year 2023. And for the intervention year, it was 95,708, which is quite a significant jump. When you look at this graph, you realize that it's moving up. If you look at this year, there was rise, but when it came to June to July, there was a dip. Then from October to November, there was a dip. And November to December too, there was a dip. But what we call statistician, I'm not a statistician, I'm an expert in that, I'm hence some expert, but the line of best fit will be in the upward direction. Now, still on the findings, realize that for 2023-2024, we have the minimum and maximum to look at the range, and for that matter, the spread, and the median. We even have the interquartile range, but I'll keep it brief. If you look at 2023, the minimum was 2597, the maximum 6577. And realize that compared to the minimum and maximum of 2023, there's a lot of appreciation. The median for 2023 was 3980, and for 2024, it was 8,659. If you come down and look down here, it's significant to look at the p-value from the student t-test or independent t-test, which is less than 0.001. So it means that it's largely significant, impressive. And the confidence interval, negative, they are negative, they don't increase at zero. So that also shows it's a way to measure it. So the increase in the monthly mean NHIS claim from 4,286 to 7,957 was highly significant. The intervention implemented in January 2024 resulted in substantial increase in NHIS claims. Finance 3, so the total amount, now we're looking at the annual, the cumulative, the annual amount of NHIS claims submitted increase in 2023 from 51,000 to 95,000, marking an 86% rise. And it's also instructive to know that no tariff increment during the intervention period, so that there's no confounding in terms of an increment. Then the median monthly claim is as stated, and the mean monthly claim increase significantly is also stated there. So from the non-intervention period of 2023 to 2024. So implications for health financing, briefly as I conclude. So enhancing financial sustainability. So we realize that a lot had been achieved over the 1 year. So the successful implementation of these interventions signal a clear pathway towards enhancing financial sustainability for health centers reliant on NHIS funding, fostering a healthy operation environment. So it's important that you pay attention to claim submission. People should be trained. We have to work with the NHIS staff to build capacity. Because I remember the former Deputy Director General said, the claims you are submitting actually is what? it's like your check. But because it's not fiscal cash, people don't pay attention to it. So as managers, at regional, district level, sub-district level, we need to look at the recommendation for future intervention. Future interventions should emphasize continuous staff training. It's important because staff will leave, you need to continue to train them, build capacity. And then the issue of adequate computation, if you come from central, national, regional, of course with partners, we need to look at it. And the issue of internet connectivity. I'm thinking of the Starlink. I don't know how we exploit it very fast, but there's a cost component because, for instance, yesterday I had the Zoom and I was on the first floor, executive towers. For 1 hour, I couldn't join the Zoom till I came into my car. And you can just imagine. And the people were waiting on the Zoom. So it's an issue we all need to look at. And this will make the claim submission efficient, responsive to evolving healthcare demand. In conclusion, some of the key outcomes. The study concludes that targeted interventions significantly improves NHIS claims submission at Gogo Health Center in the Sapega sub-district in the Boko West district, the Upper East of Ghana, demonstrated the importance of competency-based training and adequate resource allocation. We say competency-based, that the knowledge, the skills, the experience, and the attitude is very important, so that we leave that from it. Then benefits of targeted strategies. Targeted strategies yielded numerous benefits, some of which include reduced claim processing time, yes, enhanced staff competence, and improved financial outcomes, ultimately secure healthcare access and quality for the people we serve in that part of Ghana. Potential for broader application. The positive account present a compelling case for application of similar interventions across all our sub-districts and health centers. It's an issue because when I went to Upper East Region, the rejection rate was very high. It has come down. But when I used to compare to Dodova or something, they were doing very well. I think that it can be that we need to look at all these things in terms of capacity. A case for application of similar intervention healthcare facility contribute to effective, efficient, and timely claim submission across the healthcare facility, accumulating significant increase in healthcare facility internal generated fund. And when that is done, it will improve the infrastructure and all that staff motivation and enhance demand. These are the references. Thank you for your attention, and all are duly acknowledged. Thank you very much.
Thank you very much for the presentation. In my capacity as the acting chair of the session, I wish to invite Mariam Amidou to make her presentation. Thank you.
Good morning to all dignitaries present. Good morning, ladies and gentlemen. You can see my regional director of health services around. Director, good morning. My name is Mariam Amidou. I'm doing this presentation on behalf of my district director, Director Bernard Bedu-Beduaku, on innovation approaches to resource mobilization for improved outcomes in network of practice, the success story of Amasia West District. Okay. So we'll be looking at introduction, objective, the methodology, results, conclusion, and some few recommendations. Sorry. Okay, so through the presentation, we are going to be seeing keywords such as network, community engagement, resource, hub, and spook. Our main objective is to establish how community engagement and local resource mobilization can be used to effectively implement network of practice. So as a way of introduction, we realized that over the past years, focus has been on the CHIPS, that's the community-based health planning and services, and district hospitals, which are resourced to perform their roles and responsibilities, to the neglect of our health centers. Ideally, the health centers are supposed to be the gatekeepers between the CHIPS and the district hospitals. And so they should have been well-resourced enough so that cases at the CHIPS level could be referred to them to manage, so that hospitals will have adequate and ample time to look at higher cases that would have been referred. But that's not the ideal situation. The situation we find ourselves right now is clients would bypass the health centers and go straight to the district hospitals. Okay, thank you. They bypass the health centers to the district hospitals, and you go to the district hospitals and their patients are choked in, the staff are overwhelmed with the work. And realize that most of these cases, about 80%, could have been managed at the health center level. So this weakness led to the Ghana Health Service proposing an initiative to develop the networks of practice, where a health center is upgraded to become a model health center or a hub, which is surrounded by smaller facilities, such as the CHIPS compounds, maternity homes, over-the-counter medicine sellers. They are referred to as the spokes to support each other. However, this cannot be achieved if there are no enough or adequate resources. And so there is a need for resource mobilization from key actors and key partners and collaborators, both locally and externally, in order to achieve the expected outcomes. Hence, at ISSER West District, we decided to embark on an extensive stakeholder or community engagement. So somebody may ask what community engagement is. It's a process of working collaboratively with and through groups of people affiliated by geographic proximity, special interest, or similar situations to address issues affecting their well-being. It involves partnerships and coalitions that help mobilize resources and influence systems, change relationships among partners, and serve as catalysts for changing policies, programs, and practices. So our ISSER West District has a population of 119,792. It has 3 sub-districts with 2 NOPs, which are Esuo and Antwerp Chrome networks of practice. And so let's look at our methodology. True leadership, and that has to do with a selfless, committed, and dedicated leadership, together with the team, the district health management team. We developed a positive passion because we have a committed leader. This is our district director of health service, who is taking the lead in offloading mosquito nets, and so that he is able to harness the team to help him to be able to achieve his objective. Then we embarked on community entry. We had to plan to be able to enter the community. We identified key opinion leaders in the various communities, and we went down to sell the idea of the networks of practice to them so they'll be able to get their buy-in. We also held meetings with stakeholders such as chiefs, the DCE, elders, and political leaders like the assembly members. Then there was also engagement at the community radio stations. We held discussions. We also had community debates. Then there were sensitization meetings for staff and management of the NOP facilities on the NOP concept. And we also had to conduct community needs assessment together with the community to be able to identify the needs of this network. Then there's also the quarterly community health management committees assessment on the 9 quality of care indicators to serve as quality improvement process. So through the assessment, the team, they are able to kind of look at how to mobilize resources locally. So it's also enhanced community ownership of the networks. And so we needed to launch the networks, the 2 networks, and we're privileged to have our immediate past Regional Director of Health Services, Dr. Tim Crine, to have graced the occasion with the political leaders. We had our DCE, the traditional leaders, and the community as a whole. And so, the network of practice, this is one of the networks at Amasia West District. We have a Suonyunu Model Health Center as the hub, surrounded by smaller facilities such as the CHIPS compounds, the over-the-counter medicine sellers, maternity homes, and the rest. And so there's that interconnection between them, like the bicycle tire. We have the central point, which is the hub, and there's that interconnection to the lesser facilities, known as the spokes. And so the CHMC meeting I talked about earlier on community cost scoring at Suonyunu. So they had gone round to assess the facility, and they are back to kind of judge as to how to mobilize resources on identified gaps. Okay, so let's look at the results of our community engagement. We had the chief of one of the networks, the Suonyunu. He was able to mobilize a team of medical doctors from the US to come down to conduct screening for the various communities. Then also the next picture, he was also able to donate medical equipment and supplies to the spoke. Then we have the assembly members he donated the medical equipment to the hub. Then the assembly members also donated a standby generator and other medical equipment for one of the spokes. And we also have Asanko Gold Mine. It's a mining company in the Amasia West District. They also came to donate some medical items and supplies to one of our health centers. Okay, so at Suonyunu, they earlier had no maternity unit or block and nurses quarters. So the Suonyunu, the chief of the community, single-handedly built this maternity block and nurses quarters for the staff. And this is the lab of the hub. A philanthropist, an individual single-handedly resourced this lab to enhance quality of healthcare. And now the results has led to an increase in OPD attendance from 18,496 in 2023 to about 27,000 in 2024. Also, ANC attendance has increased from 4,992 to 5,558 in 2024. Then also anemia at 36 weeks. You all know that the target for anemia at 36 is 35%. But the district, one of the networks have been working below 10%. Then the community scorecard scoring. At the beginning of the year 2024, the first quarter, we had so many rates. Then the rest started reducing. So you realize that fourth quarter 2024, our greens had increased. We've improved with a few reds. And now, the results of our hard work. Our district, the Amansia West District, last year, when we had our regional performance, Amansia West District was adjudged the overall best performing district for the year 2024 out of 43 districts. Then our district director was also adjudged the best district director of health services. Then he was also adjudged the best health man for the year and best health manager for the year. Then the chief, the ISSER Auditorium, the Ghana Health Service Excellence Awards, he was also rewarded for the community support. ISSER Auditorium Health Center was awarded the best health center in Ashanti region in both 2023 and 2024. In 2024, Amansia West District alone received 7 awards of the regional awards. So in conclusion, what we are saying is that community engagement and ownership is very key to the success of the networks of practice. Resource mobilization from all stakeholders has brought tremendous improvement in the access and quality of healthcare delivery in Amansia West District. The outcomes have been no maternal or institutional mortality and no under 5 years death due to malaria, diarrhea disease, or epidemic-prone disease within the networks of practice. We are recommending that for a successful NOP implementation and sustainability, community engagement and ownership should be strengthened. And this should be the priority of the district health director. Model health centers should be well-resourced by the government in terms of logistics and staff. Then resources should be mobilized from all stakeholders. Prescribing levels or coverage of the physician assistants at the model health centers should be reviewed and expanded. Road network should be improved in deprived districts such as the Amansia West District for easy transportation and referrals. And we are also soliciting that the NOPs should have a vehicle. Thank you all for your attention.
Professor Ayagabawa has handed over the chairing of this session to Professor Patrick Assuming of the University of Ghana Business School. So can we have the next presenter?
Good morning. So I'm going to present this on behalf of the team. I'm Dr. Fred Adumaku-Boateng, the Regional Director of Health Service, the Ashanti region. And this is what we looked at. Improving access to quality health care in Ashanti region through the network of practice. And this is going to be the outline of the presentation as others have done. A brief introduction. We look at some objectives, data, methods, some results. We conclude and we give some recommendations. By way of background, I believe most of us are familiar with this, where we are looking at the Ministry of Health strategic objectives. Basically, there are 3 of them. And the first one is to promote universal access to better and efficiently manage quality health services. Secondly, to reduce avoidable maternal, adolescent, and child deaths and disabilities. And thirdly, to increase access to responsive clinical and public health emergency services. I believe from yesterday, the discussions had been the inability of CHIPS to help us to address this. All the discussions that we have been we have been having from yesterday, from the inception of the conceptualization of the CHIPS concept to the implementation for about 20 years. We believe that if you look at these three objectives, the CHIPS will not be able to help us to do. And therefore, we saw the challenge, which was basically due to the weakness in the health center at the sub-district level. So whilst we realized that the CHIPS were doing very well, the district hospital were doing very well, the linkage, there was a problem. And specifically, the problem was at the sub-district and the health center. So the overall goal that the network of practice is really to increase access to quality essential healthcare and population-based services for all by 2023, because we saw that the CHIPS will not be able to help us to do that. Now, I want us to have a look at the functions and activities of the network of practice, which would then zero it down during the discussion. And I basically want us to look at the network coordination. And when we are looking at this, you see the gaps when you look at the CHIPS. The first one, I would say monthly network committee meetings. Then we're also supposed to have monthly clinical meetings. We are supposed to have quarterly performance review meetings, quarterly sub-district supportive supervision, information sharing, in-service training, and the continuous sensitization of stakeholders on network of practice. And this is missing in CHIPS when it comes to CHIPS. Secondly, if you look at the financial arrangement and management, we are looking at, and I would zero it down to resource allocation and then distribution. I will rally around these during the discussion. So by way of background, let's have a look at Ashanti region. The total population, almost about 6 million. We have 43 districts. The number of sub-districts, 193. The number of health facilities, 860, and we are still counting. We have 120 CHIPS zones and compounds, 209. Health centers are 168, polyclinic, and then you see the okay. So that's the map for Ashanti region. Okay. So let's have a look at where the hubs are located in Ashanti region. So you see where the hubs are located in Ashanti region. Then you look at the percentage of population who can access the network of practice hub within 15 minutes using motorized medium. So the best ones are the middle, where our 80 to 100% can be accessed when you are looking at the hubs. But mind you, these are the hubs that are not well resourced. These are the health centers. And so if you are really talking about access, you are talking about quality. These areas are where clients will go and they will not be able to access that. And then you can also look at if they will have to access these areas, the hubs within 30 minutes. You know, as you increase the time, population is also increased. But mind you, these health centers cannot address the needs that we are talking about because of one, lack of human resources, lack of equipment, and lack of other. So if you look at Ashanti region, the hubs, about 96% of them are hubs, health centers. 3% of them are alpha chips, and then 1% are clinic. Alpha chips are, if you look at a sub-district without any health center, you look at the well-endowed chips compound, and that is designated as the alpha chip, and that becomes the hub for that. And these are the population, the coverage that you can really get when the health centers are really functioning in the ability that they are supposed to. And we are doing this and also adding the network of practice. So I selected some few districts so that we can discuss. If you look at Achuma and Punya, and then you are looking at only model health centers, it means they can capture about 7% of the population. But then, if you're able to have the network of practice, they're able to capture about 28% of the population. If you look at Sechafran Plains, you are looking at the hub, that's the model health center or the health center. They will be able to capture about 17.3%. But if you have a network, you are capturing about 50%. It shows that obviously the network is the way for us to go to address population-based health services and then also quality. So now, I was the deputy director for clinical care in Ashanti region at the height of CHIPS. And I remember when I assumed the position, I had the opportunity of also meeting Dr. Alexis Nambe-Fuba, who has come from Upper West. And what we saw in the implementation of CHIPS in Ashanti region, it was challenged. So when I came back as a regional director, it was kind of a deja vu, where we are also starting the implementation of network of practice. So as a way, we decided that, look, let's move around and then let's look at the implementation of the network of practice, because at that time, the guidelines were there. So we decided to do, these are the objectives that came into mind, to assess the implementation of network of practice based on the guidelines, identify strengths and gaps and other lessons that we can learn. And then based on this, we wanted to develop interventions and then train and implement in the interventions to see the outcome of the things that we would do. So what did we? We decided that as we were going through all the 43 districts, every district that we will go, we take only one hub and network, invite them, have discussions with them, review their data, and also do interview with some key people. And these were the findings that we came out with. So at the crust of the network of practice is resource allocation and distribution in the network. In a sense that if you're having about 5 or 4 CHIPS compound with a hub there, I'm using this as an example, and let's say you have oxytocin in one of the health centers, and at the end of the month, almost every time you're having expiry. As a network, you should be able to address this by looking at where you pick this from and send it to where the facilities will need. That's one of the resource allocation. How you are going to do that is crucial for the success of the network of practice. We realized that we didn't have any formal way where the network of practice should be able to do this. That's what we saw. Secondly, when we look at the main difference, the striking difference between the network of practice and the CHIPS should be the coordination, where you have somebody coordinating all the activities. There's this saying that, look, very good teamwork without leadership leads to a confusion. So you need a form of coordination, and it should be structured coordination in doing that. We looked at monthly clinical care meetings, and this will really address the clinical supportive supervision from the district hospital to these areas. They were not there. Quarterly sub-district supportive supervision are things that you are also looking for. And more especially information management. How do they manage the information as a network and not as individual? And one gap that we saw really was the way that they would do their financial mobilization and then use the money together. Because the National Health Insurance is not going to reimburse the network, no. The National Health Insurance is going to reimburse the spokes and the hub together. And the meetings that they are going to do, all the administrative charges that they are going to incur, who was going to pay for that, and how are you going to make sure it's also in tandem with the financial ATF and all those. So these were the gaps that we saw. Because of this, and then looking at the guidelines as a region, we decided then to develop some protocols based on all the gaps that we have been able to identify: resource mobilization, redistribution of resources, financial management, clinical areas, and then we have to relaunch to really make sure that all the important stakeholders are at the table, and then we remember what Dr. Awono said yesterday. Look, you all have to come together. Other than that, if you take the lead, but before you realize all of them are behind. And when it comes to health system strengthening the blocks, every part of the block is very important. So this is what we wanted to do. We saw clinical monitoring and supervision, financial management, and resource allocation. We developed guidelines, tools for operation for all of them, and then we worked on that. So as charity, we say begins at home. As a regional health directorate, we also went through the guidelines. We even did pre-test and post-test for ourselves, and all of us came on the same table. When we go out, we see the same thing, and then we discuss the same thing. So this is the results that we see, and we did this after we've brought all. And I have to state this: we also realized that the network were not trained together. So as part of support from the national, they gave us money so that we could train the network together. And after this, so before. Before is the baseline. We did a baseline for all the network across the country, and after this, the region, we decided to use the same tool to assess what the impact this had been. So these are some of them that I will want us to see. So what is of utmost important for me, others are, but I'm saying this is have a look at the NOP with designated bank accounts. At the beginning, it was not assessed. When we even did the training and we went back, we saw that it's only about 5 or 7% of the network of practice that have designated bank accounts. And then they have rules, they have prescription, how much you pay, how it's monitored. Then the other one that I wanted us to see is also protocols for patient care, and then the referral policies. These are things that, for example, how do as a network, which cases will one of the spokes refer to another spokes, refer to the hub, the coordination, what's the gap? How is the hospital going to come to support all these? So we have developed protocols for all these, which we are using. So this is what we see. So one gap that we saw was the network of practice, the committee. Look, almost every hub that we went, every district that we went, and then when we were going, we requested that the network committee should come. Almost invariably, whenever you got there, to them, the network committee was just the hub members. No, the network committee is supposed to be heads of all the spokes and hub, and then you have also, after the assessment, this is what we saw. So these are some of the things that availability of the network committee now is about 79%. These are the engine, the leadership and the governance when it comes to the network of practice. And then you have the network having names of committee members, their numbers, where they are, their functions. All of them now have been captured. And then this one, the first one we did, we looked at the monthly meetings that they have, the minutes. The next action, the next time when we are going to go in the next, we are going to look at the action points captured in the minutes, what have been implemented. It's not only the minutes that we want the outcome that we and then that is basically what I'm talking about. Network having minutes, network committee having minutes of the previous. The minutes are okay, but what are the action points and the action plan that we want to see? In conclusion, network of practice has the potential to address population-based primary. You saw, if you just oppose the network on the hub, the kind of population coverage is massive. So if you are talking about quality, and then the network is having quality, you'll be able to achieve all the three major objectives that the ministry and by extension the service is also looking at. And we are saying that attention should be paid to network coordination to be able to undertake the prescribed activities to ensure that the functions of the network of practice are being carried out. And these are the recommendations that we have to continue to add the required inputs to improve maturity levels, functionality, lab, technicians. So these are challenges that we are doing redistribution. We have requested the hospital to see to us their dispensary technicians, and we are taking them to the hubs for. We have to continuously build capacity for staff, leadership, and stakeholders regarding the identified gaps. It's very important. Then we have to support region to do district supportive supervision, district to support the sub-district, and all including clinical supervision. Thank you.
Thank you very much for your presentation. So we'll move on to our last presentation, which is on the innovative partnerships for community accountability. Let's welcome the presenters.
Good morning, my distinguished audience. We are still standing on the existing protocol of yesterday. My name is Charity Binka, and I'm the Executive Secretary of African Media and Malaria Research Network. And my co-presenter is
ISSER Auditorium, the Policy Department of the Ghana Health Service, PPM.
I've been here since yesterday, and I've been listening to all the wonderful presentations, and now all the research, and somebody will ask, so what is the media doing here? What are we doing here? I think we are here to talk about the missing link, because when we are talking about the health systems, we are talking about health systems. Why are we talking about strengthening the health systems? It's because of the people, because we want healthier societies. And we know that research has shown that many people in the communities, we in Accra, people think it's all in the rural areas, even in Accra here, they depend largely on the media for information about their health. And so if they are going to make, my mother in the village, when you go to her room, she has all kinds of drugs. You ask her, how did you come by this? Oh, she heard it on radio, that it will do this because she's old now, almost 90. If she takes this, it will help with her waist, her arm, her this. So she has packed so many things. Some of them are called dragons and all that. So I think it's very important that even as we talk about structures, we talk about the people who are providing health service, we also talk about information. What kind of information? We heard so much about research yesterday, but the findings, who is it meant for? The people. So we think that we have to have a conversation. And the African Media and Malaria Research Network has had a privilege of working for a very long time with the Ghana Health Service in various capacities, and we want to tell our story, and we want to talk about the collaboration with the PPMED, which we are very privileged to be working with, of the Ghana Health Service, to be working with since, I think, 2020, when we started developing a proposal together. The invitation to us was a surprise. We're asking ourselves, why are these health people asking us to come and work with them? But we are not surprised, because Amrin was born out of the need to create awareness around the RTSS vaccine, the new malaria vaccine that well, it's no longer new. When they started the trials under the Index Network, they had the Malaria Clinical Trials Alliance. So my NGO approached them to say that, how can we help so that parents will be willing to give out their children for this trial? And therefore, they facilitated that process in 2006 to bring together journalists from across Africa. Those journalists, they themselves, the researchers, identified the journalists that they've been working with in various African countries. I think at the beginning we were about 9, and then they added another one, it became 10. So we're able to visit all the sites that they were doing the trial. 11 sites in all, in 7 African countries. We did documentaries. We published a magazine called ISSER Malaria, especially focusing on the trials and everything. And we think that in our small way, we contributed to the acceptance of the vaccine. Many parents that we talk to engage with them in the field talk about how the differences they saw in their children, and therefore became the champions of the RTSS vaccine that we are talking about today. So 19 years on, we've still been working, and we have had the privilege of working particularly with the national malaria control programs in the various countries. We have been working with the national malaria elimination program in Ghana, and we are currently even hosting a coalition called the National Malaria Media Malaria Coalition in Ghana of our 100 journalists across Ghana. And we've had a privilege of working with, of course, the trial started with the centers. With the centers, we had some centers in Ghana that did the RTSS vaccine, so we've always been with them. And we also work with National Navrongo Health Research Center. We work with the Kintapo Health Research Center, Dodowa Health Research Center. And last year we had a big project with the WHO Ghana. And then last year also we were able to get accredited by the WHO Afro as a non-state actor to be able to do other things. So even though we started with malaria, we've extended our reach to other, because they are generally health journalists, we work on other diseases. And we are also, in doing our work with the WHO Ghana, we actually looked at the issue of vaccine uptake. And we worked closely with the EPI, and that was an experience. In fact, because of that, this year too, we are collaborating with them for the Vaccine Week and the Health Promotion Week. We just had a big webinar last week, and we've also been partnering with the UHAS now, the Malaria Research Center. We had a big webinar also last week. And so that partnership has been really very enriching, and we are very, very excited about working with the PPM-ED also of the Ghana Health Service. So that just briefly about AMREN, because we think that people need information to make informed choices about their health. And I believe, I've not done any research, so permit me if I'm wrong, but I strongly believe that most of the diseases that burden us can be avoided if people are able to make informed choices about what they should do and what they should not do. If they get the right information, I believe that the disease burden can be reduced even by 50%, who knows? So that's my belief. If the scientists are here, so if you don't agree with me, please allow me, because that's my feeling, because ignorance is worse than the disease itself. So at this moment, I want to pass the mic on to my colleague presenter to take us briefly through the scorecard project and what we've been doing together with them.
Okay. Thank you, Dr. Binka. Okay, so since yesterday and then even today, we've had presentations that have talked about the committee scorecard. So I'm just here to briefly take us through what the committee scorecard is and then the innovation that we are partnering with AMREN on. So what's the committee scorecard? So the committee scorecard, it's a committee-led accountability tool which provides platform for committee members and health workers to come together to provide feedback on the services that the health workers are providing for the community. And all this is to improve service quality and then responsiveness and then governance for the country as a whole. Then what's the goal? The main goal of the community scorecard is to amplify community voices in the health decision-making space, also promote dialogue between service providers and then users, that's the community, enhance accountability, improve quality of care through the community-driven feedback, and as well build trust between the service providers and then the community as well. So how does the community scorecard work? I said it's a community-led accountability tool, meaning that it's a space for the community, that's the Community Health Management Committee, as well as the committee members that attend or access health services within the quarter. So it's a quarterly tool, and then so the community come together to access healthcare based on 9 indicators, and they are mostly quality improvement indicators. It's not captured here, but then just to mention, so we have an indicator on the respectful and compassionate care. We also have waiting time. We have an indicator on the cleanliness of the facility, the availability of medicine, the availability of infrastructure, and quality of services that are provided, the leadership and management of the facility. We also have an indicator on whether the community health officers or workers or nurses are going for home visits, whether the volunteers are also going on home visits. We also have an indicator on the National Health Insurance Scheme, whether it's easily accessible at the facility. So those are the 9 indicators. And then the committees come together to score based on, the scores are capped at 1 being bad, 2 being average or normal, and then 3 being good. So they come together, they discuss the indicators, and then they vote based on majority. So after they discuss a particular indicator, they deliberate, discuss it, then come together, and then they give a score, whether they want to give 1, which is bad, 2, which is normal or average, and then 3, which is good. So those are the scores that are provided for the indicators, alongside with remarks or reasons for the particular score. So then after that, that's the community. Then after that, they come together with the health workers to discuss the scores that have been given. And then after that, they develop action plans to help solve those identified gaps that the committees have come together. And then we follow up. It's entered into the scorecard web platform, and then it's monitored. So we are the national can monitor it. The region, districts, and even the community members, if they are literate, can also monitor the actions that have been inputted into the web platform. So then the scores are entered directly into the DIMS, and then it's pushed into the web platform, which gives us aggregate scores in color codes, where red it's on track to achieving the solution for the problem. Yellow is that you are improving or you are in progress. Then green is that red is not on track, yellow is improving or in progress, and then green is that you've actually achieved what you decided to do. Then, so then we've partnered with AMREN on this to be like a visibility or a communication arm of the project. And this is not mostly done because for AMREN, as part of the community scorecard implementation, we wanted that the public becomes aware of the things that the community or the region or the country is doing as a whole. So that's how come we partnered with AMREN on this community scorecard implementation, being sponsored by Expertise France 5% initiative. So with that, I would hand over to my co-author.
Thank you very much, my sister. I think it's, yes, my daughter. My daughter. Yeah. Oh, it's been very interesting. This journey has been, we've been on for 3 years. And it's been we have had opportunity to be on another project where we had an interface meeting with the health workers and the community. And I'm mentioning one particular one that has to do with national health insurance. It was amazing. The officer came and he said, oh, they have been doing well, and the guy was standing there sweating. The people were saying, when we want to renew, we don't even know where to go. And when we go to some places, they take money from us, they exploit us. The man was saying the guy didn't know where to pass. And at the end of the day, the conversation calmed down. We calmed down and said, this is what we can do. And then that's when, as a regional officer, he realized that they were doing something wrong, or they needed to do, because not everybody can dial star 929 hash and be able to renew. And some of them, they said they don't even know it has expired. When they get to the facility, they say, okay, let's help you to renew. Some people take money from them. After that, they say they have to wait for 1 month. So which means on that day, they cannot get the facility. There's so much information we need as far as the national health insurance is concerned if we want it to really work for us. That is where the media should come in. On this project, we thought that we have the expertise in disseminating information. The journalists had the opportunity to be trained on how to use the scorecard in real time. So all of them have, those of them who came, all now have accounts on issues around maternal mortality, HIV, and all this. So all they need is, if they need information, all they need to do is to log on to that platform and they can get the information. So why does the media matter? Because we can amplify the concerns of the community. We have a wider reach. We can reach them just as the press of a button. People, if you go on radio, we can reach so many people at the same time, something that the health sector cannot do, or the health worker cannot go around the country in a minute, but the radio can reach. Television too can do the same thing. And we think that when the journalists come on board, that's one of the novelty. When the journalists come on board, they come not as reporters. Yesterday we saw them coming here to cover. They will go and write the story from different angles. Sometimes even when you look at the headline, you are wondering whether they were here. But when they come on as partners, the difference is clear. Even if you don't call them, they will call you. We have heard this, what can we do about it? And those of us who are concerned about Soli, they will ask you for when the journalists come on board, because they are already part, you invite them for the training, and whatever you get, they also get. So there's no need for you to be afraid. They'll call you, even ask you, can we do this for you? That is what we are talking about. We are talking about partnership. We are not talking about merely coming to cover. So these journalists have been trained on the scorecard so they can engage the public. They can also put pressure on the duty bearers, including government. They can go after a program and go and ask the critical questions that we cannot ask. I mean, well, let me say, the health practitioners cannot ask, or the duty bearers, as you are, cannot ask, or those who are providing service. It has also helped to sort of transform some of the reports and this actionable dialogue around the scorecard. And so we think that is a very important thing. About 52 journalists from 16 regions were trained about the scorecard, and then they became, and they were all paired with chiefs focal points in the various regions. In fact, in selecting the journalists, apart from our own members, we also got them to give us journalists that they were working with, so that after every program event, they can go back and work with them. And all the other district training programs they've been doing, we've been sending journalists from the various regions to be part of those training programs so that the conversation can go on, and they'll be writing stories. Now we expect them also to become champions of the CST. Of course, we thought that as journalists, there are so many success stories about the scorecard initiative. And so we think that we should put it together in a newsletter. And we have the expertise to tell that story. So we have started producing newsletters, trying to capture the voices of the people on the field, those who are doing the work and those who are receiving care. Also, so this you can see that we have the scorecard newsletter. So we now have the Ghana Community Scorecard newsletter. So far, we published 2, and we are hoping that the others will follow soon. It's a platform to tell the stories, to share the lessons learned, and also to inform stakeholders who otherwise will not get to know. We are hoping that the Ghana Health Service will put this, or we have the electronic version, to put it on their website that other people can easily access. So what have we learned? Through the training program we did, 45 stories were written right just because of the training program. And it's not easy to write even one story, get journalists to write one story. So if out of just one training program we can get 45 stories written, I think that is an achievement. Or you don't agree with me? I think you agree with me. And then the stories are still flowing. And there are a lot of other write-ups on social media and other things. And I think that is something that we should continue to do, to get journalists as partners rather than people who you invite to just come and cover. It has also increased transparency, because when we brought the focal points and all those people coming together, we are able to ask questions, important questions. What about, so it can improve transparency, because at the end of the day, we can't hide anything concerning health. If you are not doing it and you say you are doing it, by all means to come out. It's like getting pregnant and saying that you are not pregnant. By all means, the pregnancy will show, and baby will come out. So it has improved transparency and also improved responsiveness. Now we can link up with the health managers and frontline staff, and they can respond, because now they are more confident in talking to the journalists, because sometimes they think the journalists, they don't understand the science. So they are afraid to talk to journalists, thinking that if I tell you something, you go and misquote me. But now that we are together, they know they can, even if you don't understand, you can get back to them. So the building of trust is very important. The whole issue about inclusivity, the rural voices that we are able to capture, so that everybody gets to know that indeed their voices, everybody's voice matters. And then the sustained engagement. The project is going on. We have finished the first stage, and we are going to go on to the next one. And we are hoping that in the next 2-3 years, this kind of collaboration will go on, and it will be capturing the voices of the right owners and the duty bearers, so that together we will all make sure that we get a healthy society that we are looking for. So, we have already talked a lot about the success stories. You can see the pictures, the excitement. My very own Asseye is over there, and all the other people from Alma and the rest. So mutual respect and collaboration is very key between the media and the Ghana Health Service. We think that the staff, that has been fostered. And also any engagement with the media. You don't wait until the day before, then you call. So we are doing something at ISSER, can you come and cover? The person doesn't have any idea what you are doing. They just come and pick anything they want and they go. But that does not help you to achieve what the goal that you want to achieve by inviting the media. And then the use of local media. A lot of the program we did, people did it in the vernacular so that people can relate to the information. Then multi-level coordination across national, regional, community levels were ensured. And then there's an alignment and accountability. I think it's very important that we don't just talk in Accra, but we talk everywhere, because everywhere we have Ghanaians who need to make informed choices, but they need information. And that is what the media can do, to amplify the voices of the practitioners. So of course, people will say the journalists, they need this. Some people may think that, they will get some money from this, but at the end of the day, the long-term advocacy needs to be addressed. We need to ensure them that if you are in this business together, we will get a better Ghana that we want. Because you see, we are talking about politics, talking about so many things. We cannot talk about politics without talking about health. If you are coming here this morning, suddenly something happens to you, you won't be here. So it's very important that we talk about health. For me, health is even more important than politics, because health is wealth. So we're hoping that the journalists that have been trained will have an understanding that we have a duty. Because after all, journalists are also human beings. They also fall sick. If they don't fall sick, a member of your family will fall sick. The issue about consistency, media turnover and other competing priorities can challenge us, but it can be addressed. And then ethical issues. But the ethical issues can be overcome when we understand and the issues, and the journalists know that we are in this together. And then, so the solution will be, we have to continue with the training, we have to continue mentorship, we have to continue to forge these strategic partnerships and make sure that we document our success stories, our challenges, and how we are able to overcome them. And I think the newsletter aspect of it is also very important. We have to capture our stories, we have to tell our stories, so that even those who are not here, they can read in a very simple way without peer review. Because not all of us read peer review journals to understand what we have written. But if it's written in simple language, devoid of all the jargons, I can even put it in my bag and read, or I can go on the net and read it. It's so important that health information is as simple and it can reach everybody so that we can make informed choices. That is what all this partnership is about. It has worked and it will continue to work if we nurture it. And I want to say that AMREN is also present in other countries, and they are working closely with national malaria control programs and the various health services, so that together we'll have healthier communities and healthier people who we want to make sure. So we are saying that this is a model that can be replicated by other people who are working in education, water, sanitation, governance, and all the others. And we are happy that we are working with ALMA, WHO Ghana, WHO Afro, and this community of practice is a network of practice, and then all those things. In fact, during the meeting, the journalists were asking, all this network of practice, what are you talking about? It's like the health people are talking to themselves. So we want them to talk to us. And that has been demystified, and we want it to continue. So digital innovation is also important. That's why we are saying that the newsletters, all those things we must explore, because we are ready, the journalists are ready, and they are willing to work with you. Not to be, some people say we want to use the media. We should change the language from using the media to working with the media, because together we will win, and surely we should. Thank you very much. We want to say that we are very grateful to the Ghana Health Service. Of course, there's a recommendations. Government institution, we have to institutionalize the media partnership as part of the national accountability strategy. And for donors and partners, we have to find long-term media engagement, not just for short-term communication campaigns. So that must be part of your proposals. Effective use, you have to work effectively with the media. Must be put. It should not be just something we think about, because this project has put in the media as part of an essential component of the project, and it is working. And it can work for others also. We think that the journalists must make sure that whilst we are working with the health practitioners or the Ghana Health Service and other health institutions, we must be very ethical. Because health issues can be very sensitive, and therefore we need to be sensitive in the way we go about our practice, and must be community-centered. Finally, we think that the Ghana Health Service must sustain and scale the CSC media advocate model and document its contribution to policy shifts. It's very important. We must tell the story. And so we want to again thank the PP MED of the Ghana Health Service and the Ghana Health Service as a whole for giving us this opportunity and having the confidence in us to work with them. We are willing to continue all the way to make sure this project succeeds in a very special way. And then, of course, all the Ghana Health Service at the national level, region, district, sub-district, and the community, the AMREN itself, and the other partners who were part of this, who are part of this project. Thank you very much. And these are the signs and sounds of this thing. You can see all the excitement there. Our very own Dr. Yim smiling very broadly. It has been a very engaging session in the training, and we want to continue all this in the coming years. Thank you very much. Merci beaucoup.
I think we can do it better for them. Thank you so much for the presentations. We've heard 4 wonderful presentations, 3 touching on different aspects of network of practice, and then the last one on how we can work with, rather than use the media as health professionals and the researchers to enhance the work that we do for the good of all. So it's now time for discussion. So I'm going to open the floor. Anybody who has questions, comments. We have a fair amount of time, so maybe I might even allow short speeches. So the floor is open. Okay, so our first question comes from Dr. Adoma Kubuatin. Kindly still mention your name, and if the question is addressed to a specific presenter, you can also indicate.
So I'm Dr. Adoma Kubuatin. So my question is to the first presentation, Director Bibi. So I wanted to know how the change idea was tested and for how long. I don't know if you have any measure that you'll be able to show us improvement in the processes and the testing. Then I was looking during your findings, the first slide that you show. I wanted to find out whether in the explanation or in the measurement as improvement, you were still using the targets. And then specifically, let's say the trends for the targets for improvement. I don't know whether you ever use the run charts for the processes. And the reason why I'm asking that, if you really are using only the targets for improvement, if you look at the last data point that and then the trend, it means that we are going back to where we started from the pre-intervention. That's the first slide. That's the question. And then my other question to my mom, Madam Charity. So I want to ask, in this social media galore, where what place has Facebook, WhatsApp, Twitter, and all those come in working with the media? Because as we are sitting here, messages are flying all over. And they are communicating, whether we like it or not, how they understand it. I don't know how we work with them also to address all this, whether for useful information or for disinformation. Thank you.
Thank you. There's another hand here.
Thank you very much. My name is Hubert Amu from UHAS. And my comment is not a question, it's a comment to the first presenter. At the results section, you showed a number of pictures, while I was hoping to look at some statistical analysis which showed some relationships between some variables that, as the first presenter mentioned, are testable or not. What I'm trying to draw at is that a lot of facilities work with academia to make sure that the research you conduct is really one that you can say, yes, stand the test of time. For instance, the results that you found, the improvements, how sure are you that they are not due to other variables or other interventions that happened? But if you bring academia on board, we will bring all our statistical analysis and say that definitely the network of practice is the reason this particular change has happened. So it's just a clarion call to Ghana Health Service. A lot of you do very well in engaging academia, but the others, once you are conceptualizing the study, get an educational institution around you and collaborate with them. That way, you can publish the findings so that the general society gets to benefit from your results. Thank you very much.
Thank you. My name is Ledna Paz Campbell. My question is going to my madam. I just want to understand, in her presentation, she had mentioned that sometimes patients are shunning health centers to district hospitals. In view of the hub and spoke, I just want to understand the staffing and equipment and supplies. And the last question is, when these patients present to the district hospitals, there was a mention of long waiting times. So what are these district hospitals doing to deal with this challenge? Thank you.
Okay, I think maybe we will let we have had 3 questions and a comment. So maybe we will let the presenters respond and then we come back. We have enough time. We will go back. We will come back.
Thank you very much. Dr. Admako, that was a very good question as a quality expert. Of course, this is not academic. What is happening is that with the team, we did test it for a few months and it was working. So we settled, like I said, the first one when it comes to the computers, it was quite obvious that they couldn't get immediate laptops, so they used the laptop of the staff. So that was handy. I mean, it was available. But after testing the ideas, from January we started. But what I want to say that we didn't use the run chart. It's well taken. But the important thing is that, I mean, there are other ways to do things. We decided to use the independent t-test to compare the means. So that's what we did. We can look at the run chart, as we've said, as an expert, but if you look at the p-value, which was less than 0.01, it should have statistically significant. And we did involve some of the research experts at Navrongo Health Research Center to be up with us. So basically, that's what I can say to that. But I think the team was taking notes, and we look at that. Thank you very much.
Okay, so there are 2 questions for Dr. Benka and Asseyi.
I only remember the one, so I don't know where's the second one. About the misinformation and all that, right? How to use the social media. I mean, how do we control that? I think for the social media, maybe if I don't remember the second one, can somebody please remind me? But concerning the social media, we cannot control we don't control what people write. But if you have journalists or you have people who want to use the social media, the message must be targeted. We know what we want to do. So if you have targeted information, it can counter the misinformation that we are afraid of. If somebody is not in this room or somebody does not understand what is going on here, what has been presented, you just want to make noise, you can't go on the net and complain about it. But we can put in out there what we really want the public to know. That's what we have to use. People are afraid of social media, but it is for our good. People can use it for evil, but we can use it for our good. And I think that the health sector can maximize the strength of that. Fortunately for us, even for the traditional media that we are working with today, in fact, most of them, or maybe 95%, are online. Even the news we watch every evening on television is online. They stream it live on Facebook, breakfast show, and all of them. So even apart from maybe going to report, you can go back on the net and you see the real story and whatever information you want to give. So there's really no, we shouldn't be concerned about that at all. It is what we want people to know. That's what we should put out there, and not what people think they should be saying. People every day put pictures of themselves all over the place. That is their problem. Our problem is, our issue is, our concern is how do we use the technology to our advantage to push the agenda of making sure we have healthy societies. Thank you.
There was a second question from the gentleman here for you. Maybe he can remind.
Yes.
Okay.
Can you?
Yes. No, please bring the mic to the second presenter.
Oh, my question was, you had mentioned that patients are churning health centers to go to district hospitals because of, I assume, maybe staffing or equipment supplies at the spokes, and they are going to the district hospitals. So I just wanted to understand when it comes to staffing for the hubs and the spokes, because there should be a reason why someone would not go to a spoke, but they would decide to go to a district hospital. So I'm not from here, but I just want to understand how it goes. Because where I come from in Malawi, they say a patient can choose everywhere they want to go, right? But when they go to that facility, they are not chased, they will be assisted. And there's still more that challenge of long waiting hours that burdens the clinical team at this hospital. So I just want to understand that in terms of the hub and the spoke here. So staffing, equipment, supplies.
No, please, let her answer the question. That was a previous question. No, that question is for her, right?
That's not her question. That's the the challenge that you said. That's a challenge. The question is, people are free to choose wherever they want to go, but there are still levels. So we have a community level, we have a health center, we have a district hospital, we have a regional hospital, and they have staffing norms, the expertise that they are supposed to provide. So, for example, if the challenge that we are having is not choosing where they want to go. The challenge that we are having is that these health centers have not been resourced enough, one, in terms of equipment, the people there. And therefore, they bypass that, not because of the preference, because of what these services are supposed to render is not there. And that's why they bypass that sub-district and go to the district hospital. They have a lot of implication for quality. So that cases that are not supposed to, for want of better word, uncomplicated, simple malaria, where you can use RDT to test and give somebody just anti-malaria, antiviral. This person will bypass this health center and go to district hospital, where they have to manage severe cases. So you see that the quality is going to be affected because you are going to have a lot of people going which are not supposed to. And the reason is that these health centers that are supposed to do a gatekeeper system and maybe do a filter, that's the challenge. That's what the network of practice is. So even in sub-districts, you can have more than 1, 2, 3 health centers, but still we are looking for a hub, a particular one, where they can go. So it's not choosing. The issue that we are having right now is because the services that we are supposed to provide is not there in terms of all these challenges. So the network of practice is going to build this so the spokes are the community-based health planning services, CHIPS component, and the hubs are supposed to be the health centers. And so that's the basis for that. It's not truncating where people to go. They are going because the services they need are not there. Thank you.
Thank you. So you go for another round. I see Dr. Yim, and then I see 2 other hands here. So, okay, let's start from here.
Thank you very much. My name is Hammond Sakwa from the Ghana Health Service. So my question goes to Dr. Fred Adomako. So During your presentation, I saw one of the slide where you talk about before and after the interventions of the hub. And there were many variables that were assessed, example, the HIFRA, the accreditation. I saw increment in all the variables that were assessed, but unfortunately, you see entry into the DHIS2 system, there was a decline. Before was 70%, then it declines to 69%. I would like to know what causes the decline in this entry. Thank you.
Thank you. My name is Mutaru Guru, a student at RIPS. I'm making comments on two presentations. One is on the health insurance, intervention on the health insurance, and the second one is on the innovative resource mobilization for the Model Health Center. So on the health insurance, my issue is on the conceptual framework, where he indicated the fishbone analysis, where we have the processes. He listed some variables under the processes, which in my opinion should have come under the logistics, where we have outdated template, poor internet connectivity. Unless, of course, you could explain to us why we keep those variables under the process. I feel it should come under logistics. Then my second comment is on the innovative. Madam, this is now your question. You indicated methodology, and you said leadership is everything. I have an issue with that statement, leadership is everything under methodology. And in your methodology, you emphasize on community engagement as a way of mobilizing resources, and you listed various stages of engagement. You did not mention philanthropic organizations or individuals, yet when it comes to actualizing the methodologies, the first was a philanthropic organization coming from outside to do screening. The second was a philanthropic individual presenting medical equipment to the community. And then the third one was a chief building a block. These are all philanthropic organizations. So my observation is that in the methodology, it should have indicated some philanthropic organization. You also indicated approaching a mining company in the community, but in the methodology, you didn't mention that. In your conclusion, you indicated no maternal mortality, no under 5 mortality, but you didn't indicate the reference year. Because once we talk of mortality, you have to indicate the year, then we know within what period it happened. Thank you.
Thank you. We have a question here.
Thank you. Mine is a comment. And when it comes to, and I thank, Prof. Bauer is here. Yes, one of the things concerning our collaboration with the universities is that I remember for this conference, when we were meeting as a scientific group, as part of what we are doing, sometimes when we meet the academia, we explain to them that even though we are doing a lot of observations, they may not pass some of the scientific rigor. Because when we started, we were working, and everybody thought it was interesting. This thing we can collect data, we can do this, and we can do that. So sometimes we didn't start with all the scientific rigor. So in the middle, sometimes we meet the university. And so, of course, the allowances are then given, and we come and showcase it. So that once we showcase it and the scientists are here, they can look at what is happening and see where the gaps are, and then help us to tighten it. The second thing was yesterday's presentation, which emphasized on implementation research, which was an area where, again, we were trying to bridge that gap between us in practice. And so we are actually trying to really engage academia, but we are not going to the extreme of science. We are trying to, for them to also come closer, then we get closer, and that's the model we are trying to use. The second thing is with the media. Why we are now adding them to our proposal is that the social media, like was said, is filled with very a lot of news, but we want good news as well. So it's not like we are eliminating bad news, but we are saying that let's also add good news to the news on the social media, so that if somebody is having both access to bad and good news, our advocacy can also go well. So that was the main thing. Then with the network of practice, just for the sake of the question, we started 2 decades ago with the CHIPS policy, which was a wellness policy. A wellness policy means that we were supposed to go to the community and explain to them and help them to prevent disease. But when they get disease, the hospitals were there to deal with the disease. But the community were saying that we still needed the treatment of disease close to us. So then we decided that then let's strengthen that system so that with the health centers, they would deal with the disease phenomenon of the whole community concept, whilst the CHIPS continue with the health promotion and preventive services. So once they form a network, then it's a one-stop shop for anybody who falls into that sub-district system. There's a strength in curative care, and there's also strength in health promotion at the network level before we get to the district. So that is the main concept that we are pushing. Thank you very much.
Okay, so we go to the...
Yeah, thank you very much. To the PA student, UNFP working with, I think that was a very good observation. You know, when the team meets, sometimes discussions come where we should place what. Realize that I said that when it comes to software, the claim with software is the insurance will bring updates like download and install. So the challenge is that that software is there, but it's not updated. So it's not like, so that's why we saw it as a process. But it's well taken, you know, we look at it, especially when we want to polish our information. So I think it's well taken, and thanks for your comment. Yeah. To community scorecard, where's Dr. Binka? No. Yeah, I think as director, I really enjoy listening to you. You made it very lively, and I can assure you, you get that support. I mean, you're so lively. I mean, I enjoy listening to you, and we are going to carry on forward. We were discussing, realize that the community actually assesses these facilities. By discussing with my team, how do they check our attitude? There are some things that are qualitative that you may have to look at it, because sometimes you can get a high score, but there are some things that does not really surface in the scorecard. I don't have the answers for it, especially when it has to do with human behavior, because I can't exploit in terms of customer care. So I think we'll be talking. I think the quality expert is shaking his head, so they will provide the answers. Thank you very much.
So Harman, it's true. The first one, we had 70/70. And the second one, we had 69/70. I mean, so the statisticians are here, 100% and 99%. And the second one, the way that we approach it was even quite different when it comes to the entry of them. Apart from we accepting, we also there with you to look at how it's done and ask some questions. So the first one, more of we not being on site. So the second one was more rigorous. But notwithstanding, it went down. I think that was the only indicator that I wouldn't even say went down, but went slightly. Thank you.
Thank you very much. I think in one of your questions, you made mention of the methodology we used. We mentioned leadership. Yes, what we are saying is that people sometimes wait for government to bring in money, bring in resources, so that we'll be able to carry out the network of practice. But we have a leader who is committed. Yes, he moves with the team. When the NOP, network of practice, came, he said, before government comes in to help us, let's go into various philanthropists. Let's go into opinion leaders in the community, the political leaders and the traditional leaders. Let's go and sell out this idea to them and see how they can help us. So if you are bringing leadership under methodology, I think it's in a good cause. Then also, he also mentioned the year that we scored the zero institutional maternal mortality with regards to 2024? I think these are the two questions I got. Thank you.
Okay, we have enough time to go for another round. So let's start from Dr. Chiravira, and then here, and then go all the way to the back.
Yes, it's just a remark. It's not a question. I wanted to say that those of us in academia, we should also begin to think about how useful our supposed scientific knowledge is to the practitioner. So instead of calling for the practitioners to reach out to us, we should begin thinking about how useful we can make our work to the practitioner so that they can use it. Those technical writings that we are referring to, that, oh, if we do it this way, you bring in the researcher, you can publish it, for what? We are thinking of the type of evidence that can help people solve problems. Very simple evidence. And we are thinking about very technical things that will let you publish papers. So I just thought that I need to say that we have to ensure that if we must stay relevant, our work should be focused on how we can collaborate or partner with the service to serve the people, not our academic achievements. Thank you.
All right. Thank you so much. Yeah. My question goes to my boss, the Ashanti Regional Director of Health Services. I realized that when you were comparing before innovation, the intervention, you had only at least 2 midwives in only 22 facilities. But at the end of the day, all the 70 facilities now had at least 2 midwives. I just want you to share your experience, how you did it, so that maybe we too, we can cut and paste in Upper East. Thank you so much.
Yes, thank you very much. My name is Abbas Suleimana from the National Health Insurance Authority. First of all, I bring you warm greetings from the CEO of the NHIA, and then also from the Deputy Chief Executive in charge of operations at the NHIA, Dr. Senanu Kwesi Jokoto, who happens to be one of you, those of us from Ghana Health Service, some few months ago. It's indeed a pleasure for us from the National Health Insurance Authority to be part of this conference. And then I would like to commend the presenters so far on the wonderful presentation that they have delivered. A couple of issues came that has to do with the NHIA that I would like to speak on. First of all, there was an issue on training on claims, which I think is commendable, but I'll say that as far as the NHI is concerned, our doors are open at the district level, at the regional level, and at the claims processing center levels, that if you require any training, our doors are open. You can reach out to our offices, and we'll be more than willing to support the respective health facilities to be able to build their capacity so as to be able to handle claims effectively. And then secondly, there was an issue on Claim 8, the e-claims application. I must say that the Claim 8 has been strategically developed to be able to work at both an online and offline system. And so we this actually was developed by in-house staff of the NHIA, and we consciously did that so that CHIPS compounds, health centers, polyclinics that may have challenges with internet connectivity will be able to submit or will be able to generate claims at the health facility level, and will be able to submit it via an offline facility. And so, again, district hospitals, secondary health facilities, and tertiary facilities that are in the urban areas and cities will be able to also submit via the online facility where they can have access to internet connectivity. To conclude on that, I'll say that if there are still some facilities, especially in the hard-to-reach areas and the hinterlands, who are still having challenges with the claims rate, once again, our doors are open. We'll be able to engage them. I'm here. If you want to reach out to me, I will listen to you, and then we'll be able to support them with whatever system challenge that they have, so that they will be able to generate and submit their claims with ease. Thank you very much.
Thank you. This will be our last round of questions. So are there any other hands? Okay, I see one here.
Yeah, thank you so much for the opportunity. I think this presentation has been very eye-opening. We've seen a lot of things that are so good. My concern has to do with this. We are talking about bringing out quality paper to guide practice. That is why we have academia and practice in one room, so that we see how to iron out. But we have the big people from Ghana Health Service here. I know we have policy on research, but how are you going to entrench that? If you are looking for one of the best ethical committee, it's one of the Ghana Health Service one. If you are working somewhere, you have to forward this thing to them. But people will work in the practice, they will stress to do the work, but even where to even publish it become a problem. So you stress to do the partnership, you have a quality paper, you want to push, and then all you can hope for is research democracy. Go and fill some form so that some journal will have mercy on you to waive it off for you. If they say that pay 40%, and that 40% is translating into $2,000, you look at your monthly salary. If you even annual salary cannot even pay for the $2,000. So I think Ghana Health Service, if even you can have your journal, I don't know, or you have that repository where all the information are deposited, so that if you are looking for it, we go there, we can have access to it. Or else we'll be talking, and then we'll go energized to go and do the work. You do, and at the end of the day, you will not see where to say it will be gathering dust. Thank you.
Thank you very much. I know that all of them were comments, except one question for... Okay. It looks like some hands have emerged. So,
to the gentleman from insurance, and I was with Upper East. For most of our regional directors and district directors, we work with you when it comes to even facilitation. So, for example, for network of practice, let's use Upper East where I came from. We deliberately invite the leads of the district to be there with the ambulance. So this one we are talking about, just it's 15 minutes, so we can't say everything. So you were even the lead to help us to negotiate these things. So our doors are open. Sometimes feel free to come and correct us, because when it comes to rejection, if we work with you, we get things better. All that sometimes we may not have money for a formal meeting. So feel free to also do pro bono things for us. Then we too can do pro bono things for you. Thank you very much.
Okay. So let's take one more from Dr. Yim, and then we come.
How come we have 2 midwives in all the networks? So when we went around, we realized that there was a lot of maldistribution of midwives, even within the districts where these network of practice are. And so it's mandatory, some of the low-hanging fruits for you as a district director to make sure you have, especially when it comes to redistribution. So that's what we use. Then the second one, I agree with Prof in terms of research. Look, in Ghana Health Service, the district director, the regional director, medical director, there is nowhere that the person is written that do 2 or 3 publications for your promotion. It's not there. And so, but I believe that if you don't publish, you perish in academia and our partnership. So for you will, it's part of your mandate to do. But when it comes to the service delivery, the question that I will want to put to the academia, and I believe that that's where the challenge, a lot of the implementation of the evidence that you have generated are not, let's say, I'm not saying we are not doing it wholly. How can you support us when we deliver the service in the way that what we have done in implementing the evidence are captured and also shared. And that becomes an incentive for us, so that if we don't really go through the method and all those justified sample size, random selection, and all those, there should also be an avenue where, as a district director, he's gone to the field to make sure there's implementation. It's work. It has to be captured and shared. And making sure that all these policies are there so that it can energize us. And I believe in the long run, when we begin to support us, when we deliver service in such a way, we are going to deliver the search in such a way that it will be standardized. And so that even your data collection will be easy. Because the methods that all of us are going to be used now, because you are supporting us to polish, will be better. So let's capture. And we're also on platform. He's a fellowship. He's a fellow. I'm a fellow. I'm a consultant public health office. In the same platform that we are, they will put a publication there. Academia especially will put a, I'm not against. I mean, I'm talking about the reality. Everybody will praise. Good work, great work. But if he go to the field and put it, nobody will acknowledge that. Thank you.
Okay, so Professor Bauer has graciously agreed to respond to that on behalf of academia.
So I think it's fair, some of the comments that you have made, and it is the reason why we have tried to promote this collaboration and to work with the service. And we've been doing this for a very, very long time. You all know Dr. Awono Williams. If you Google Dr. Awono Williams, although he was one of you, he has over 40 publications. And it's not because he was writing all of them by himself, but it is because of the way he collaborated with academia. He worked with us, he has good ideas, we partner, we work together, and we publish. And I think that is where we have to meet as both researchers and practitioners. And now there's what we call implementation science, and that is what we now try to promote around the world, because it's not just about science, it's about implementation. So how do you promote the science of implementation? And that's where this collaboration has become much more important globally. And if you go to a lot of the international health research forums, they've continued to promote this. But also, you also have situations where you don't need to go through the rigor of the methodological rigor that is required. And you probably know it better than me that as a medical doctor, you have what you call case reports. So if you have a case, you can go and publish it in case reports, and so that others can benefit from that. So yes, we want to encourage this, work with the scientists, and we'll work together. What we want to do is to foster the use of evidence to promote practice and decision making. And I think that there's no better forum than for us to work together. Those of us whose craft is to do the rigorous science, but working with you, sometimes you have some technical ideas that we don't have, and then we can meet together and work together to promote this so that the bigger community can benefit. So please, our doors are open. Fortunately, now you have a lot of schools of public health, almost in every region. So collaborate with them, and that is what we try to do in this program. When we started this program, what we did was to get the UDS, for instance, to work with the medical school, to work with the regional health directorate, so that they can partner to see how they can work together to promote evidence-based service delivery. In the same vein, because those were the two regions, we also got the University for Health and Allied Sciences to collaborate with the regional health directorate and other health practitioners in the region. And I think that is the model that we want to promote. Let's work together with our scientists to make sure that whatever best practices are there are properly documented. One of the things that we don't do in this country is writing. You would have the ideas, but as a doctor, most of the time you say you want to focus on your patient care. But there are things that you can work with us to get them published. I remember when I served on the board of the Tamale Teaching Hospital a few years ago, one of the difficulties that we had as a board with the doctors is, even for them, when we started to try to introduce the HAMS, the Hospital Administrative Management System, there was a lot of resistance, because for the doctors, they say, oh, it's a waste of time. We can't type fast, and we want to write prescriptions, and you are asking us to go onto a platform. But eventually what we did was to say, look, for you to become relevant internationally, if any of you doctors move from this country and go abroad, what you are going to be confronted is the same thing that we are trying to promote. So get onto it, and who knows, you would suddenly find yourself going to study, and you are in a health facility where you can't write. You have to enter everything on a platform. And that's how we got them gradually to get into it. And I think that we should begin to work together to promote this. Thank you.
Thank you. Okay, last hand, and then after that, the MC, Mr. Dr. Santua, will also give a comment, and then we will bring this to a close.
Thank you very much for the opportunity. My very humble addition, and I hope Dr. Amu will permit me, because I had quite a conversation with him yesterday, and I found out that there's a student whose thesis is on the implementation of network of practice. This student is a district director. The supervisor is a district director. That's first supervisor. Second supervisor is an academic. And this is to improve the service. In the recent annual review in the region, several poster presentations were made, all falling on data that students had picked from the service, had researched on, and were feeding us back. So I think it's a collaboration to foster knowledge and improve knowledge. And what is the service if we cannot reassess ourselves? And how do we reassess? It's by research. So I think that's just a small addition I want to add. Thank you very much.
So go ahead with your comment.
Okay. Thank you very much, Mr. Chairman. How easy it is to forget that even an MC is a participant. My comment goes to Professor Fred Adumako Boateng's presentation. Don't worry, you are getting there. And all those who are working on network of practice. I could not agree with you more that when you find yourself in a pond infested with crocodiles, your topmost priority is to swim to safety and not to try to find out who pushed you. It is after you are safe, then you can now ask, who pushed me? So CHIPS happened when the priority was geographical access. After we achieved that, they will say, the services are there, but now the people cannot afford. Then we are talking of National Health Insurance Scheme to support it. Then we kept improving the science, advancing the evidence. Now we are at network of practice. I'm urging you to move beyond a network of practice to a web of practice. A web of practice would recognize the intricate, complex, and even convoluted interactions and interconnections that come to play in the provision of quality health care, because it takes into consideration the economic, the political, the social, the spiritual aspects of healthcare. Thank you very much.
Okay, thank you, audience, for your engagement, and then also thank you to our presenters for their wonderful presentations. So, I mean, the idea of putting together a session for, in particular, the service to share innovative practices and ideas happening was to, for all of us to learn about it. And then also an acknowledgement that there are some interesting things that are being done, some innovative things that are being done, which do not straightly meet the kind of academic rigor that was applied to some of the other sessions. And I think that the discussions that have followed show that the objectives has been met. We've been very informed about different aspects of what has been going on, innovative things going on with the network of practice. And then we've heard some wonderful presentation about how, as health practitioners and academics, we can work with and not use the media for the greater and common good of all of us. So I would like us to give a warm hand of applause again to all the presenters. And then also to all of you, our wonderful, engaging, and then also very supportive audience for your time. And thank you very much for making this session a success. So this is where we bring an end to it. I'll invite the MC to come and tell us what we do next. Thank you very much.
Yeah, so thank you very much. We have saved time and the organizers are excited about that. If we keep going at it that way, we can close early enough, and those who want to catch the next available VIP or Passion Air can do so. This is an announcement that goes to travel award recipients. Kindly see the accountant during lunchtime at the registration desk for important information. Now we will want to step out for the gallery walk, the poster gallery walk, and then grab our snack, and please reconvene for the breakout sessions, and let's keep saving time so that we can benefit from it. Thank you very much for your attention. Enjoy your poster walk and snack.
Estas reuniões culminam com a elaboração, portanto, de um plano de ação que é fundamentalmente um instrumento que guia a ação, portanto, ao nível das unidades. Este programa contribui para o reforço do sistema de saúde através do treino de profissionais e de financiamento, portanto, de pesquisa, de implementação, que contribui, em última instância, à redução da mortalidade, quer, portanto, infantil, quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people who come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals would solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people. 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only about 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system. We are focusing on community-based primary healthcare system as the basic primary healthcare vehicle to drive systems at the community level. That is what our health system needs.
Community health officer because I have the zeal to work, to help my community, to help Mother Ghana. I render child welfare clinics. I do immunization. I do family planning. Then I also treat minor ailments. I have the passion for the job. I'm doing it with my heart. It's humanity. You are helping somebody. One day someone will also help you.
You look at the problem and try to find solutions through innovative ways. And one of the things that we did was to introduce a motorcade ambulance service to serve women in terms of referral from one community to the other. Women were dying, babies were dying. Most of the deaths were recording in the communities. We addressed that problem by providing what we call the motorcade ambulances. This is a local initiative.
With the introduction of the motorcade to this place, the community has really done well.
If you do something successful, there's always a need to carry on. We have a major public health system working.
The parallel sessions.
Volunteers working, the nurses have adequate equipment, they have their clinics, they're working. Any country that looks at our health system or look at our program should be able to apply it.
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system.
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first phase of the African Health Initiative, we put out an open call for partnership proposals from 11 countries. And after quite a long review process, we narrowed down and awarded grants to pilot projects in 5 countries. Those countries were Ghana, Tanzania, Rwanda, Mozambique, and Zambia.
For the program to work, it needed support and agreement from all the levels, national, provincial, down to the people who have day-to-day oversight of the delivery of services.
We view data as one of the ways that a health system can be best informed.
You have to be able to see what you've done. You need a health information system. You have to be able to have the ability to examine those data and to course correct. That requires leadership and the ability for local actors to make decisions.
Not all of the projects were successful. From that, we decided to have a second phase of the African Health Initiative and to make some changes. We required that an individual from the national government commit time to leading the program. The second important shift was a recognition that we wanted researchers, practitioners, and program managers to come together regularly to talk about data and research and evidence use and to talk about what the data was telling them in their communities. It's our intention to build that culture of review and thoughtfulness when making decisions around service delivery.
This is not a high-cost investment, but it's not one that can be achieved without resources. We need funders to start thinking about coming together and enabling projects to be implemented not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people that we've supported, not only in the lives saved, but in the researchers, the policymakers, and the practitioners who've embodied this approach. My greatest hope is that the countries where we're investing are able to continue this effort in strengthening their health systems after the Doris Duke Foundation funding comes to an end.
How do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, there's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is to support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
we believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. Researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
Global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in arms who recognize the unique contributions they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
A pesquisa de implementação é tida como uma das prioridades do Ministério da Saúde, dado que é a melhor forma de identificar, portanto, as fragilidades de resposta do sistema de saúde, portanto, nos diferentes níveis do sistema.
The IDEAS project covers 12 districts, about 150 health facilities, and covers a population of about 3 million people. It's creating a mechanism so that there's a better understanding of what we are doing and how to do it better, and using data to drive that process.
O projeto tem fundamentalmente três componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de melhoria de qualidade de dados e uso nos processos de tomada de decisão.
A informação é colhida ao nível da unidade sanitária pela enfermeira e passa depois para o resumo.
Por exemplo, se ela consegue notar que das 100 mulheres que vieram fazer consulta pré-natal, só consegui fazer testagem em 80, porque os testes acabaram. Acabaram porque eu, enfermeira, não pedi, acabaram porque o sistema não tem.
E eles têm essa capacidade de fazer essa análise ao nível local da unidade sanitária e constroem os seus gráficos para poderem tomar decisão ao nível local. Depois o resumo é enviado ao serviço distrital e do serviço distrital essa informação entra numa base de dados que a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Tudo isto depois leva à realização desta reunião.
Every 6 months, the meetings bring together district and facility level managers to review performance and follow on supervision and financial support.
É um momento não só de apresentação de resultados, mas ao mesmo tempo é um momento de partilha de experiências, portanto, entre as diferentes unidades sanitárias. Estas reuniões culminam com a elaboração, portanto, de um plano de ação que é fundamentalmente um instrumento que guia a ação, portanto, ao nível das unidades. Este programa contribui para o reforço do sistema de saúde através do treino de profissionais e de financiamento, portanto, de pesquisa, de implementação, que contribui, em última instância, portanto, para a redução da mortalidade, quer, portanto, infantil, quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people who come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals would solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people. 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system. We are focusing on community-based primary healthcare system as the basic primary healthcare vehicle to drive systems at the community level. That is what our health system needs.
I'm a community health officer because I have the zeal to work, to help my community, to help Mother Ghana. I render child welfare clinics. I do immunization. I do family planning. Then I also treat minor ailments. I have the passion for the job. I'm doing it with my heart. It's humanity. You are helping somebody. One day someone will also help you.
You look at the problem and try to find solutions through innovative ways. And one of the things that we did was to introduce a motorcade ambulance service to serve women in terms of referral from one community to the other. Women were dying, babies were dying. Most of the deaths were recording in the communities. We addressed that problem by providing what we call the motorcade ambulances. This is a local initiative.
With the introduction of the motorcade to this place, the community has really done well.
If you do something successful, there's always a need to carry on. We have a major public health system working. We have volunteers working. The nurses have adequate equipment. They have their clinics. They're working. Any country that looks at our health system or look at our program should be able to apply it.
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system.
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first phase of the African Health Initiative, we put out an open call for partnership proposals from 11 countries. And after quite a long review process, we narrowed down and awarded grants to pilot projects in 5 countries. Those countries were Ghana, Tanzania, Rwanda, Mozambique, and Zambia.
For the program to work, it needed support and agreement from all the levels, national, provincial, down to the people who have day-to-day oversight of the delivery of services.
We view data as one of the ways that a health system can be best informed.
You have to be able to see what you've done. You need a health information system. You have to be able to have the ability to examine those data and to course correct. That requires leadership and the ability for local actors to make decisions.
Not all of the projects were successful. From that, we decided to have a second phase of the African Health Initiative and to make some changes. We required that an individual from the national government commit time to leading the program. The second important shift was a recognition that we wanted researchers, practitioners, and program managers to come together regularly to talk about data and research and evidence use, and to talk about what the data was telling them in their communities. It's our intention to build that culture of review and thoughtfulness when making decisions around service delivery.
This is not a high-cost investment, but it's not one that can be achieved without resources. We need funders to start thinking about coming together and enabling projects to be implemented not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people that we've supported, not only in the lives saved, but in the researchers, the policymakers, and the practitioners who've embodied this approach. My greatest hope is that the countries where we're investing are able to continue this effort in strengthening their health systems after the Doris Duke Foundation funding comes to an end.
How do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, there's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
we believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. The researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
Global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in arms who recognize the unique contributions that they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
A pesquisa de implementação é tida como uma das prioridades do Ministério da Saúde, dado que é a melhor forma de identificar, portanto, as fragilidades de resposta do sistema de saúde, tanto nos diferentes níveis do sistema.
The IDEAS project covers 12 districts, about 150 health facilities, and covers a population of about 3 million people. It's creating a mechanism so that there's a better understanding of what we are doing and how to do it better, and using data to drive that process.
O projeto tem fundamentalmente três componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de melhoria de qualidade de dados e uso nos processos de tomada de decisão.
A informação é colhida ao nível da unidade sanitária pela enfermeira e passa depois para o resumo.
Por exemplo, se ela consegue notar que das 100 mulheres que vieram fazer consulta pré-natal, só consegui fazer testagem em 80, porque os testes acabaram. Acabaram porque eu, enfermeira, não pedi, acabaram porque o sistema não tem.
E eles têm essa capacidade de fazer essa análise ao nível local da unidade sanitária e constroem os seus gráficos para poderem tomar decisão ao nível local. Depois o resumo é enviado ao serviço distrital e do serviço distrital essa informação entra numa base de dados que a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Tudo isto depois leva à realização desta reunião.
Every 6 months, the meetings bring together district and facility level managers to review performance and follow-on supervision and financial support.
É um momento não só de apresentação de resultados, mas ao mesmo tempo é um momento de partilha de experiências, portanto, entre as diferentes unidades sanitárias. Estas reuniões culminam com a elaboração, portanto, de um plano de ação que é fundamentalmente um instrumento que guia a ação, portanto, ao nível das unidades. Este programa contribui para o reforço do sistema de saúde através do treino de profissionais e de financiamento, portanto, de pesquisa, de implementação, que contribui, em última instância, portanto, para a redução da mortalidade, quer, portanto, infantil, quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people who come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals would solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people. 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only about 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system. We are focusing on community-based primary healthcare system as the basic primary healthcare vehicle to drive systems at the community level. That is what our health system needs.
I'm a community health officer because I have the zeal to work, to help my community, to help Mother Ghana. I render child welfare clinics. I do immunization. I do family planning. Then I also treat manual ailments. I have the passion for the job. I'm doing it with my heart. It's humanity. You are helping somebody. One day someone will also help you.
You look at the problem and try to find solutions through innovative ways. And one of the things that we did was to introduce a motor kidney ambulance service to serve women in terms of referral from one community to the other. Women were dying, babies were dying. Most of the deaths were recorded in the communities. We addressed that problem by providing what we call the motor kidney ambulances. This is a local initiative.
With the introduction of the motor kidney to this place, the community has really done well.
If you do something successful, there's always a need to carry on. We have a major public health system working, we have volunteers working, the nurses have adequate equipment, they have their clinics, they're working. Any country that looks at our health system or look at our program should be able to apply it.
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system.
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first phase of the African Health Initiative, we put out an open call for partnership proposals from 11 countries. And after quite a long review process, we narrowed down and awarded grants to pilot projects in 5 countries. Those countries were Ghana, Tanzania, Rwanda, Mozambique, and Zambia.
For the program to work, it needed support and agreement from all the levels, national, provincial, down to the people who have day-to-day oversight of the delivery of services.
We view data as one of the ways that a health system can be best informed.
You have to be able to see what you've done. You need a health information system. You have to be able to have the ability to examine those data and to course correct. That requires leadership and the ability for local actors to make decisions.
Not all of the projects were successful. From that, we decided to have a second phase of the African Health Initiative and to make some changes. We required that an individual from the national government commit time to leading the program. The second important shift was a recognition that we wanted researchers, practitioners, and program managers to come together regularly to talk about data and research and evidence use, and to talk about what the data was telling them in their communities. It's our intention to build that culture of review and thoughtfulness when making decisions around service delivery.
This is not a high-cost investment, but it's not one that can be achieved without resources. We need funders to start thinking about coming together and enabling projects to be implemented not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people that we've supported, not only in the lives saved, but in the researchers, the policymakers, and the practitioners who've embodied this approach. My greatest hope is that the countries where we're investing are able to continue this effort in strengthening their health systems after the Doris Duke Foundation funding comes to an end.
How do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, there's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is to support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
we believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. The researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
Global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in arms who recognize the unique contributions they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
A pesquisa de implementação é tida como uma das prioridades do Ministério da Saúde, dado que é a melhor forma de identificar, portanto, as fragilidades de resposta do sistema de saúde, portanto, nos diferentes níveis do sistema.
The IDEAS project covers 12 districts, about 150 health facilities, and covers a population of about 3 million people. It's creating a mechanism so that there's a better understanding of what we are doing and how to do it better and using data to drive that process.
O projeto tem fundamentalmente três componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de melhoria de qualidade de dados e uso nos processos de tomada de decisão.
A informação é colhida ao nível da unidade sanitária pela enfermeira e passa depois para o resumo.
Por exemplo, se ela consegue notar que das 100 mulheres que vieram fazer consulta pré-natal, só consegui fazer testagem em 80, porque os testes acabaram. Acabaram porque eu, enfermeira, não pedi, acabaram porque o sistema não tem.
E eles têm essa capacidade de fazer essa análise ao nível local da unidade sanitária e constroem os seus gráficos para poderem tomar decisão ao nível local. Depois o resumo é enviado ao serviço distrital e do serviço distrital essa informação entra numa base de dados que a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Tudo isto depois leva à realização desta reunião.
Every 6 months, the meetings bring together district and facility level managers to review performance and follow on supervision and financial support.
É um momento não só de apresentação de resultados, mas ao mesmo tempo é um momento de partilha de experiências, portanto, entre as diferentes unidades sanitárias. Estas reuniões culminam com a elaboração, portanto, de um plano de ação que é fundamentalmente um instrumento que guia a ação, portanto, ao nível das unidades. Este programa contribui para o reforço do sistema de saúde através do treino de profissionais e de financiamento, portanto, de pesquisa, de implementação, que contribui, em última instância, portanto, para a redução da mortalidade, quer, portanto, infantil, quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people who come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals would solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people. 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only about 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system. We are focusing on community-based primary healthcare system as the basic primary healthcare vehicle to drive systems at the community level. That is what our health system needs.
I'm a community health officer because I have the zeal to work, to help my community, to help Mother Ghana. I render child welfare clinics. I do immunization. I do family planning. Then I also treat minor ailments. I have the passion for the job. I'm doing it with my heart. It's humanity. You are helping somebody. One day somebody will also help you.
You look at the problem, we try to find solutions through innovative ways. And one of the things that we did was to introduce a motor kidney ambulance service to serve women in terms of referral from one community to the other. Women were dying, babies were dying. Most of the deaths were recorded in the communities. We addressed that problem by providing what we call the motor kidney ambulances. This is a local initiative.
With the introduction of the motor kidney to this place, the community has really done well.
If you do something successful, there's always a need to carry on. We have a emergency public health system working, we have volunteers working, the nurses have adequate equipment, they have their clinics, they're working. Any country that looks at our health system or look at our program should be able to apply it.
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system.
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first phase of the African Health Initiative, we put out an open call for partnership proposals from 11 countries. And after quite a long review process, we narrowed down and awarded grants to pilot projects in 5 countries. Those countries were Ghana, Tanzania, Rwanda, Mozambique, and Zambia.
For the program to work, it needed support and agreement from all the levels, national, provincial, down to the people who have day-to-day oversight of the delivery of services.
We view data as one of the ways that a health system can be best informed.
You have to be able to see what you've done. You need a health information system. You have to be able to have the ability to examine those data and to course correct. That requires leadership and the ability for local actors to make decisions.
Not all of the projects were successful. From that, we decided to have a second phase of the African Health Initiative and to make some changes. We required that an individual from the national government commit time to leading the program. The second important shift was a recognition that we wanted researchers, practitioners, and program managers to come together regularly to talk about data and research and evidence use, and to talk about what the data was telling them in their communities. It's our intention to build that culture of review and thoughtfulness when making decisions around service delivery.
This is not a high-cost investment, but it's not one that can be achieved without resources. We need funders to start thinking about coming together and enabling projects to be implemented not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people.
Good morning
that we've supported.
once again.
Not only in the lives saved, but in the researchers,
I hope
the
everyone has
policymakers
had
and
something
practitioners
to
who've embodied this
drink,
approach.
whether it's
My greatest hope
cold
is that
or
the countries
hot.
where we're investing are able to continue this
We
effort in strengthening their
are
health
moving
systems.
into the breakout sessions, and in this auditorium, the moderator would be Professor Patrick Assuming, and so those who will be presenting are here. In the seminar room 2, up here on my right, we have Dr. Samuel Amon, who would be moderating that session. And then the RIPS seminar room over there, Fidelia Dake would be the moderator. I want to believe that the moderators are always here, or they are already here, and then they would probably take position and wait for their presenters. Let's try to make time, as we have been doing since yesterday. If we save time, it will be to our advantage. And then because we have presenters who would be presenting online, we also need to be on time. Thank you, please. So I expect that all of you will break out into your various groups, and then we can have the parallel sessions and then reconvene. Well, we may not have to reconvene. We can go up to 1 o'clock, that's lunch. And then we start another round of breakout sessions. So we will reconvene at 1 o'clock. And then at 2 o'clock, we have the next round of breakout sessions. And then we can be wrapping up. So if we are done by 3 or before 3, that will be fine for everyone. Then we can try to beat the Accra traffic, rain or shine. Thank you very much. If you have any questions, please address them to me. I want to believe that those who are here are those who have chosen to stay here for the presentations that are going on here. Let me repeat this announcement, that travel award recipients should kindly see the accountant at lunchtime at the registration desk for an important piece of information. So I'm out of here. Enjoy your time.
Good afternoon, ladies. Good afternoon, ladies and gentlemen, and thanks for coming. May I plead with you to come forward a little bit so that we can kind of concentrate in one area for the purpose of the cameras. Thank you so much for agreeing to do this. Okay, so thanks for coming for this session. This session is about, the theme of this session is universal health coverage, and we are going to have 4 presentations. So there are 2 presenters who are here in person with us, and we have 2 presenters who are online. And we do also have audience online. So each presenter will have 15 minutes. And then, so I'll urge presenters to stay within time. So time is fast, so I don't want to take much time. I will introduce our first, I welcome our first presenter, who is Dr. or Professor Herbert Amu from University of Health and Allied Sciences.
Thank you very much. So my name is Hubert Amu, and I'm presenting on the aspect of the UHAS CHIPS Plus implementation. And I'm looking at the fact that capacity building improves the implementation of CHIPS as the project had it. This is the full list of our authors. I coordinated the project on behalf of my dean at the time, Professor Margaret Kweku. By way of outline, this is what I'm looking at, right from the introduction to our proposed recommendations. Now, by way of introduction, primary healthcare is hinged on the Amata Declaration, which was one of the first steps towards defining that concept. And then when we failed to achieve the Millennium Development Goals, we had the Sustainable Development Goals coming in 2016 to further solidify the relevance of primary healthcare in ensuring that we achieve universal health coverage. Now, to achieve this universal health coverage and strengthen primary health care, we introduced the CHIPS concept sometime in 2000, and I think we've had a lot of discussion on CHIPS already, so I don't need to give a lot of the background, but that was what happened. But then it's faced a lot of challenges from its inception. There were lots of challenges. For instance, there was a lot of focus on the provision of clinical services and the infrastructural provision to the detriment of some of the core things that CHIPS stands for, which includes improving the capacity of those who are supposed to provide the services. You are providing the facilities, and then the people who are supposed to provide the services, you are not investing in them. And so CHIPS was to be scaled up. It started with the GHIP project, which was implemented in 2010 through to 2015, and then it was scaled up across the country. And so I'm happy Dr. Chirawura is here. While I coordinated this at the University of Health and Allied Sciences, he did so at the University for Development Study, which were the implementing university partners of the project. So this is the CHIPS Plus. These were the main partners: Ghana Health Service, Columbia University, with the university partners, UDS and UHAS. Even though Legon was a university partner, they were doing the overall evaluation of the project. And of course, Doris Duke Foundation provided funding for the project. But as a university partner, what was our role? We were to train health workers, the frontline health workers in the Volta region. So it was in the Volta and then the northern region. So UDS was looking at the northern part, and we were looking at the southern part. And so our job was to train and build the capacity of those who are at the front line of implementing CHIPS, the CHOs. And our mandate was in the Nkwanta South and Central Town districts. Nkwanta is now in the Oti region, but at the time, it was in the Volta region because the project was in the Volta and the northern regions. What did we do? When we started, our implementation actually started in 2017. And so what we did was to develop a curriculum as a university. That's one of our core jobs, to develop curricula and train based on that curricula. And so we did that. So we had a CHIPS Plus curriculum, which was about 12 courses, which we put into 5 modules. And then having done this, we did it together with Ghana Health Service staff who provided expertise into the content that we did. And so having done this, we went ahead and trained the workers with regional level and national level Ghana Health Service trainers. So we did not conduct the training ourselves. We used Ghana Health Service staff to do the training. And so the objective of the current study was to go back 3 months post-training to find out if some action points which were developed as the fallout of the training had been implemented. And so that was the main objective we used in the field. So this was the curriculum that we developed. And these are the, I just screenshot the table of content. So we had topics on community entry and organization. We trained them on cultural competency in healthcare delivery. We also looked at communication skills and a number of them. These are pictures of some of our training sessions. That's Professor Margaret Kweku, Dr. Menu, Phyllis, our project officer, and I'm the one in the corner there. This was taken somewhere in 2017, so it's been a long time. And then this is a session of the training. We did this in Kwanta South, Kilimanjaro Hotel. And then this part of our data collection process. You see a field officer, Samuel, conducting an in-depth interview with a CHO. And this is one of the things we observed. So when I get to the methods, I will show the methods that we used, and you will see that observation of the things that were done that were part of the things that we did. So our evaluation, our study is a bigger one. So this presentation is just capturing a concept out of that, and it's qualitative in approach. And then, as I mentioned earlier, we evaluated the action points. When I present some of the tables, I'll go back and tell you what those action points are and the results we got from them, which were the main reason we went to the field. And this, as I mentioned, was done 3 months post-training, enough time for them to have effected the things that we recommended. We all agreed that when they go back, they should go and do. And these were the dates that we did the data collection in the 2 districts. And of course, they were the people that we trained. We trained one CHO, a community officer, is Ghana Health Service staff who has been recruited and placed in a CHIPS zone to deliver services. So they were the ones. So after they had taken the training, they were followed up to see if they were doing the things that we all agreed for them to do. As I mentioned, we collected data using in-depth interviews and then focus observation checklists. We used thematic analysis to analyze our data, and then the project itself got clearance from the Ghana Health Service. And then this particular study, we took clearance from the UHAS REC. Of course, permission from the various places where we took the data. Social demographics of the participants. In Kwanta, where we had about 16 that came for the training. So the facilities decided who should come. And they were usually either the CHO or just the in charge. They decided. And so that when they go back, they will go and then make sure they train their colleagues as well. So these were people who were mainly in their early 30s, males dominated, and then they were mainly certificate holders. They were all Christians. Of course, voter region, they were AWES. They were single. And then they had worked at the various centers or zones between 1 and 2 years. Qualitative analysis, so as we use thematic analysis, we had 3 main themes that emerged from our study. So the first one, which was the main grasp of our study, is to see if there was some improvement post-training. And so I wouldn't bother you with the rest. When we go to some of the others, then I throw a bit of light on that. So on the first theme, which is improved CHIPS implementation, these were the action points, some of the action points that I was alluding to earlier. And so you'll see that deployment, when you are deployed, it means that when we send you to the CHIPS zone, we don't expect you to just go and sit down and start working. We need to make sure we send it to the chiefs, send it to everybody who matter, so that they know you and they are ready to work with you. Before the training, we realized that out of the 34 from both districts, only 9 had been deployed. But after the training, that number increased to 15. Of course, the percentages are in the brackets for you to see, but I try to be very basic so everybody understands what I'm presenting. You will see that the others improved. The major ones are the ones in green. Community Health Action Plan, very important in CHIPS implementation. I mean, what are the directions you are doing? What is guiding whatever you are doing? We call it CHAP. And then before the training, 2016 of them had the CHAP done, some not even fully developed. But then after the training, this increased to 22. I'm in a hurry to get back to home visiting bags, which didn't see any improvements post-training. And this probably could be because it came with financials and the training did not provide any money for anybody to go and buy bags. But of course, because they were trained, the things that affected the training were the ones they could easily do themselves. So these are some of the quotations from them and the themes that emerged. So clearly, the training was able to improve organization and clarity in the deployment of the CHOs. It also improved the orientation that is organized for them. And these are quotes that are buttressing this. Of course, some of the practical tools, as I've shown, saw improvements. They were eager to make sure that they now have them. A lot of them did not even know how to create the things. So we had to make sure that we put in the mechanisms to make sure it was done. Transportation improved and accessibility challenges. Transportation was, however, a major challenge to the implementation of the CHIPS. And then they made some recommendations on how we can improve CHIPS. They said that we should continue building the capacity of the staff, and that is what we are carrying forward. We conclude this study by arguing that when you build the capacity of frontline health workers, it helps them to improve their implementation of CHIPS. And so we import that into the final recommendations that we are making, that there should be continuous capacity building despite the challenges of finance that we have. Whatever means possible, let's try to continue building the capacity of frontline health workers, because even as we try to implement the network of practice, we all agree that it is hinged on an effective CHIPS, which will make sure that the network is able to work effectively. And then, of course, when you look at the results in detail, when there was increased monitoring, it also induced the officers to implement the program more effectively. And so the DHGs, even the region, should do more of the monitoring visits so that it will force them to do their work effectively. Thank you very much.
Thank you very much, Dr. Amu, for your presentation and also for sticking to the time. Our next presenter is going to join us from online. She's in the person of Agoligan Nihad. I hope I have not massacred the name. And she's going to present to us on the gender intentionality in the design implementation of health financing reforms. So, Nihad?
Hi, can you hear me?
Yes, we can hear you. If you can hear us, we are ready for you to start your presentation.
Okay. I think it's okay now. Okay, let me share my screen. J'ai déjà. Non, il y a. J'ai coupé déjà. Can you see my screen?
Yes, we can.
Okay, thank you. So thank you everyone. My name is Nihad Agoli Gontometi, economist.
Nihad, can you hear us? We see your slides moving, but we are not hearing anything.
Can you hear me, please?
Yes, we can hear you now. Please go ahead.
Okay, super. So I'm saying that gender is linked to sex, refers to the social side of being male or female. It refers to the society's roles, behaviors, and expectations for women and men based on cultural norms. So gender norms can create structural inequalities in access to health services and shape health programs outcomes. When health financing policies ignore these inequalities, they can make them worse and block access to care, especially for the most vulnerable men and women. This brings us to gender intentionality concept, which is identify and understand existing inequalities and unfair norms and take steps to fix them. So our study examines the IMH reform
Nihad, the sound has gone off again. I don't know if you can hear us. In the last 2 minutes or so, we haven't heard you.
Can you hear me, please?
Yes, now we can.
Yes, now we can. Okay. So the main objective was to assess gender intentionally in the design and the implementation of IMAC scheme. So our study was a case study, and we used 3 methods to collect our data. We reviewed 50 documents on the IMAC project, such as laws, decrees, IMAC project plans, IMAC operational guides, IMAC evaluation report, and so on. The documents were officially obtained from the National Agency for Social Protection, which is the IMAC management agency. After that, we made an interview with 8 key stakeholders, and at the end of the data collection, we organized a validation workshop which brought those
Okay, your sound has gone off again. I guess every time it goes off, I will let you. Your sound has gone off again, Nihad.
Can you hear me now?
Yes.
Yes. Okay, thank you. So we adapted our data analysis framework from these 3 existing frameworks. The analysis framework highlights criteria for evaluating the process of designing and implementing IMAC. For each criterion, we scored gender intentionality from 1 to 5, both in the design and the implementation phase. So score from 4 to 5, have green color and means that the criterion was highly taken into account in the IMH policy document. Score from 2 to 3 have yellow color and means that the criteria was moderately taken into account, and a score of 1 have red.
Okay, so we've lost sound again. Nihad?
Can you hear me?
Yes.
Yes. Is it okay now? Can you hear me?
We can hear you. Please proceed.
We can hear you. Please proceed. Okay, sorry. So we have 4 criteria which are moderately taken into account. The first was reference to gender, women, men, these terms in policy documents, gender inequalities consideration, gender-related legal and institutional framework, and gender parity in the governance system. So we also have 2 criteria which are very lowly taken into account, and one criterion, which are highly taken into account. So we can conclude here that the design phase were partially and unstructured gender intentional, and this can lead to a reduction of equity gains and weakening the efficiency of the system. So for the implementation phase, we have 6 criteria, and the first was highly taken into account. You can see on this diapositive you can see the needs of women, men, and children which are taken into account in the benefit package. So you can remark that women are more favorable than men, and children also have their needs taken into account. So after that, we don't have a gender responsive budget for the IMH program, and there is moderately set disaggregated indicators for performance monitoring and evaluation. So here we can conclude that even though we have inclusive health services, our budget is gender responsive, and these also can create a weakness of the system efficiency. So to conclude, we can say that IMH demonstrates a more or less gender-sensitive intentionality, but in an unsystematic way. And we recommend that IMH Management Agency should implement the existing institutional framework for gender-sensitive budgeting, should involve gender actors and institutions in IMH implementation and monitoring, and he should invest in a more inclusive and systematic approach to gender.
Nihad, we lost the sound again. We know you are on your concluding slide, but if you can confirm to us if you have finished.
Can you hear me?
Yes.
Yes. Okay, so the last recommendation is that future research have to evaluate the real impact of IM Act. So thank you, and sorry for the issues with connection. Thank you.
Thank you so much for your presentation. You've also kept within the time, even though we had a couple of issues with the connection. Thank you so much. So kindly stay on for us. We'll have a Q&A session when all the presenters are done. So next, I will invite Dr. Stephen Apanga from the University for Development Studies to come and make his presentation.
Good afternoon, ladies and gentlemen. I'm happy to be presenting on the topic measuring Ghana's primary healthcare system readiness towards attaining universal health coverage using a composite index. Interestingly, our chairman is one of the authors. Okay, so I'll give a brief background through to sharing our key findings and some recommendations. Strengthening and funding of primary healthcare systems, coupled with financial risk protection, is being said to be the shortest pathway towards attaining universal health coverage by the year 2030. In 2019, the Minister of Health of Ghana developed what's termed as the National Universal Health Coverage Roadmap. And this is a health sector plan focused on strengthening primary healthcare delivery in all facilities across the country. This roadmap was intended to achieve two things. First, to situate universal health coverage efforts in Ghana's policies and systems. And then second, to guide the development of operational plans to deliver health services for the next decade. And for the primary healthcare system to attain this goal, there is the need for the system to be ready to deliver the package of services under UHC. This also requires that we are able to measure the readiness of the system at any point in time to guide us to know whether we are on track or not. But however, to date, we don't have any scientifically appealing approach of doing so. So we set out to develop a robust and scientifically appealing composite index for measuring Ghana's primary healthcare system readiness. And we went ahead to use this composite to measure the readiness of the primary healthcare system. When you are constructing a composite index, the first requirement is to have access to quality and complete data. And in this part of our world, it's often very difficult to do. So we tend to rely on data from projects and programs. So we did the same. So we used an end-line health facility survey in the Volta and Northern regions in 2020. So we then selected indicators based on the capacity of the health system to deliver quality services under the service coverage dimension of universal health care. And we also did so in line with the WHO and World Bank framework recommendations, which focused on prevention, promotion, and treatment. Recognizing the crucial role of the community in the primary health care system, we included an indicator to measure that. So we then grouped all our indicators into 4 categories. The first category dealt with availability of trained staff, essential medicines, essential supplies, equipment, and infrastructure. Then the second category of indicators dealt with types of service delivery. The third one dealt with quality. So we tried to get indicators to track or monitor quality. Then the fourth one, of course, looked at whether the facility worked with community agents or not. We then used principal component analysis to generate the components of our composite. For those hearing principal component analysis for the first time and wondering what it is, this is just a mathematical tool or technique that is often used to reduce a large set of variables into a smaller set of variables called principal components. And these components tend to contain a chunk of the information that were contained by the initial variables, just to enable you now deal with fewer variables. And in principal components analysis, our interest is to look at how these components explain the variance in the data set. And these same components form the building blocks of our composite. So we then generated a single score for each facility within its level of care. After which we ranked these scores on a scale of 5 that ranged from facilities that were less or least ready to those that were most ready to attain universal health coverage. I hope I didn't press. Okay. Good. So after analyzing 400 facilities from both regions, our composite contains 8 components. And these 8 components explain 53% of the common variance out of the 70 selected indicators we use. Now, these 8 components were related to 3 categories of our indicators. The first component, which explained about 17% of the variance, was related to quality of care. This was followed by availability of functional equipment that explained about 11% of the variance in our data. Then 5 components came together to explain 22% of the variance in the data. Then the last component accounted for just 3%, and that was related to the type of service delivery. So table 1 depicts the rankings of the system readiness. And what we did was that depending on the proportion of health facilities that were most ready to attain UHC, we gave that entire level a particular color. So if the proportion was less than 25%, we colored it red. If the proportion was between 25% and less than 50%, we colored it gold. And if the proportion was between 50% and less than 75%, we gave it light green. And if the proportion was between 75% and 100%, we gave it deep green. So if you combine both regions, this is the picture you have. But please take note of maternity homes and clinics. Most of them are privately owned, private for profit, whereas the CHIP zones, health centers, polyclinics, and a chunk of the hospitals are state-owned or government-owned. Now, if we were to segregate the data and look at it on regional basis, this is what you will see. Northern region, completely red. Volta region, you see the various stages of readiness. So the picture being created by these two tables is that facilities at the lowest or the lower tier of the health system are those that are least ready. And most of them are state-owned or government-owned. Then our maternity homes and clinics that are mostly private for profit are those that are doing well. Very interesting. Of course, we saw the regional variation there. Ladies and gentlemen, we have succeeded in constructing an index for measuring the primary healthcare system readiness towards attaining UHC, and the components or the building blocks of this composite are the monitoring of quality of care, availability of functional equipment and essential medicine, types of service delivery. And we're saying that the readiness is at various stages and levels of the system. From what we've seen in the results, we are recommending that the government of Ghana, through the Ministry of Health and its agencies, and with all stakeholders involved in the drive towards attaining UHC, invest more on these critical areas of ensuring quality of care, ensuring that equipments are functional, ensuring availability of essential medicines, and the type of service delivery. Once we do this, we can bring up their scores. That we should not make this investment uniform. We will have to prioritize it because different regions of the country are at different stages of readiness. We have seen the picture from the private sector. We have a policy, but this is not entirely being enforced or enhanced. And this is an opportunity for us to rethink and engage the private sector more so that we will be at par. So we want to acknowledge the Duke Charitable Foundation, the co-PIs of the CHIPS Plus program, and then the RIPS and Ghana Health Service team of CHIPS Plus for supporting us in our work. Thank you. Just a quick intervention.
We have a very distinguished person who is just visiting us, and I wanted to introduce him briefly. He has to go. He's in the person of Professor Jacob Malungu, an alumni of RIPS. He finished his training here in 1993. He's currently an advisor to the President of Zambia. He's visiting Ghana. He came to pay a courtesy call on us. So I asked him to come.
Good, is it afternoon? You don't even know whether it's afternoon or morning, depending on where you are. Good afternoon, colleagues. Good afternoon, everyone. Thank you so very much. We just wanted to check how we're doing. Whenever I hear of Ghana, I remember of RIPS way back 93 when I got my master's, before I went and did my PhD elsewhere in Australia. And we were having a big meeting in Gimpa, GIMPA, I think you know, is a Management Development Institute. And since we came on Saturday, I said, by all means, I need to get to Legon. And I found my colleagues, I really value their interaction with me. And I think as a person who interacted with Ghana, it's very important that we can continue with the linkages and the networks. When we have an opportunity, we need to see where we can bring things together. I had at a permanent secretary level, one of the institutes under the Office of the President, where we do a lot of training for all the government workers, about 620,000 of them. They have to come through that institute for training, and also we do academic training. And we will have to, I was just excited when I saw, I'm a professor of demography and population studies. So when I saw these models, I felt very nice that they are still there and we can use them very effectively. Once again, Prof, I really value, and everyone, thank you so much for this brief moment.
Thank you so much for passing through to say hello. We are honored that you came. So we will continue with our regular programming, and we have one more presenter who is also online. We have Amy Yedunu. I believe he's already online. Amy, can you hear us?
Yes. Hi, everyone.
Great. So I see your slides coming up. So if you can kindly upload your slides and make your presentation. Yeah. Okay, I see your slides now. So you have 15 minutes from now. You may take it away. Thank you.
Thank you very much. So hi, everyone. I'm Dr. Emily Deno from Benin, and I'm pleased on behalf of the Research Center to share with you the result of our study entitled Strategic Purchasing of Primary Health Care in Benin, Changes and Progress from 2020 to 2024 towards universal health coverage. So just as a background information, we know that universal health coverage as a policy objective endorsed widely by government means that everyone is able to use needed health services of sufficient quality to be effective without fear of financial hardship. And in addition to being a political commitment, we also know that universal health coverage requires government to allocate public resources with distributive mechanisms to protect the poor. That's where health financing is a key enabler for universal health coverage, and government responsibilities are the three health financing functions that we know: revenue raising, pooling, and health purchasing. However, it's also obvious that increased health spending does not automatically translate into improved health access to necessary services without financial risk to households. Actually, some active policy measures that direct spending towards health priorities are needed. And these policy measures are collectively known as strategic health purchasing, and they are really essential to directing increased government health spending towards advancing universal health coverage. So again, strategic purchasing means that we deliberately direct health funds to priority population, intervention, and services. So it involves using information to make decisions about what health services should have priority for public funding, selecting providers from whom these health services can be accessed, and defining how and how much will be paid to providers to deliver those services. So as recommended by authors as a practical step to improve strategic purchasing incrementally, we conducted a system-wide mapping of health purchasing arrangement in Benin in 2020 using the Strategic Health Purchasing Progress Tracking Framework. And this yielded pockets of progress on the strategic purchasing landscape of the country, essentially existing multiple benefit packages within a highly fragmented health financing system, purchasing functions carried out in silos with different agencies involved, and many more. However, achieving more strategic purchasing that leads to progress toward UHT is really a journey, and countries at all income levels are seeking to progress on this continuum towards more strategic purchasing. They make gradual progress, overcoming challenges with incremental change. That's why we decided 4 years after the first application of the framework to follow up on the previous findings by tracking changes and identifying purchasing trends and progress in Benin. But in this second application, there was a more targeted focus on primary health care as an entry point into health systems. This is partly driven by how the low investment by 2/3 of low and middle income countries in essential health services, including primary health care, despite clear evidence that primary health care underpins progress towards universal health coverage. So our research question was, how has strategic purchasing of primary health care evolved from 2020 to 2024 in Benin to support universal health coverage? So our general objective was to conduct a system-wide mapping of existing primary health care purchasing arrangements in Benin, and specifically to describe the purchasing of primary healthcare services in Benin, to track changes in purchasing arrangements in Benin from the baseline assessment, and to contribute to Benin's discourse on improving the utilization of primary healthcare resources to accelerate progress to universal health coverage. So following the various international conferences on primary health care, the Beninese government decentralized primary health care by creating 34 health districts to really ensure access to basic care, manage resources, and develop community participation. And this aims to empower these districts and make them autonomous. The national health system was then modeled on the administrative division and is now organized into 3 levels. So we have the primary level, which consists of health centers and district hospitals, focusing on basic health services and preventive care. The secondary level comprises departmental hospitals, providing more specialized services. And the tertiary level includes university hospitals and specialized institutions offering highly specialized medical care. Furthermore, a national agency for primary health care was also created in 2019 to supervise and implement the national policy for community health, which was officially launched in 2023. And this community health policy was implemented in 5 pilot communes involving 37 community health workers and 1,500 community volunteers, people who were really equipped with the necessary materials to promote primary health care. So in Benin, multiple fragmented health financing schemes have been operating so far, each targeting different population segments with distinct characteristics. So we have non-contributory schemes that include health insurance for students in the public sector and people or disease-specific vertical programs. On the other hand, contributory schemes include our National Health Insurance Scheme, commonly known as Earmark, the State Civil Servant Scheme, Mutuelle de Santé, and Primary Health Insurance. Yet, Benin's health expenditure is dominated by out-of-pocket payments with low government health spending. And in 2017, only 8.4% of the population was actually covered by a health insurance. So we purposely selected 4 insurance schemes, considering a set of criteria comprising their integration into the health system, the level they operate at within the three-tier system, and their share population coverage. Therefore, horizontal schemes promoting primary health care were then prioritized, and we excluded people or disease-specific vertical programs that usually promote specialized care at the tertiary level. Subsequently, selected schemes include an earmark, our national health insurance scheme, which was launched in 2019, and it's actually the main component of a vast social protection program that includes training, credit, and retired pension for extremely poor populations and informal sector workers. So actually, this scheme has been prioritized by Benin as the primary scheme to achieve universal health coverage. So the civil servant scheme targets active and retired civil servants and their right holders, and it operates through the Benin National Pension Fund. The Mutuelle de Santé are community-based health insurance schemes that primarily target the informal sector and people located in remote areas. The primary health insurance is a voluntary scheme offered by private companies. So considering our research question as stated above, we applied a descriptive single embedded case study design as described by Robert Min. So the case under study was then the strategic purchasing of primary health care with 4 units of analysis represented by the 4 health insurance teams selected. So we reviewed almost 100 documents and conducted informal interviews with relevant stakeholders involved in the implementation of each scheme. And a crucial component of the data collection process was the collaboration between policymakers and the research team. So regular consultation meetings enable researchers to gather and prioritize inquiries, leading to rapid analysis that inform decision making. So we collected data using an Excel-based tool, and they were manually analyzed following a deductive approach that was guided by our framework. So this is just to give you an overview and idea of the framework. So the premise of this framework is that any purchasing system carries out a set of core functions supported by governance and institutional arrangements that allocate the responsibility for carrying out those functions. So when purchasing functions and governance arrangements are in place, the purchaser can directly influence the allocation of resources, the incentives that drive individual provider behavior, and accountability through contract enforcement and performance monitoring. All these can then affect overall progress on intermediate and long-term UHC goals. However, the purchaser's influence on resource allocation, incentives, and accountability can be enhanced or mitigated by some external factors, such as the legal environment and all. So one of our main findings is that no additional scheme has been created from 2022 to 2024. Consequently, the trend seems towards a decreased level of fragmentation across Benin's health financing arrangements with regards to the changes occurring so far. Actually, earmark in Benin is consolidating schemes such as the National Exemption Scheme for C-section deliveries, Civil Servants and Student Scheme, as well as the Malaria Vertical Program for under 5 and pregnant women. Some external factors include the reinforcement of the legal framework for the implementation of mandatory health insurance policy, and also the absence of specific law applied to mutual make them operate under the status of a non-governmental organization. So all 4 schemes have an official and designated purchasing agency with clear lines of accountability. The key changes regarding governance arrangement include the appointment in 2021 of a new purchasing agency for the implementation of earmark, the hiring in 2024 of a private entity that will take over and ensure its operational management, and the establishment in 2023 of a national unique social registry to really identify and manage information on those extreme poor populations. In the civil servant scheme, an online service was launched in 2023 that allows beneficiaries to get a digital medical checkup form to request health services. Except for the civil servant scheme, all the other ones have a well-defined essential health service package that actually includes primary health care services. Similarly, there are no formal or selective contracts with providers in the civil service scheme. And while earmark contracts mostly with both public and private faith-based providers, private health insurance companies contract mostly with private for-profit providers and some public ones at the second or tertiary level. So fee-for-service is the only provider payment method used across all the schemes. But actually in 2024, earmark set up a district-level proposition of funds to mitigate payment delays to primary health care providers. And the key change noted in terms of performance monitoring is within earmark, where a national consultation forum was set up in 2021. So the findings indicate notable improvements in the governance of strategic purchasing, particularly within earmark, which has made strides in institutional reform and operational efficiency, including the transition to a new purchasing agency. However, disparities persist across schemes regarding service coverage, data management systems, and provider engagement. So our recommendations are just to mainstream strategic health purchasing within the health sector by clearly articulating how strategic purchasing advances the objectives of the health system, to aim for a more patient-centered primary health care system rather than a team or vertical approach, and to strengthen evaluation mechanisms within implementation agency to ensure accountability and continuous improvement of primary health care. So this leads me to the end of the presentation. Thank you for your attention.
Thank you so much, Amy, for your presentation, and indeed to all our presenters. So now we are done with our 4 presentations. It's time for Q&A. So we don't have much time. We have barely about 10 minutes. So we'll just do only one round. So please, anyone who has any questions and or comments for any of the presenters? Okay, I see one hand.
Thank you. My name is Al-Hassan Abukari. I'm a district director of health from Central Gonja district in the Savannah region. And I'm also a mentee on the IHP COP program. From the presentations yesterday and today, I'm just going to make a comment. And mostly on the CHIPS and the primary health care interventions that the country has implemented over the years. Looking at the results from both researches that have been conducted by the academics and then the practice outcomes that have been shared here, undoubtedly we think these policies or interventions are good for us as a country. But what I've also observed is that during the interventional period, when you are implementing a program, the outcomes are usually very good. But after the programs, sustainability usually is a problem. Then I also saw that consistently from yesterday and today from, I've forgotten doctor's name from UHAS and then Dr. Apango from UDS, you can see something that is featuring clearly, that is lack of resources for these interventions to be sustained for us or for us to benefit from it. And then crowning it, universal health coverage is just 5 years away. Dr. Apango's presentation tells us clearly that we are not likely to achieve universal coverage. And from my own personal experience on the field, I see it and we deliberate about it. So what are we doing as a country, or for maybe for this forum, what proposals can we bring out of this? Because there is no deliberate funding for these activities at the primary health care level. Most of the time, funding is programmatic. And so during the programmatic phase, you are doing very well. Suddenly, when the program fills up, then you are back to where you began from. My director for PPME and the team are all here. I want to use this opportunity to find out what the service, and by extension, the Ministry of Health and the government is doing. Because in terms of budgetary allocations, public health services are not catered for deliberately. And it is always said, depend on IGF, to the point that the IGF that we are depending on for the public health activities are decapitalizing the facilities that took care or that brought forth the IGF, resulting in that cyclical effect of the facilities being depleted. You go to some of the facilities like they have seen, even a home visit bag is not there. BP apparatus and very basic equipment are lacking. And so as I sat through since yesterday and today, this is what has been going on in my mind. And I wish that we also discuss some of these issues. Thank you.
Thank you very much. Even though it's not directly meant for the presenters, I know, thankfully, Dr. Bibi is here, and Dr. Ayum is here, Dr. Salamatu is here, so I'm sure when it's time for answers, they will deal with that. So let's go to...
would like to use the opportunity to also say something.
You are abusing your... you are abusing your position.
And actually, I had a concern. Doctor, thank you so much for the presentation. And truly, CHIPS Plus, capacity building of frontline workers through CHIPS Plus brought positive change in CHIPS implementation, not only in the southern part, but also in the northern part. And I saw the results, the CHAP activity movement plan of the CHO. Please, my concern is, were you able to also assess the action items on the action plan, whether they were able to implement it? Because I believe it's not only having the action plan, the CHAP, but then also its implementation, which could tell the success story of the frontline health workers training.
All right, thank you so much. My name is Cosmos Manila. I also want to have a bite on the presentations. And let me thank all the presenters for the good job done. Mine is on the presentation made by Dr. Apanga. It has been an insightful one. And you are looking at measuring the Ghana's primary healthcare system readiness. Like my colleague rightly pointed out, the CHIPS as a policy is centered on public health services generally, a bit on clinical, which is just to treat minor illnesses. So, and from the presentation, it was very clear that there has been some indicators that were developed for the assessment. I don't know whether they were specific based on there were specific indicated based on the levels, because you have CHIPS compounds, you have health centers, and these hospitals. All these are flat indicators that are applicable across. If it is the case, then I won't be surprised to see much of the rest in the CHIPS compounds. Else, the CHIPS per its implementation, I'm saying this, Dr. Roy is here. When it was implemented, the emphasis is not about the structures. It was about having space within the community where CHOs can stay and render services, which are generally public health in nature. And so, comparing them, I want to see the basis on which you are putting them in their readiness. Is it the case that you expect them to also participate in this treatment or some level of illnesses? If it's the case, then it won't be fair. And then also, it's also issue inform us, and Dr. Yim is also here. Like my colleague rightly said, the targeting of resources. Relative, when you show the two regions, you could see that there wasn't even a single green in northern region. It's all red for northern region, but for Volta region, there were some appreciable greens, if not all, but they were largely green. I think we should look at targeting of our resources and not to maybe use a blanket distribution across board. Other than that, those who are already down will continue to lie down, and those who are already up will continue to move up. That's just one thing I wanted to really emphasize on, and to see what we can really do collectively. Assemblies, let me also touch those who are not here. For the CHIPS compounds, they are interested in putting up the structure. They will put up the building, nice one for you. Not even a bench will be in it. And then you come to assess us. I mean, and there is nobody, apart from sometimes where we, at the district level, try to lobby the local partners. And in our context, in the northern part, it's about households, assemblymen, who are really also vulnerable, can hardly contribute much. I can hardly contribute much. So the emphasis to when we are doing this, maybe at a higher level, let's see how we can really engage central government through the district assemblies. That when you put up a CHIPS compound, ensure that you stock it appropriately so it can function as such. Just a little contribution I also want to make. Thank you.
Thank you. We will take one last comment from Dr. Amwakubuatin, and then also our online guests. If you have any questions, please put them in the chat, or you can raise your hand and then we give you the opportunity.
Thank you. My question also goes to the quality of care. And it's following what our colleague just said. So when you give the composite for quality of care, most of the time I see we look purely about the inputs. We decide maybe to leave the processes, maybe outcome. We leave all of them. And the emphasis has been on the input. If you had the opportunity to look at the recent Global Commission on Quality, where they are telling us now we should really look at the processes, because the point is the availability of all these inputs are not translated into quality. It's the processes. And if you look at the perinatal mortality, maternal mortality, the issue that came up. Then also, when we are looking at quality, if you look at the dimension of quality, is it a safety? Is it the timeliness? Is it patient related? Is it efficient? So which dimension do we normally look at? Because it's very easy for us to lump and say quality. But are we looking at a particular dimension that we are looking? And if you go to the ground, to the community health center hospital, apart from the whole issue of quality, it's about quality improvement. Though resources will not be available across all, but even what they have and the targets that they are supposed to meet, within the resource availability, especially if they use the priority matrix, do they know how to do the improvement? Whilst we wait at the community, whilst we wait at the CHIPS compound health center. So that has been some of us our challenge for those at the level to continuously improve with what they have, looking at the gaps. I don't know whether we saw that, and I don't know which the composite is also addressing. Thank you.
Okay, thank you so much. I think that's, do you have any comments or questions from online? Okay, so I see that Dr. Sevnafanka has like 3 questions. I'll give him 2 minutes, and I'll give 1 minute to Dr. Amu. But I do have one question for Nihad. I don't know, if Nihad, if you are still online, if you can hear me. I wanted to ask, in your presentation, so you did give us some results on the design as well as on the implementation, where you showed that the issues about gender have not been sufficiently factored. I was just wondering if the program has been implemented sufficiently enough for us to begin to see anything on outputs or results or outcomes, and whether you're able to comment on whether this has how this has translated into outcomes between gender-based outcomes. So I'll give you 30 seconds for that, and then 1 minute to Dr. Amu and 2 minutes to Dr. Afanga.
So I can start?
Please.
Okay, thank you very much. So there was a question on the action plans, if we also tried to see if they were really implemented, or they only created the action plan and that was it. So in my presentation, I mentioned that there was a bigger study that we did, and this was just part of it. So in the bigger one, we actually also spoke to CHMCs, that's the Community Health Management Committees, where we did focus group discussions. And some of these CHOs were also in those meetings where we tried to investigate whether the action plans were being put in place. Then I can say that, yes, we found that they actually implemented the things. So that was also investigated. Maybe other studies, if we have the chance to present another work from that evaluation, we'll be able to tell that part of the story as well. There was a question on sustainability, which was not directly directed to me, but I feel that CHIPS Plus was so basic that anybody who got involved in its implementation could go on and do the things that they were especially trained on, since we focused on capacity building, because we taught you how to develop the chap, how to create a movement wheel. This doesn't need any money for you to get a cardboard and create a movement plan. The challenge has, however, been the high attrition rates at the CHIPS compounds. You train somebody today, 3 months that you go back, they are no longer there. Either they've gone to school or they've been moved to another zone. So that has rather been the major challenge. So if the Ghana Health Service finds a way of reducing the attrition, it comes with a lot of motivation though, because the person is not satisfied with their salary and wants to improve upon themselves so they can get better. So if we're able to find a solution to the attrition rates at the lower levels, community, sub-district levels, I think it will help a lot of the many good things that we implement, but the people we train are not there to get them implemented sustainably. Thank you very much.
Thank you. If you can hand it to Dr. Panga behind you.
Okay. My good brother, if you have read the revised CHIPS policy, you realize that there are some basic things that are needed at that level. And the focus is on maternal care, family planning, and child health. So our tool was modeled along that. And we use the same thing for all the levels of healthcare. So we didn't go to look at whether the facility was doing a cesarean or not. So just those basic things. All right, so that was a standardized tool. And it will interest you to know that there were a few of the CHIP zones that were even doing better than the hospitals. Is that okay? Okay, and my boss, the quality. I'm sure you agree with me that as at now, we don't have a standardized way of measuring quality. There's always this to and fro thing about quality, so people are bringing out process and what have you. And they are trying to develop new indicators to measure it. But what we have in the system are mostly proxies. So we expect that if you go to facility A and you find a maternal health register, you look at it and you see that it's been well filled. At least it tells you that they did some level of monitoring. Because you are, ideally, you should be there to see and then take to make sure that it follows the standard procedure. So for now, what we did was to look at these proxies. I hope I've helped. But then that still means that you have a lot of work to do, you, the quality people, so that we can get more of such indicators. Thank you.
Thank you. There's one question from me from Nihad. I don't know, Nihad, are you still online?
Hello, can you hear me?
Yes, please.
Yes, please. Okay, so thank you. You are right when you say that is the insurance has been sufficiently implemented. We are. It will be 6 years soon that we implemented it, and I want to say that our study focused on the gender intentionality. So we were more focused on the policy document to see if gender issues were taken into account in the development of IMAC policy. So if you see my presentation at the end, we recommend that future research should have to evaluate the gender mainstreaming. So we just focused ourselves on the gender intentionality. So in the results, you can also see that there were no gender assessment before, before the IMAC development. So this is one of what we were searching for. Sorry for my English. So we basically focus on the intentionality on the IMAC policy development. So thank you.
Thank you so much. Thank you so much. This is where we bring down the curtain for this session. I would like to thank our presenters, our 4 presenters, especially those who join us online. Thank you for making the time in spite of the challenges sometimes with the connection. And also thank you, audience, for your participation and attentiveness. So I know there was one question that was asked by the District Director for Central Gonja, but since all the people who matter from PPME are here, I'm sure they will gather together and have a discussion and then come and report to us what they concluded on. So on that note, I don't want to stand any more between you and lunch. We will bring the session to an end, and I'll ask the MC if there are any announcements. But thank you very much for your participation.
We'll go according to the program.
Yeah, we are going for lunch.
How do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, There's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
we believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. The researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
Global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in arms who recognize the unique contributions they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
A pesquisa de implementação é tida como uma das prioridades do Ministério da Saúde, dado que é a melhor forma de identificar, portanto, as fragilidades de resposta do sistema de saúde, portanto, nos diferentes níveis do sistema.
The IDEAS project covers 12 districts, about 150 health facilities, and covers a population of about 3 million people. It's creating a mechanism so that there's a better understanding of what we are doing and how to do it better, and using data to drive that process.
O projeto tem fundamentalmente 3 componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de melhoria de qualidade de dados e uso nos processos de tomada de decisão.
A informação é colhida ao nível da unidade sanitária pela enfermeira e passa depois para o resumo.
Por exemplo, se ela consegue notar que das 100 mulheres que vieram fazer consulta pré-natal, só consegui fazer testagem em 80, porque os testes acabaram. Acabaram porque eu, enfermeira, não pedi, acabaram porque o sistema não tem,
E eles têm essa capacidade de fazer essa análise ao nível local, da unidade sanitária, e constroem os seus gráficos para poderem tomar decisão ao nível local. Depois o resumo é enviado a serviço distrital, e do serviço distrital essa informação entra numa base de dados que a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Tudo isto depois leva à realização desta reunião.
Every 6 months, the meetings bring together district and facility level managers to review performance and follow on supervision and financial support.
É um momento não só de apresentação de resultados, mas ao mesmo tempo é um momento de partilha de experiências, portanto, entre as diferentes unidades sanitárias. Estas reuniões culminam com a elaboração, portanto, de um plano de ação que é fundamentalmente um instrumento que guia a ação, portanto, ao nível das unidades. Este programa contribui para o reforço do sistema de saúde através do treino de profissionais e de financiamento, portanto, de pesquisa, de implementação, que contribui em última instância, portanto, para a redução da mortalidade, quer, portanto, infantil, quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals would solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people. 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only about 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system. We are focusing on community-based primary healthcare system as the basic primary healthcare vehicle to drive systems at the community level. That is what our health system needs.
I'm a community health officer because I have the zeal to work, to help my community, to help Mother Ghana. I render child welfare clinics. I do immunization. I do family planning. Then I also treat minor ailments. I had a passion for the job. I'm doing it with my heart. It's humanity. You are helping somebody. One day someone will also help you.
You look at the problem and try to find solutions through innovative ways. And one of the things that we did was to introduce a motorcade ambulance service to serve women in terms of referral from one community to the other. Women were dying, babies were dying. Most of the deaths were recorded in the communities. We addressed that problem by providing what we call the motorcade ambulances. This is a local initiative.
With the introduction of the motorcade to this place, the community has really done well.
If you do something successful, there's always a need to carry on. We have a major public health system working, we have volunteers working, the nurses have adequate equipment, they have their clinics, they're working. Any country that looks at our health system or look at our program should be able to apply it.
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system.
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first phase of the African Health Initiative, we put out an open call for partnership proposals from 11 countries. And after quite a long review process, we narrowed down and awarded grants to pilot projects in 5 countries. Those countries were Ghana, Tanzania, Rwanda, Mozambique, and Zambia.
For the program to work, it needed support and agreement from all the levels, national, provincial, down to the people who have day-to-day oversight of the delivery of services.
We view data as one of the ways that a health system can be best informed.
You have to be able to see what you've done. You need a health information system. You have to be able to have the ability to examine those data and to course correct. That requires leadership and the ability for local actors to make decisions.
Not all of the projects were successful. From that, we decided to have a second phase of the African Health Initiative and to make some changes. We required that an individual from the national government commit time to leading the program. The second important shift was a recognition that we wanted researchers, practitioners, and program managers to come together regularly to talk about data and research and evidence use, and to talk about what the data was telling them in their communities. It's our intention to build that culture of review and thoughtfulness when making decisions around service delivery.
This is not a high-cost investment, but it's not one that can be achieved without resources. We need funders to start thinking about coming together and enabling projects to be implemented, not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people that we've supported, not only in the lives saved, but in the researchers, the policymakers, and the practitioners who've embodied this approach. My greatest hope is that the countries where we're investing are able to continue this effort in strengthening their health systems after the Doris Duke Foundation funding comes to an end.
How do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, there's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is to support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
We believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. Researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
Global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in arms who recognize the unique contributions that they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
A pesquisa de implementação é tida como uma das prioridades do Ministério da Saúde, dado que é a melhor forma de identificar, portanto, as fragilidades de resposta do sistema de saúde, tanto nos diferentes níveis do sistema.
The IDEAS project covers 12 districts, about 150 health facilities, and covers a population of about 3 million people. It's creating a mechanism so that there's a better understanding of what we are doing and how to do it better, and using data to drive that process.
O projeto tem fundamentalmente 3 componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de melhoria de qualidade de dados e uso nos processos de tomada de decisão.
A informação é colhida ao nível da unidade sanitária pela enfermeira e passa depois para o resumo.
Por exemplo, se ela consegue notar que das 100 mulheres que vieram fazer consulta pré-natal, só consegui fazer testagem em 80, porque os testes acabaram. Acabaram porque eu, enfermeira, não pedi, acabaram porque o sistema não tem.
E eles têm essa capacidade de fazer essa análise ao nível local, da unidade sanitária, e constroem os seus gráficos para poderem tomar decisão ao nível local. Depois o resumo é enviado ao serviço distrital e do serviço distrital essa informação entra numa base de dados que a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Tudo isto depois leva à realização desta reunião.
Every 6 months, the meetings bring together district and facility level managers to review performance and follow on supervision and financial support.
é um momento não só de apresentação de resultados, mas ao mesmo tempo é um momento de partilha de experiências, portanto, entre as diferentes unidades sanitárias. Estas reuniões culminam com a elaboração, portanto, de um plano de ação que é fundamentalmente um instrumento que guia a ação, portanto, ao nível das unidades. Este programa contribui para o reforço do sistema de saúde através do treino de profissionais e de financiamento, portanto, de pesquisa, de implementação, que contribui, em última instância, portanto, para a redução da mortalidade, quer, portanto, infantil, quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people who come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals would solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people. 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only about 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system. We are focusing on the community-based primary healthcare system as the basic primary healthcare vehicle to drive systems at the community level. That is what our health system needs.
I'm a community health officer because I have the zeal to work, to help my community, to help Mother Ghana. I render child welfare clinics. I do immunization. I do family planning. And I also treat minor ailments. I had a passion for the job. I'm doing it with my heart. It's humanity. You are helping somebody. One day someone will also help you.
You look at the problem and try to find solutions through innovative ways. And one of the things that we did was to introduce a motorcade ambulance service to serve women in terms of referral from one community to the other. Women were dying, babies were dying. Most of the deaths were recorded in the communities. We addressed that problem by providing what we call the motorcade ambulances. This is a local initiative.
With the introduction of the motorcade to this place, the community has really done well.
If you do something successful, there's always a need to carry on. We have a major public health system working, we have volunteers working, the nurses have adequate equipment, they have their clinics, they're working. Any country that looks at our health system or look at our program should be able to apply it.
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first phase of the African Health Initiative, we put out an open call for partnership proposals from 11 countries. And after quite a long review process, we narrowed down and awarded grants to pilot projects in 5 countries. Those countries were Ghana, Tanzania, Rwanda, Mozambique, and Zambia.
For the program to work, it needed support and agreement from all the levels, national, provincial, down to the people who have day-to-day oversight of the delivery of services.
We view data as one of the ways that a health system can be best informed.
You have to be able to see what you've done. You need a health information system. You have to be able to have the ability to examine those data and to course correct. That requires leadership and the ability for local actors to make decisions.
Not all of the projects were successful. From that, we decided to have a second phase of the African Health Initiative and to make some changes. We required that an individual from the national government commit time to leading the program. The second important shift was a recognition that we wanted researchers, practitioners, and program managers to come together regularly to talk about data and research and evidence use, and to talk about what the data was telling them in their communities. It's our intention to build that culture of review and thoughtfulness when making decisions around service delivery.
This is not a high-cost investment, but it's not one that can be achieved without resources. We need funders to start thinking about coming together and enabling projects to be implemented, not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people that we've supported, not only in the lives saved, but in the researchers, the policymakers, and the practitioners who've embodied this approach. My greatest hope is that the countries where we're investing are able to continue this effort in strengthening their health systems after the Doris Duke Foundation funding comes to an end.
How do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, there's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
We believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. Researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
So I think you should just go.
Global
So good afternoon and welcome back. We expect that you would go into your breakout sessions and then meet your moderators and let's begin. Please, let's try and make the time so that we can close right on time and then we can bid each other goodbye. Good luck and see you later at 4.
Who support single disease programs, who support data use. We need all hands on deck.
A pesquisa de implementação é tida como uma das prioridades do Ministério da Saúde, dado que é a melhor forma de identificar, portanto, as fragilidades de resposta do sistema de saúde, tanto nos diferentes níveis do sistema.
The IDEAS project covers 12 districts, about 150 health facilities, and covers a population of about 3 million people. It's creating a mechanism so that there's a better understanding of what we are doing and how to do it better, and using data to drive that process.
O projeto tem fundamentalmente 3 componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de melhoria de qualidade de dados e uso nos processos de tomada de decisão.
A informação é colhida ao nível da unidade sanitária pela enfermeira e passa depois para o resumo.
Por exemplo, se ela consegue notar que das 100 mulheres que vieram fazer consulta pré-natal, só consegui fazer testagem em 80, porque os testes acabaram. Acabaram porque eu, enfermeira, não pedi, acabaram porque o sistema não tem.
E eles têm essa capacidade de fazer essa análise ao nível local, da unidade sanitária, e constroem os seus gráficos para poderem tomar decisão ao nível local. Depois o resumo é enviado ao serviço distrital e do serviço distrital essa informação entra numa base de dados que a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Tudo isto depois leva à realização desta reunião.
Every 6 months, the meetings bring together district and facility level managers to review performance and follow on supervision and financial support.
É um momento não só de apresentação de resultados, mas ao mesmo tempo é um momento de partilha de experiências, portanto, entre as diferentes unidades sanitárias. Estas reuniões culminam com a elaboração, portanto, de um plano de ação que é fundamentalmente um instrumento que guia a ação, portanto, ao nível das unidades. Este programa contribui para o reforço do sistema de saúde através do treino de profissionais e de financiamento, portanto, de pesquisa, de implementação, que contribui, em última instância, portanto, para a redução da mortalidade, quer portanto, infantil, quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people who come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals would solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people. 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only about 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system. We are focusing on community-based primary healthcare system as the basic primary healthcare vehicle to drive systems at the community level. That is what our health system needs.
I'm a community health officer because I have the zeal to work, to help my community, to help Mother Ghana. I render child welfare clinics. I do immunization. I do family planning. Then I also treat minor ailments. I have the passion for the job. I'm doing it with my heart. It's humanity. You are helping somebody. One day someone will also help you.
You look at the problem and try to find solutions through innovative ways. And one of the things that we did was to introduce a motorcade ambulance service to serve women in terms of referral from one community to the other. Women were dying, babies were dying. Most of the deaths were recorded in the communities. We addressed that problem by providing what we call the motorcade ambulances. This is a local initiative.
With the introduction of the motorcade to this place, the community has really done well.
If you do something successful, there's always a need to carry on. We have a major public health system working, we have volunteers working, the nurses have adequate equipment, they have their clinics, they're working. Any country that looks at our health system or look at our program should be able to apply it.
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first phase of the African Health Initiative, we put out an open call for partnership proposals from 11 countries. And after quite a long review process, we narrowed down and awarded grants to pilot projects in 5 countries. Those countries were Ghana, Tanzania, Rwanda, Mozambique, and Zambia.
For the program to work, it needed support and agreement from all the levels, national, provincial, down to the people who have day-to-day oversight of the delivery of services.
We view data can be best informed.
You have to be able to see what you've done. You need a health information system. You have to be able to have the ability to examine those data and to course correct. That requires leadership and the ability for local actors to make decisions.
Not all of the projects were successful. From that, we decided to have a second phase of the African Health Initiative and to make some changes. We required that an individual from the national government commit time to leading the program. The second important shift was a recognition that we wanted researchers, practitioners, and program managers to come together regularly to talk about data and research and evidence use, and to talk about what the data was telling them in their communities. It's our intention to build that culture of review and thoughtfulness when making decisions around service delivery.
This is not a high-cost investment, but it's not one that can be achieved without resources. We need funders to start thinking about coming together and enabling projects to be implemented, not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people that we've supported, not only in the lives saved, but in the researchers, the policymakers, and the practitioners who've embodied this approach. My greatest hope is that the countries where we're investing are able to continue this effort in strengthening their health systems after the Doris Duke Foundation funding comes to an end.
How do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, there's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
We believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. Researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
Global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in arms who recognize the unique contributions that they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
A pesquisa de implementação é tida como uma das prioridades do Ministério da Saúde, dado que é a melhor forma de identificar, portanto, as fragilidades de resposta do sistema de saúde, portanto, nos diferentes níveis do sistema.
The IDEAS project covers 12 districts, about 150 health facilities, and covers a population of about 3 million people. It's creating a mechanism so that there's a better understanding of what we are doing and how to do it better, and using data to drive that process.
O projeto tem fundamentalmente 3 componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de...
Hello, good afternoon. You are welcome from lunch. This is our session, the prior session in room 1. I'm Dr. Boache Boatin, Director Policy Plan Monitoring Evaluation Division of the Ghana Health Service, and I'm moderating with
Dr. Salamatu Atanantokma, Deputy Director, IME.
I wish to assume that our presenters are all here. We have Eunice Tangwam of the Ghana Health Service from the Katsina and Kana Municipal. Let's invite her with a clap, come to the front. Yes. Let's clap for her as she comes. From the Upper East region of Ghana. Yes, sit down. One of my mentees. He will be talking on improving first trimester pregnancy registration at the Kologo Health Center. Then next will be also from the Ghana Health Service. Samson Obripo, where is he? Where is Samson? Just come. Where is it by him? Let's invite to the club. He will be talking on adherence to infection prevention and control guidelines by healthcare workers in the Volta region of Ghana. Then we have our own good friend from Bono, where we worked with and under them. The Regional Information Officer of the Bono region, George Asari Tabi, where is he? George, come to the front. Let's clap for him as he comes. George Asari Tabi will be speaking on decline in institutional maternal mortality ratio, the Bono story. Last but not the least, a very handsome gentleman. I hope he's around. Very, very handsome. I see him on Facebook, very handsome. Dr. Anthony Chung of the Ghana Health Service. Let's welcome him with a clap. Go ahead and sit. Let's welcome him. Are you okay? So Dr. Anthony Chung will be presenting on healthcare quality improvement journey with advanced self-care tool, the case of Kintampo Municipal Hospital in the year 2004. I can see that he has a lieutenant. What's your name? I'm Shaibu. So let's clap for Shaibu. He is Elisha and he is Elijah. So we are going to be in the driving seat or the captain, and we have a smooth sail. So without much ado, we want to invite the first presenter from my region, Upper East region, Miss Eunice Tangwam, from Ghana Health Service, Kasana Kana Municipal, to talk on improving first trimester pregnancy registration at Kolugu Health Center. We have 15 minutes. We shall prompt you when it's 5 minutes and it's 2 minutes. So good luck, madam. Yeah, good luck, good luck.
All right. Good afternoon, everyone. And good evening to audience online who are ahead of Ghana in terms of time. Okay. I'm Eunice Tangwam, Ghana Health Service from Kasna Municipal. I'm here to present on a point of care quality improvement project titled Improving First Trimester Antenatal Care Registration at Kogo Health Center. Okay, this is how I'll be taking you to Navrongo today and now to Kogo Health Center. All right, by way of background of the facility and the problem, Kogo Health Center is situated in the southern part of Kasna Municipal. And despite its strategic position, in fact, those who have been to Upper East and the Kogo Health Center would agree with this. But for some time now, it has been grappling with low antenatal registration rates, especially with first time registrations. So yes, we all agree that early initiation of antenatal care is very key. Just like who focused antenatal models recommend timely initiation, and that is from the last menstrual period to 12 weeks of pregnancy for every pregnant woman. Yes, so in 2023, Upper East region recorded 52% of first trimester pregnancy registrations, which didn't meet the national target of 55%. Then when you come to Kasna municipality, it recorded 48%, which does not also what? Which did not also meet the target. So as Kogo Health Center, we recorded 32, for that. So you can see that Kogo Health Center has contributed in letting Katsina and Ankara North meet the target in 2023. So yes, in 2024, by half year, Kogo Health Center recorded 33.3% of first trimester registrations of pregnant women, which was very worrying. So yes, the staffs thought of looking at how that gap could be worked on. And also, we know that late ANC initiations has a lot of issues, because sometimes some of the families are not able to prepare for birth and also complication readiness, and unforeseen consequences may arise during antenatal, delivery, and after. So yes, after sitting and thinking about it, when it comes to quality improvement, data is key. Quality improvement projects are data-driven. So upon identifying that as a gap, we couldn't have just picked it to work on it just like that. So we went into our data and noticed we had 3 gaps, which we had to prioritize using the problem identification method or the prioritization matrix. So the problems identified were anemia at 36 weeks, ANC registration in first trimester, ANC clients making 4 visits plus. So in prioritizing these gaps, the importance of a patient outcome, ANC registration in the first trimester took the greatest bite. By the end of the day, when you come to the total score, after looking at affordability of time and resource, easy to measure, whether it's under control of the team members at the facility, we realized that ANC registration in first trimester was the highest. So that is how come we picked that as a project. So after prioritizing and identifying the gap to work on, where were we and where are we going? So our aim statement is to increase first trimester antenatal care registration from 33.3% to 60% within 3 months, from 13th June 2024 to 13th September 2024 in Kogo Health Center. So after carving our aim statement, we needed to use a method to implement the initiative, which we exploit the root cause analysis using the fishbone analysis. In fact, if any of us have enjoyed Navrongo tilapia, you know that this fishbone is from Navrongo. All right. So from here, our fishbone analysis, our main problem was resources, the client, process, then staff. So when we look at resources, the facility doesn't have an ultrasound scan or machine. And there are issues of finance. You know, sometimes at the facility, you would have an idea, but sometimes you need some resource like finance to carry out certain projects, not necessarily huge sums of money. But then, sometimes you would need fuel and other resources which you need to carry out an activity. Then when you come to clients, when you ask them to go and make a scan, they'll tell you they don't have money. So it becomes a problem. Then with myths and beliefs, they wouldn't come for antenatal early. When you find out, some of them say that usually when they report early, the pregnancy would be terminated. And some of them will be waiting for compound heads or landlords or their sister-in-laws to announce the pregnancy before they commence antenatal services. Then with the processes, our midwives, we notice that our midwives always want evidence of the scan before they can register them for their first antenatal. Then when it also comes to the staff attitude, less effectiveness follow-up visits, then less clinician involvement and referral from the consulting rooms. So we use the improvement model to help us evaluate our initiative. So the PDSA cycle is an improvement model where we have P, that stands for planning, where you would have to set your objective and propose an idea. Then the do, that is where you implement your initiative. Then the study, that is where you would have to analyze your data you have picked. Then the act is where you would have to, the study is where you study the data you have collected and to see whether you have learned something from it. Then the act is where you act. Then you share what you have, your initiative. So yes, what changes did we do? So what changes do we think will help solve the problem? So one, we register mothers whilst waiting for scan. And how will this change improve care? It will encourage clients to come for the first time. Then the second change is to liaise with TBAs and opinion leaders. And this would help detect and educate clients to report early for registrations. Then the follow-up visits. This would remind our clients to go for their scans. Then the urine pregnancy test at OPD, that is involving our clinicians to help us in early detection of women who are pregnant. That visits our consulting room. So yes, we analyzed and measured quality of care. So here we are asking, what measure will we use? We said we will use percentage of mothers reporting in first trimester, and it's a process measure because the act of registering the pregnant woman is a process. Then the denominator would be number of ANC registrants. What data source will we use? We use the antenatal care register. So how frequent will we review? Every 2 weeks. We review the data every 2 weeks. And our midwife is responsible. So these are expected outcomes. So we say increase early ANC registrations from 33.3% to 60% or higher. Then improve early detection and management of pregnancy-related conditions. Then enhance community involvement in maternal health. Strengthen capacity of health staff to carry out quality improvement initiatives. So the main interventions we carried out were the ANC registrations whilst waiting for the clients to go for ultrasound scan. Then the engagement of our TBAs and community opinion leaders. Then follow-up visits for eligible women. The introduction of the UPT. So we used the RAN chart. So looking at the RAN chart, it wasn't easy. So the first week we had 25%. The fourth week, you know, we said we will be reviewing in every 2 weeks. We had 100%. All the clients who came within the 2 weeks, all were in first time. Then with the third week, no clients came. Then the fourth week, we had 80%. Then the fifth week, 33.3. Then the sixth week, we had 100%. All the clients who reported came in first time. So this is the results. At the end of the project, we recorded 68% ANC registration rate in the first time. The UPT test intervention led to notable improvements. So despite some setbacks, definitely we had some challenges, but then we sailed through and decided to adapt the initiative. So we had positive and negative initiatives, impacts as well. So I think our recommendation, this project's outcome is shared to inform policy and advocate for a scale-up on UPT use at our OPD levels, which will help us detect the pregnant women early. Then registration of our pregnant women whilst waiting for the scans will help. Then we are equally appealing that in our various health centers, especially those at the periphery, if they have ultrascans available, it would help. So we conclude by saying that the point of care quality improvement project demonstrates structured interventions and community engagement, which significantly what improve ANC registrations. All right, this is our gallery. Then acknowledgement. All right. Thank you very much.
Thank you so much, Madam Eunice, for that insightful quality improvement project. Our next presentation is adherence to infection prevention and control guidelines by healthcare workers in the Volta region of Ghana, and it's presented by Samson Obrepo. Shall we welcome him with a hand? You have 15 minutes.
Thank you.
Good afternoon. Chairman, permit me to stand on a already established protocol to present to you this interesting topic. It's a privilege. I'm a disease control officer, and when I was arriving from the main gate till the 2-day observation, I actually realized that my topic has already been discussed, and it's something that we've observed. So infection prevention is not something that is very strange to us. It is something that requires the support of all, not only health workers, but all partners. There are visible signs at the entrance where they can say, wash your hand here. You check around, there is nothing. There is no water, like the source is not really there. No nose marks, no entry. Observing this room, yes, we realize that visibly, nose marks is not really there like that. So gone were the days, early part of 2020 to 23, nose masks, the sitting arrangements, hand washing facilities would have been very strict, but here we are. So let's move into it. Okay, so this is the presentation outline from introduction through to some recommendations. So infection prevention is very critical in terms of quality of care and also safety. Within the healthcare settings, it is very paramount, and most institutions, they strive to maintain this. Though it is not always easy, there are a lot of factors that are embedded in there, and quality is actually assessed through this, and it's also subjective. It is the wish of every client visiting the health facility to get the desired outcome, at least with the conditions that they presented being attended to, without the risk of carrying any infection from the facility. It is the wish of every client visiting the health facility to get the desired outcome attended to. Infection house. And we are saying that it requires the support of all, not only health institutions, just like I was using. Where we are is a public facility, and we should try to maintain some precautions for others to follow so that we can all be very safe. So time passed, most of the institutions, Ministry of Health, Ghana Health Service, WHO, they've been trying hard to see how these guidelines, standard guidelines, will actually be adhered to by all. The health workers, healthcare managers, they all have a role to play. And the current situation is that there is still disparity in knowledge. You know, about understanding, the information that we get is different. I think today we had a presentation from our partner from the journalist side. Is it AMREF? Yes, I think it came up that for the sensitization, information sharing is there, but there is still that knowledge gap. And it also has to do with attitudinal. The laid down protocols are there, but are we really adhering to it? Because when we observe, when we went for lunch, we know wash your hand with soap and running water. Fufu is right there waiting, there is no soap. Would you wait for the soap? Okay, so we just continue with it. So these are some basic things that we need to actually put together to get the collective adherence that we ask for at all facilities. So hospital-acquired infections is one key thing that is coming up, and there is no institution or no country that has actually fought this. At least there are always some infections that are coming up even in the process of seeking care in our hospitals. We are saying that these infections, they are acquired at our health facilities. And it is because of some of these protocols that we don't adhere to. And hand hygiene is one critical aspect of it. The hands, as we see, they carry a lot of microbes. And we need to work on it. That's what the WHO has actually stated, that the hand hygiene is one of the major pillars of breaking transmission of nosocomial infections within our facilities. So there are a lot of health workers that are actually getting infected day in, day out with various forms of infections, and it is alarming. We need to take clue and come together to address this, because we need the safety of the staff, the clients, their relatives, and also the healthcare settings as we are. Because the more they get infected, they stay extra, it becomes a burden on us, on the relatives, they spend more, and it has implications as a country or individuals. So it is established that adherence to these guidelines are still low, and we need to actually work together. There was one study conducted at Rich Hospital by Higher Etel 2012. They discovered that, and this current study, which was done in the Volta region, was to establish something similar. This calls for more collaboration as a way of addressing issues of IPC. So we looked at some few things, trying to establish the objectives, overall adherence by all healthcare workers, and also specifically to look at among the trained staff, are they actually adhering to these protocols? and also to assess knowledge. Do they have some knowledge on the guidelines? And the guidelines, there are about 12 of them. Hand hygiene, waste management, there are several of that. So whether staff actually had knowledge on these protocols established. Okay, so we also wanted to assess whether there are some related factors influencing adherence. And that one we did the assessment from the staff level and also the healthcare managers, because they had a role to play in getting most of the IPC materials, the support, the oversight, supervision to ensure that these guidelines are being adhered to by all workers. Okay, so in terms of the study site, it was conducted in the Volta region, specifically in 7 government hospitals within the Volta region. Those days, Volta, this one, OT is embedded. As at the time the study was conducted, it was still one region. Okay, so in terms of the design, yes, it was just descriptive cross-sectional study. We just went in one point in time to assess the situation as it is. And also the study population limited to healthcare workers, specifically clinicians. Clinicians here, doctors, the physician assistants, other prescribers are included. Nurses, laboratory staff, cleaners, laborers, almost all cadres of staff were assessed to see their adherence at that level. So we had to define a scope, get a scope who should be included and who should not be. So we said that specifically those that had some training on IPC and available at the time of data collection. So yes, we actually looked at that, and those that were even trained but on any form of leave, whether maternity, annual, they were excluded. Okay, so we had 401 healthcare workers that were assessed, forming the sample size. In terms of the sampling, we adopted multi-stage sampling, where the regional hospital, now teaching hospital, was purposely selected, with the other 6 hospitals from the 9, okay, so as at that time, Volta region, there were 29 hospitals. 29 hospitals, so the rest, they were also classified under the North, Central, and South, and they were sampled. So systematic sampling was also deployed at the facility level to select the respondents. So in terms of the variables, yes, the adherence was the dependent, with other factors being the knowledge, availability, and accessibility. Availability here, if we take, say, soap for hand washing, as a university here, it can be within the facility, but it's not available at the point of use. If you visit our washrooms, you try to get soap, it's not available. But it doesn't mean that the facility or the institution, they don't have. So we realized that some of the materials were there, but not available at the point of use. Okay, so in terms of data analysis, we use descriptive and inferential statistics, and also try to be sure that most of the statistical standards were met. Epidata was used for the data entry and cleaning, exported to Stata for analysis. The results, yes, we came up that knowledge was really good, and this one we used the Likert scale with the original Bloom's cutoff to determine that range. 80 to 100% signified good knowledge, anything below 80, poor. So we came up that at least some, there was good knowledge, and the overall adherence was low, 43.9% among the 401 healthcare workers assessed. We also established that there was some significant relationship between marital status, knowledge, accessibility, and availability in terms of adherence. Yes. As in the process of collecting data, some 2 young staff ladies were asked the relation, why we were asking of marital status and things. And a very senior mother actually said that if you don't want to be bathing every night, don't marry. That means marriage had something to do with hygiene. It's good. Okay, so in terms of discussion, this study actually came up with a good knowledge specifically on the hand hygiene. As WHO said, it is the most singular pillar that is very effective in breaking the transmission. So it also established that about 95% of the health staff were adhering on the specific guideline on hand washing. This one was also similar with other studies found, and Higher Etel, they conducted it earlier, 2012, they actually found figures lower than what we discovered. But at the end of the day, they actually also supported the view that knowledge and other factors were related or associated with the hand hygiene or other adherence practices. So in conclusion, we are saying that yes, as established, the knowledge was good, but that is not to say that we have reached a limit. Even after this study, there were a series of trainings by Ministry of Health, WHO, even the era of COVID, where if you meet any other person, they can tell you more information about hand hygiene in particular. But adherence in particular is still low. And that is why we need to do more studies to be sure that at least most of the health facilities and staff are adhering. Availability and accessibility, they are closely related, or they have some relations with the adherence, and that is why we need to establish, because it is very significant. If you look at it, if the materials are not readily available with the knowledge and everything, they will not be able to adhere to that. Then the recommendations, we are saying that written protocols should be made available. All the 12 safety protocols, the precautions, they should be made available, accessible every point in time so that people can adhere to them. The hospital management should also ensure regular supply of water and other IPC materials. This is very critical because if we have a reliable water system, most of these protocols, even with the knowledge, they should be able to adhere. And we are calling for continuous trainings on other stakeholders for most of our staff on IPC. And okay, so healthcare leaders should also supervise, because it takes that commitment to be sure that the staff are really adhering to that. And we also call for further studies, because the time that it was conducted, and even post-COVID, there are a lot of things that have happened, and we need to now do more to evaluate the situation as it is. Thank you for the time.
Thank you very much. So from washing our hands in the Volta region, we move on to listening to the Bono story, that is decline in institutional maternal mortality ratio, and that will be presented by George Asari. Please give him a hand.
Thank you, Director, for the opportunity. My name is George Asari. I'm here to tell you a story about how we were able to decline institutional maternal mortality ratio in Bono region. Bring you greetings from my regional director, Dr. Mokodie. So, we know maternal mortality remains a global burden, and especially in low-income countries. Over 260,000 maternal deaths recorded globally in 2013. Out of this, 92% of these deaths in low and middle-income countries. And we know that reducing maternal deaths actually saves families, communities, and the economy. In Ghana, our average maternal mortality for the past 5 years has been around 310 per 100,000 live births, which is still below the SDG target, which is we are looking at 70 per 100,000 live births. Bono region, we have made a significant progress since 2016 to 2014. And averagely, we have done within the 5 years 72.5 per 100,000 live births. Our single objective was to look at or describe the efforts that we put in place in the region to reduce the maternal mortality. Data sources and the methods. This is a retrospective descriptive study. We look at we review 9-year trend that is from 2016 to 2024 of our maternal mortality ratio. We review activities that were targeted to reducing maternal mortality. And our data that we picked were from DEMS 2. And we also look at activity reports, workshop trainings reports that has gone all over these years. We actually also did a trend analysis using simple SL2. And this is a part of our routine operational research and public health surveillance we have placed on maternal mortality. So this is the results. You see from 2016 to 2024, you have seen that there has been an over 50% reduction of our maternal mortality. That is from 124 per 100,000 live births to 60 per 100,000 live births in 2024. When we look at the trend or the linear regression analysis we did, it actually indicates that we were actually reducing the maternal mortality 7.4 per 100,000 live births annually. But there was a spike in 2020, between 2020 and 2021, and we could actually attribute it to low utilization of services during COVID-19. And we have another research that actually confirmed that utilization of maternal and child health services came down during that period. We think that, but overall, we see that there has been a very drastic decrease in our maternal mortality from 2016 to 2024. That's a 50% reduction. What actually led to this improvement? We actually established a maternal mortality task force, and the responsibility of this task force was to look at all audited reports from reporting facilities. We review it at the Regional Health Directorate, look at how the case note was written, the cause of death, and the recommendations, whether it aligns to the deaths. And we want to ensure that all the recommendations that were actually written in the audit reports are implemented and timelines are given. We also conduct zonal maternal mortality audit meetings. We have zoned our region into 4, where we bring together facilities, referring facilities, and facilities reporting maternal mortality together. We discuss the deaths, the issues surrounding any death that has occurred in the facility, how the referral was done, and recommendations are given. We also ensure that all the recommendations are followed and actually implemented. There was also point of care quality improvement training. We ensure that at the point of care that services are provided, we did quality improvement. Quality improvement teams were formed all over the region, ensuring that they picked up projects, look at their data, and actually ensure gaps are identified, especially in the area of maternal mortality, and try to solve them. Life-saving skills and obstetric triaging trainings were also done. There were regular coaching visits to facilities with their quality improvement teams to ensure that they are adhering to the recommendations that they have given and also adhering to timelines. We try to strengthen quality improvement, set up quality improvement team, focus training on respectful and data-driven maternal care, real-time assessment and action plans at the facility level. We also ensure there's a boost in emergency skills, where we trained midwives and nurses on life-saving skills. And I must say this training was supported by National Association of Nurses, Registered Nurses and Midwives. We also focused on the area of emergency childbirth, postpartum hemorrhage, and neonatal resuscitation. Facility-based action plans were also developed during those trainings. Using triaging to also save lives. Obstetric triaging and implementation package, popularly known as OTIPS, were also used with modified early obstetric warning signs known as the MEOWS chart, were also introduced throughout the region. And over that, we were able to train over 189 midwives across all districts. There was also early detection and response to maternal complications, also to improve services. However, we came across some challenges which we are trying to work on. We have irregular meetings with the quality improvement teams, incomplete documentation, especially on the maternal mortality audit, equipment and staffing gaps in high-risk centers. This is also an issue that is faced by the region. The use of data for decision-making is also another challenge. In conclusion, we also want to say that institutional maternal mortality in the Bono region dropped by over 50% between 2016 and 2024. Success driven by leadership task force, audit, and skill training given to our staff. We have strong support from WHO, UNICEF, and other partners who supported us in quality improvement trainings and life-saving skills. We realize that COVID-19 also served as a weak point for us, and why we have issue with the maternal deaths in 2020 and 2021. Data gaps, poor documentation, and equipment shortage also persist in the region. We recommend for quality improvements, meetings, and audits to be strengthen the use of data and documentation for decision-making. We wish to expand coaching and mentorship, and this has actually helped us in reducing maternal death, ensuring availability of triaging tools and emergency equipment geared towards reducing maternal deaths. We also wish to deepen our collaboration with partners like WHO and UNICEF to improve maternal deaths, maternal mortality. We acknowledge these people, my regional director, my team at the Regional Health Information Unit, the Maternal Audit Task Force, PPMED, Ghana Health Service, WHO, UNICEF, and the National Association of Registered Midwives, who supported us in this our effort. Thank you very much.
Thank you. Let's give him a special clap. He saved us 5 minutes, actually. So we move on to our last presentation for this session, and that is Healthcare Quality Improvement Journey with Advanced Safe Care Tool, the case of Kintampo Municipal Hospital in the year 2024, and it will be presented by Shaibu Isifu. Please clap as he comes. Thank you.
Good afternoon. I'm standing on the existing protocols established. Yes, like they mentioned, I'm here to present on healthcare quality improvement. If you took note of all the presentation this morning, one common thing or one common denominator is quality, quality, quality. But this presentation, I'm sure probably that's why it is last. So we are squeezing out all the quality from all the presentation and concentrate it on this presentation so that we can all go home nicely. So I am presenting on behalf of three authors. Our boss, Dr. Anthony Chum, is here, and the other co-author, Issa Sumela, is here. You can give the crowd a wave so that they know that you are here. So I'm well covered. So there is a new introduction, Safe Care, Advanced Safe Care Tool. So now one will ask, what is Advanced Safe Care Tool before even I come to the whole thing? So if you look at Advanced, it's a tool for assessing quality, and this is comprehensive quality. Quality should not be in piecemeal, where if you are doing clinical care, right from entrance, reception, HR to accounts unit, there must be quality. And quality is established through standards and protocol. And that is what I'm talking about, because this one covers everything, including mortuary. So we see it here. This tool was jointly produced by COSASA. If I talk about COSASA, I'm referring to the South Africa, the Council of Health Service and then Accreditation, that's in South Africa, and JCI, that is Joint Commission International of USA. They are also in charge of quality. And it has actually been accredited by ISSER. If I say ISSER, that is International Society of Quality in Healthcare. They produce this tool called SafeCare for measuring quality in healthcare. So this is the presentation outline. Yes, the thing will be centered about this certificate you've seen here. It's a very important tool I'll be talking about. That is why it's actually in the first page, as you've seen. So we are saying that every year annually, about 8.5 million people die. These are real human beings through poor quality healthcare or inaccessible healthcare, the two put together. And we are saying that out of this number, 60% can be attributed to poor healthcare. So those who are not coming, they said, oh, we don't have access to healthcare. Only 3 million die. Those who are saying that we have healthcare, the healthcare that ends up killing 5 million. This is data on WHO website. And we are more suffering. And if you come down to our sector here, it is even worse. 15% of all IGF goes into poor healthcare. Either you didn't give the right medication, somebody extended period in the healthcare. 15% of all IGF is spent on needless issue that quality could have resolved. Then we are also saying that if you look at quality, it's very costly. If you look at our story here, the Ridge Hospital recent ruling, if you look at Joabin Government Hospital, the recent ruling, these are hard cash. We are talking about 7 million Ghana cedis that the service had to face because of poor quality healthcare. In one of the cases, there was actually a protocol, but that was not adhered to. So the people actually snapped the protocol and took it to court. That this is their own document we are bringing to you. So this is how quality can cause the Ghana Health Service. Imagine you taking your car to a mechanic with an exhaust issue, only to end up your engine being destroyed. So people come to the hospital with malaria, they are going home with pneumonia or tuberculosis. That is the cost of quality. So the objective here is to tell our journey in Kintampo Municipal Hospital using the advanced SafeCare tool and what we saw out of it. Now, before I even come there, the SafeCare, when they were speaking, I think director, and let me pay a glowing tribute to him because he's the founding father. I'm talking about director Adumako. It was his time SafeCare was introduced in Bunu East. He's the founding father of that region. And it is not a small journey. You see, he asked a question that we are talking about input in quality. What is the process? In fact, the SafeCare looks at 3 models. We call something Donabedian model for healthcare quality. And it looks at the structure, which is the equipment, everything. It looks at the process, and it looks at the outcome. So once you are using SafeCare 2, it means that you are looking at these 3 things at a glance. All right, so what did we do? The facility had to reinforce its quality improvement team with staff from all sectors. So we have somebody from administration, human resource, the administrator himself was part, somebody from public health unit, the estate, everybody, so that we have that complete salad of people to take care of quality. So we had that put in place. Then also, and the clinical coordinator was actually the head of the team who reports to the MESUB. And the MESUB also made it a point to always join the quality meeting, which was held almost every week to discuss issues that we had discovered. Then inside that, we said we needed a nucleus. So why don't we have 3-member committee that will be reviewing the work of the quality improvement team to see whether they were on track or they were not on track. So these are some of the measures we put in place. And monthly supervision, it is not fault finding, because you see, if somebody is pricked by the needle and you blame the person, you are not blaming anybody. If you bring a different person there, the person will be pricked by the needle because it is a culture. So when somebody reports something to you, we don't look at the person, we look at the system. What might have gone wrong? Probably everybody is doing, he was not fortunate and he has been pricked. And that is how we approached it. So you realize that everybody was getting on board. We were producing monthly reports and scoring the various wards per the tool we had developed internally to supervise them, waiting for external supervision. Then copious action plans were produced. Anytime we come to your ward, we all agree on the issues. we do the action plan. We have work improvement committees in the various wards. They take it up, they work, and they report. So the timeline is being monitored. And you see we have QPP. QPP is a platform for monitoring. So once the Safe Care Advanced Tool is used to assess you, they create what we call QIP. And QIP is Quality Improvement Plan. So that Quality Improvement Plan is actually on the app, which is the QPP, the quality platform for providers. So anytime you go, you see the recommendation. So we don't have to now stress to use fishbone analysis, to use, the problem tree, or the 5 whys to find the root cause. The root cause has been identified using the Safe Care tool. Yours is to do the implementation and then see what works. So that is what we're doing. Now, after all these things, then the Safe Care team, and let me give a little background. It was introduced in 2022, and the pilot were 2 regions. Ghana Health Service actually introduced that pilot in 2 regions, which is Bono East 20 facilities, Savannah 20 facilities. Now, in last year, which is 2024, because of the successes achieved, it has been scaled to now 10 regions. It means that 8 regions have been added, 6 more yet to be added because of the successes we chalked. Kintampo Municipal Hospital is the only facility currently in the country that is on advanced Safe Care tool. The rest are on rating. So that we can say that even in all the 10 regions, the Kintampo Municipal Hospital is outstanding now on advanced Safe Care. And I'll tell you why. Because we have 3 tools for assessing. And we have what we call the self-assessment tool. That is 45 questions. And then we have the rating. The rating is and the self-assessment is for the CHIPS compound, for them to do their own self-assessment. Then we have the rating for health center, polyclinic, and hospital, district hospital. Then the advanced, the rating has 170 questions. And then the advanced has 680 questions. That is 4 times that of the rating. So you can imagine the load you carry on your head if you are to use the advanced Safe Care tool. And it measures 13 areas we call the service element, right from governance and management, human resource, up to support service, which we are talking about food. If you have food services there, all of them will be assessed using this tool. Now, after we placed all these things, the people came in 2022. That was the baseline assessment. We scored 38% overall with a certificate level of level 2. That is not something out of 5, 2 out of 5. That wasn't something we should be proud of, isn't it? They came the following year. We were hoping that we were going to do better. And we scored only 42. That is 4 points increment. The same level 2 certificate. So 2023 or 2024, we placed in the measures I have mentioned already. Then we saw things started changing. Because the QPP, anytime you perform a task and you put there, it gives you a percentage. So if you get to 100%, it means that you are done with all the tasks assigned to you by way of quality. And after we put all these measures, ladies and gentlemen, 2024, they came and the people were shocked about what they saw. And they professed it with their own mouth that they were surprised about what they saw. We had moved from 42% to 73%. 31% increment. And now we didn't go to level 3, we moved to level 4 straight. That is like jumping somebody in one class. And that is what happened in 2024 after we placed all these measures in place. And surprisingly, all the service element improved. 2024 is what we see in yellow. And you realize that the 13 service element, the first one being governance and management, the second one being the human resource, the third one is talking about patient and family right and access. We have the 4, which is the information management. We have the 5, which is the risk management. We have the 6, which is the outpatient, 7, inpatient management, 8. We are talking about the 8 here is surgery and anesthesia. We are talking about 9, which is laboratory services, 10, diagnostic imaging. And then we are talking about 11, which is medication management. Here we don't use pharmacy because medication transcends pharmacy. So we're talking about right from the pharmacy to the ward. How do you monitor it? How do you keep the cold chain? The pharmacy store, do they have monitoring temperature? Do they have AC? All those things have to be assessed to the granular level. Even the mortuary, do they keep a code? Do they maintain the chart? Because if they don't maintain, then there's something wrong. The people who come to do the cleaning, do they use the same mop to mop the veranda and use the same mop for the ward? In that case, we are spreading infection. We are not rather controlling the infection because the ward is highly concentrated. We are using one mop. So if you are using separate mop, are the mop color coded? In fact, if you go to the theater, does the theater bed, does it tilt sideways? Can it assume Tredelenberg or reverse Tredelenberg? All those things are part of the 680 questions we have to assess you on before they can come with a particular score, that this is your overall score. And let me say this one to the glory of God, that even out of all the several facilities we have in Ghana, apart from we being advanced and we have secured 73 unprecedented score, the best in terms of the rating have been 65%. In the rating, those they use 170 questionnaire, the best anybody has scored as it stands now is 65% in Ghana Health Service, and we are still cruising in a comfortable lead. So, we conclude that with commitment, leadership, and investment, quality is something that is achievable. Quality is not standing somewhere and we are doing the work somewhere. In some facilities, when you go, they say that quality for now. But everybody, including the customer care, the receptionist, the cleaner, everybody must integrate quality. If you have an autoclave, what are the protocols that you have? Do you have a protocol? Is it that when somebody like he put the thing there 5 minutes, another person comes to do 10 minutes, another person do 30 minutes, or how do we do it? So you must produce a protocol to govern all aspects of your operation. And I'm sure you saw it. Before they came, we had produced over 80 SOPs and guidelines, and this is not one-page document. Some of them span 30 documents, including even occupational health. How are the human resources being catered for? Do you have their interests at heart? What are you doing for them? All those things are part of the guidelines we produce, and it is not like you download somewhere. You have to customize it to suit the facility and its resources. And ladies and gentlemen, we did that, and we are recommending that safe care is a good thing. It can be scaled up across all facilities, and with proper adherence to rate quality, we can achieve it. And 8.5 needless death, Ghana will not be counted as part. Medical legal issues will be far from us, and we'll be in a better country, in a better health system. Thank you so much for your audience.
Okay, so thank you so much to all our wonderful presenters. Can we give them another hand of applause, please? So we'll just have a short discussion. So we'll start, I'll take the first few questions. So I'll start from this row, and then we'll move. Any hands from this side? Okay. Okay, so we have 2 here. Any hands from this side? We have 2. Any hands? Okay, 2. So let's start from, let me give you the mic.
Yeah, thank you very much.
I think it's working. It's working.
All right. Thank you very much for the opportunity. I must say this last batch of presentations were on point. But my question goes to the one who presented on the IPC. I think after they were done with the chi-squares, I was hoping to see them doing regression analysis to tell us the strengths of the associations. Because sometimes you do your chi-square test of associations, you get some associations, but then once you do the regressions, you realize that those associations are actually spurious. So I think next time, with such presentations, once you are done with the chi-squares, kindly take a step further to do the regression analysis for us so that we'll get to know whether the associations that we saw in the chi-squares were real associations or they were just spurious ones. Thank you very much.
Thank you. So the next, yeah.
Thank you so much. So, yeah, I also enjoyed the presentations that have been carried out so far. I will first want to ask the first presenter. So, I realized that the study, I'm sure they just use secondary data from their records to carry out the study. Because I think that if they had to do some primary data collection, I'm sure some of the findings that they got would have differed. For instance, if you look at the fact that there were low registration for pregnancies, I'm sure that obviously if you take women who have had previous births, comparing to those who are pregnant for the first time, there's likely to be differences in how they treat the registration of pregnancies. And then they also had timelines which shows that by the 13th of June to the 13th of October or so, that's 3 months period, then they were able to see an increase in registrations. But so this one makes me ask that how is it that people were pregnant waiting because it looks too good? Because if within a 3 months period you can get a number of people who are coming to register first-time pregnancies increasing number, it's just as if they were pregnant waiting in the house. Then after their education or whatever, then they started coming out to register their births. So I think that if they could go on to look at, it's very interesting, honestly, but if they can go on to do some primary data collection, then I think that we can get more evidence. And then I also want to largely inquire from the regional directors of health. I think that usually in research, you don't kind of set the questions and then also answer the questions. But largely, over the last 2 days, I've realized that a lot of the regions do their own research questions, interventions, evaluations, which, for me, I think that if you engage independent evaluators, it makes the findings more strong, and then I think that then it gets the buy-in of a lot of people. Thank you.
Thank you very much. I'll kindly ask that let's make our questions quite snappy so that we are behind time.
Mine is just a comment. According to the last presentation, he had mentioned about involvement of management team when it comes to quality. Where I come from, Malawi, I've noticed that if you have a quality focal person who is doing the work in isolation, not involving the management, most of the times it does backfire. But nowadays, since we're talking of quality, I've seen that if there's that engagement, buy-in from management, because this is, it's a process, you need lots of resources, because for some of these activities that are in quality, you need resources. But if you don't engage with management, it's quite challenging. So very, very important that whatever we are doing, all quality activities, management should be abreast of that, and it works that you can see in the strides as we're showing that now around 64%. Very, very important. Thank you. So I just want to make that comment.
Yeah, thank you very much. My name is Dr. Foribuedu, Director responsible for Institutional Care, Ghana Health Service. I think I'm not actually going to ask them questions. Otherwise, it would be like a headmaster asking his own children questions. Because most of the work they did was within our institution. which I superintend part of the clinical services and the quality of work. But what I must say is that I want to stress on the last presenter about the safe care quality tool that has been established and the request that we should use it. I want to just reassure you that we are already using it. Because Dr. Adumako is aware that when the pilot was over in Savannah and Bono East, the service adopted it, and that's the reason why we have trained 20 assessors within the 10 regions that we are now practicing it. And the good thing is that it cut across the various segments of care. He mentioned it, even mortuary. If you want to see the quality of care in mortuary, it has its own protocols, you must go through it. And we are hoping that we are starting from the sub-district level with the network of practice within the service to strengthen the primary health care area. And we hope and believe that the successes that were identified in Savannah and Bono East, when we go to the sub-district level, we're going to see this improvement in our quality of work. And therefore, it will move not only staying at the sub-district level, but it will come to the level where we are going to even apply the advance in the secondary facility level. So we are really on the ground, and we hope that this quality improvement assessment tool will be used as part of our improvement model in the service. Thank you very much. You have all done well anyway.
Thank you. So the next.
Thank you, presenters. My question goes to the presenter for quality improvement, the antenatal related issue. In the recommendation, you did mention that you want to scale up the pregnancy testing at the OPD of every woman that reports there. Now the question is, it's not every woman that may want to keep pregnancy that have just started. So are you going to maintain that, or there are going to be other determinants that you'll be using to complement this initiative? Thank you.
Thank you. So we have the last question from Director.
Hello. King Tampo, you didn't add my name to the paper. you know, this program was from pharmacists. They don't work in Ghana Health Service. They work in private. So I met them at La Palme, and I told them that, look, they should bring this safe care to Bono East. And that's how safe care ended at Bono East, and the others survived. And you didn't put my name there.
They will put it there.
Okay, so you have to put my name there. Okay, so that's how come it has been adopted and we use. But my comments really go to the ANC and the other quality. I saw that, go and look at them again. For the table, you made it the problem identification. It's prioritization. And then even if you look at your problem, you just picked a lot of problems which were not related. Please look at it. The run chart, look at it very well. I just want to also ask Bono, you gave us a lot of interventions. That intervention in reducing maternal mortality ratio, is that all the interventions for all the districts, all facilities? You have to be able to come up, let us know in part where the problems were really coming from. That's one. And which are particular activities, because as we are here, you have been able to demonstrate it in your context. If I want to go and adopt, you should be able to give me the specific processes that you did. And so in the two presentations, I realized that most of that, we didn't even test. I don't know whether you are presenting testing, or you are presenting implementation, or you are presenting what has been sustained. These are comments that I am giving. Thank you.
Okay, thank you very much. I think our presenters, some of them were comments. We'll probably just respond to, we can start from Madam Eunice, our first presenter then.
Thank you very much. I think the question of the UPT testing, We at Kogo Health Center, we are not saying that when our clinicians do the UPT test and it's positive, we go right away giving the client an antenatal card. We are saying that when the clinician identifies that, the client is referred to the midwife to be talked to, so that if the person is ready to start, then we go ahead. We don't do the UPT and right away you are enrolled. But I think that has really helped. Thank you.
Okay, thank you very much. Mine was not really a question, it was a comment. So I actually showed the full analysis because of the limited slides. We actually did the regression by variate and multivariate, and I've actually shown it to him. So thank you for the inputs.
Okay, thank you very much. For Bono region, what we did is like you realize that now, from 2026, from 2016 to 2024, there has been a drastic reduction in our maternal mortality. This is interesting. Now we said, what did we do to be able to achieve that? So we went back, looking at our records, our training reports, so it's like a retrospective study, looking back what we did, synthesizing all of them together to tell a story. Okay, so that's how we do it. But the intervention that we put in place, sorry, I didn't mention, it was targeted to facilities reporting maternal deaths. So we identified the facilities reporting high maternal deaths, high neonatal deaths. Then the interventions were targeted. So if you are doing training on life-saving skills, we call participants from those facilities, those who refer to those facilities, then we train them. So that is what we are doing. It wasn't like testing a change idea, like starting a quality improvement project, but we went back looking at our records, what we did that has resulted in that drastic achievement. Thank you very much.
I think mine were largely comment, so I have to appreciate all those who commented. My good friend from Malawi, when we are given a small position in our various units, let's try to make management part of it. Because if your manager is there, you are the quality person, you do your action plan or whatever of the year, program of the year, then you float it on the platform. He has seen or she has seen, but you won't get the feedback. But if you were to push it to the person back door, please look at it and then make the necessary modification or suggestions for improvement. Once the person does that, there's ownership, and the person is bound by it. But if you are doing your own thing, no manager will commit to it because it comes with money. But an investment in quality has a lot of reaping. You won't see it, it's not material. Okay, if people are spending less, efficiency, effectiveness, timeliness, all those things are money we can't quantify. So thank you so much, all of you, for your... And Director, sorry once again that your name wasn't there because I acknowledge you are the father of the safe care, and that must be said and said loudly. Yes. And then the Director, ICD, I know what you are doing actually. You are doing very well in terms of the safe care. Now to 10 Reggie.
So
well
thank
noted,
you
Director.
very much. Thank you very much to our excellent presenters. I think I'll invite the Director PPMED to just summarize our session for us.
Thank you very much. I think it's been a very great session, and the presenters and the audience deserve a big round of applause. Let's applause. You've done very well. Time is not on my side. We will try to be brief. I think we heard a lot. Although I'm in the Ghana Health Service, listening to all this innovation is quite impressive. From Upper East, my region, listening to Eunice. Eunice, we heard you in terms of efforts in quality improvement to improving the first trimester pregnant registration at Kulugu Health Center. Over the period, you were able to achieve what you and the team wanted. That's the 60%. You achieved it. And in terms of policy, I think first and foremost, across the districts, your municipality, Upper East region, then the country. So there's still more work to be done. And we hope that this quality improvement in terms of the terminologies, the understanding, will become commonplace knowledge for all staff. So that is what we wish for that. So that is very good. We commend you for all the good work we've done. Then we came to the second presentation by Samson Obripo, Adherence to Infection Prevention Control Guideline by healthcare workers in the Volta region. I think for those who know about COVID, when COVID-19 came, I think for that period, there was nothing like cholera because, especially the men, they say we don't do well. We all abided by the rules of engagement. For us as regional director, and our concern was after COVID is gone, will we be able to maintain all the Veronica buckets, all these practices? And it looks like we've not been exactly been able to do that. So it's good that this study was done to look into adherence to infection prevention control, and it came out clearly that we are not doing very well at all. I mean, whatever the hypothesis you put was confirmed. And you ended by saying that there is a need for leadership. That is the facility in charge, the district directors. For those who are familiar with the WASH field too, I'm also a WASH advocate. Realize that you assess yourself in terms of the traffic color, red, gold, and green. It's good that you assess these WASH field indicators. It's very, very important. Sometimes when there are outbreaks, when there are challenges, we do well, but when it's over, we forget about it. What even paid me was that the Veronica buckets, it's an English name. I think that the lady is called Bequin or something. We need to look at some of these things. It should have been a Bequin bucket or something. These are things we really need to look at and patent. That's why sometimes our kente is found on international market and it's used for tablecloths. They did very well and it was very helpful. So for IPC, I think I agree perfectly with you. The guidelines and protocols should be available. When you go to hotels, sometimes it's written, flash me. All those things are very important because when it comes to human behavior, it's very complex. You have to keep on reminding the person to do all the good things, and this comes with the leadership. The guidelines should be available, and leadership should drive it. I also want to that the community, those who come to our facilities, should be really, really involved. Now, on the third presentation by the Buno, in terms of decline in institutional maternal mortality, he went on to say Ghana is around the 300 per 100,000, and you move from 120, I think, which year was it? 20 what? 16. To about 60, that was over a 50% reduction, which for me is quite significant. And you mentioned very important, when it comes to maternal mortality, we need to be very deliberate as leaders. We can talk about the causes, pregnancy, induced after AP. It's about S. What do we do to change this thing? You mentioned leadership. You mentioned the fact that you had established maternal task force, yes. You were meeting regularly. You talk about OTIP, life-saving skills, etc., etc. So it's important that at all levels, at the regional, district, facility level, our doctors are here. We need to be committed because sometimes that's why doctors in the past were dying very early. You go home at 1 day and you call at 3 a.m. But if you don't go, somebody will die. That is a challenge. That is why we need to be well taken care of. So we are going to do that to make sure that no lady or woman dies out of giving birth in terms of the perpetuation of the species. That is what they are doing. They have got divine duty, and we should assist them that those things don't happen. You mentioned so many things, we wouldn't want to go into that. Then when you come to my handsome brother Chum with Issa and Shaibu, Chum, can I have your attention? What your regional director said very instructive. As regional directors, we are very busy supervising and monitoring you. Under no circumstance should there be a publication without writing. So when you go and do the needful. And as director of PPM, I'll be following you to check that you bring first name. Every district, everywhere, the name should be inside. So that is why Kologo Health Center, I was here, you see? Your name should be there. And he raised a very cogent, which I agree, in my closing remarks to come. That we can all become astute researchers. Hello? Are you with me? Clap for that, because it's very important. So that you too, maybe small, we can also become some little professors. Is that not it? Otherwise, we will never be. That's the problem. But I think it was quite instructive to know that they have distinguished themselves with this country. And I'm not surprised. Because I was in Ahafo, and now we was in Bono. We were called ourselves 20. And when it comes to quality, as far as back is concerned, I think he is actually a legend. Let's clap for him. He's a legend. So no wonder you are doing so well and you have distinguished yourself. We want you to keep it up and just don't want you to be in Kintampo Hospital. We want you to be across all the hospitals in Bono, Ahafo, in fact, all the regions of Ghana. So, Chum, I'm looking at you. I know you are doing well, but it's not enough. When you do well, others too should do well. So that is what I'll leave to you. So I think that we've learned a lot. I'm hoping that the presentations will be shared for us because they are very quality presentations so that we can follow from there. On that note, on behalf of my co-moderator, Dr. Salah, thank you for your attention and supporting us. Thank you very much.
Thank you very much. We are now waiting for our colleagues who were at the RIPS seminar room to join us, and they are coming. So let's give them like 1.5 minutes. They will be here with us. In the meantime, in between time, the current debate is about post-retirement contracts, and that makes me happy. So there was this professor who applied for a post-retirement contract, and so he checked in with his head of department to know the status of his application. And when he entered, the head of department said, "Welcome, Prof. Please take a seat." So he sat down, and then he said, "Prof, I have sad news and good news for you. Which one would you want to hear first?" And you know, professors, they ponder over things before they answer. So he said, "Well, if it is good news and sad news, maybe we should start with the sad news, because from there, things can only start getting better." Then the head of department said, "Prof, I'm sorry, but your application for a post-retirement contract has not been successful." He said, "Okay, fine, now tell me the good news." Then he said, "Prof, over the last 32 years that you have been here, you have produced 5 professors, any number of PhD holders, and these are capable of taking over from you. So we are grateful for what you've done for us." Is that good news or bad news? Yes, so our colleagues are joining us. Is Professor Adokia in here? Okay, so we just give him a few more minutes. So as we wait for Professor Adokia and his team to join us, those who were at the RIPS seminar room, are you here? They are coming? Okay. So we'll just give them a few minutes to arrive. So as we give them a few minutes to arrive, let me tell you another story. There was a bone of contention between 3 people about who should become a chief of a certain community. We had the chameleon, the frog, and the kingfisher bird. They will all say that we are the oldest in this community, so we ought to be given the leadership. So they ended up at the Paramount Chief's Palace. Okay, so you narrate the story. Then the chameleon was first asked to narrate the story. How come that he thinks that he's the oldest and should be the elder? Then he said, you see, when I walk, I take very slow, gentle steps. It is not for nothing, it is for a reason. When I was born, there was a great flood. And when the water subsided, the place was so muddy that if I stepped hard, I sank. So I learned to walk with very slow steps. That's how now I've got used to it. Even when it's on hard ground, I still walk like that because it has been ingrained in me. So that's his story. So I think that I'm old enough to be the chief of this community. And then they said the frog. And the frog said, well, Chief, you see, you know the IHOP. That great inundation that he's talking about is true. I lived through it. And at that time, when the water subsided, there were just small pieces of rock here and there, so I would hop from one rock to the other. So I'm used to hopping now. So that's how come I think that I'm older than everyone else. Yes, Professor Doke is here. In 2 seconds, he would acknowledge him and then we'll move on. And then they said, okay, the kingfisher bed. Maybe you don't know the kingfisher bed, maybe you do. But it has some bushy hair. Then the kingfisher bed said, the inundation they're talking about, he's talking about when the water subsided. At that time, the whole place was flooded. And my mother carried me on her back, and we're flying and flying and flying, waiting for the water to subside. And when she died, there was nowhere to bury her, so I buried her on my occiput. So if you see the bushy hair on my occiput, that's my mom's grave. So if you were the paramount chief, who will you give the chieftaincy to? That's a subject of research. So welcome back to the closing ceremony. My work is very short, is to introduce the chairman for this session, who is none other than our very own Professor Bawa, who is the principal investigator for the African Health Initiative Community of Practice, and also the director at RIPS here in Legon. So Professor Bawa, the audience is yours. Thank you very much.
Your phone is here. Okay, thank you very much. I didn't know 2 days would come this soon. When we were planning this, it took us several months, but 2 days is already passed without noticing it. And we are at the end of the program, which is to close the conference. And so thank you all for coming. I know there will be vote of thanks, but let me start by thanking you all for coming. I think you would all agree with me that it's been a very productive 2 days, and I think that the time spent here together was, in my view, well spent. So for this closing ceremony, there are about 5-6 agenda items. The first agenda items is to observe a moment of silence for Ms. Lola Adedikum. I'm sure in the course of the 2 days, some of you would have heard about Lola, and I will tell you a little bit about her. So we are going to observe a moment of silence for this young woman who died very young at the age of 42, but those 42 years were well spent, in my view. Very short period, but were very well spent. So let's observe a moment of silence in honor of Lola, and I'll tell you, so if you can all stand up. And so let's have 1 minute moment of silence, and then I'll tell you a little bit about her. May his soul rest in peace. So you can sit down. So I want to take this opportunity of this conference to remember Lola. Lola Adedikum, we call her simply Lola, died last year, but until her death, she was the executive director of the Aspen Global Innovators Group at the Aspen Institute, and a co-chair of the Aspen Institute Forum on Women and Girls. The Aspen Institute is in Washington, D.C. But prior to joining the Aspen Institute a few years ago, Lola was the director of the Africa Health Initiative at the Doris Duke Foundation, the foundation that is supporting, or the foundation that supported this conference as part of the activities of the community of practice of the Africa Health Initiative. So prior to joining the Aspen Institute to become the executive director, she was the director for the Africa Health Institute at the Doris Duke Foundation. She spent about 14 years at the foundation, and during the course of those 14 years, she was part of constituting the Africa Health Initiative. And when she became the director, she made several grants to several countries in Africa, Ghana, Ethiopia, Mozambique, Rwanda, Zambia, and I think those 5 countries. And over the course of 10 years, she was embedded in this work. She spent a lot of time traveling to these countries and supporting the work of the Africa Health Initiative. And so this is the person that we are remembering today. She was an advocate of social change and sought to nurture and empower local leaders to reduce inequality, strengthen communities, and enable individuals and families to lead healthy, vibrant, and self-determined lives. This was this young lady, and she dedicated most of her life to ensuring that this was done. So the Africa Health Initiative, which she led for several years, aims to strengthen health systems in sub-Saharan Africa by supporting partnerships and large-scale health systems in primary health care. Lola was a very strong advocate for what we call embedded implementation research and promoted this activity during her lifetime. She actively participated in the work of the Africa Health Initiative throughout the period that she was the executive director, and was instrumental in the creation of the Africa Health Initiative Community of Practice, which is the work that we are carrying on today. The Community of Practice, after several years of showing that if you strengthen health systems, you will improve life, she then said, to sustain this activity, let's create a community that would continue to nurture this idea of promoting health systems. This time, not doing the hardcore research and science, because we have already demonstrated that it works, but to create a pipeline of researchers who will take implementation science as a vocation, and then to continue to advocate for implementation science research to promote the development of health in Africa. And so she helped us to establish this community of community of practice, and got the foundation to provide us funds, initial funds for 3 years to do this. And this is the person that we are remembering today. She died very tragically last year, and I believe that if she was alive, she would have been here for this conference. So let's all remember her in our prayers, and we will continue to advocate for what she stood for in her life and make sure that her memory never dies. So thank you all, and we'll continue with the rest of the program. So the next agenda item that we'll take is the award of posters. you would see that we have we set up posters outside, and we had a team to go around to evaluate the posters and to grade them. So we are going to award the best 2 posters, and to do this, I would like to call Dr. Edrana Baini, who is the chair of the 2025 Health Systems Innovation Scientific Committee. She led, the evaluation of all the abstracts with the team, the scientific committee. She led the committee to evaluate all the abstracts for this conference, and you would all agree with me that they did a very good job in selecting these abstracts. So, Edrana.
Thank you, Prof. Bauer. And as Prof said, it's the team effort. So it was a scientific committee that did it all. So please, an applause to the team. Okay. So as Prof said, we're giving out awards to 2 of the best posters. So they are the best because of certain criteria, which I'll mention. But we thought it fit that those who wanted to present posters, we wanted to at least award them for it, just as it's done in other scientific conferences. So we awarded them based on 5 points. So the first is content quality. So this is in terms of their content, so problem statement, research questions, meaningful conclusions, and so on, the implications that they drew out from their study. And then also visual design as well. So how just the poster looked, how things were laid out, if there were any typographical errors and so on. So that was the visual design. Then the data presentation. So this is how the data was speaking to those that awarded the marks, our scorers. And then the engagement, how the poster presenter engaged with their audience. That was also one of the criterion on that was scored. And finally, overall impact of the study. So that was the criteria we used to award our poster winners. And we have 3 judges that scored. So I don't know if the judges are here, Dr. Charlotte Ofori, Dr. Yao Atiglo, and then Dr. Aaron Christian. If they can just wave. Okay, so yes. Okay, they're here. So they are the ones that, after many deliberations, they came up with the winners. So our 2 winners, hopefully they're here. So should I start with the top scorer or the runner-up? The runner-up, okay. So our runner-up, the person, should I mention the score? No, okay. So our runner-up is Emanuela Enam Goodwillman. So I don't know if she's here. Okay. So Emanuela, please. Okay. So then, okay. So our top scorer is Frank Opong Kwafu. Okay. Okay. Okay, so well done to them, and you can hear from the screams that it's well deserved. Yeah. So I also want to take this time to mention that we have a number of early career researchers that so their papers got accepted. And let me say that it was a rigorous process in choosing the papers because we had over 100 submissions. And after taking out those that were not English and other factors, there was a lot to consider. And so for these early career researchers, people that have just finished undergrad and they're waiting to go to do their masters, for them to have been accepted, then it's a big deal. So we owe them a standing ovation, all the early career fellows. From the University of Ghana, from UHAS especially, a large contingent from UHAS. Okay. And we also want to acknowledge their mentors that are here. I don't know if Dr. Hubert Amu and Dr. Mauli Kushito. Okay. Because they really mentored these young people. I don't know what I was doing after undergrad, but I wasn't as serious as them, so yes. And finally, I want to mention that today is Dr. Kushito's birthday, so happy birthday. Thank you.
So let me add my voice to congratulate the two winners. I see that the two winners are from the early career, which is what we, as part of this program, as I indicated, we want to be able to nurture a pipeline of early career researchers who take up implementation science as something that they want to do for their career. So congratulations, and in particular to also the others who made it to this conference. I noticed and I observed them from afar. They were all serious, and like Dr. Paine said, I can't imagine what I was doing myself when I finished my first degree. And if I tell you when I finished my first degree, you would say that at that time I should have been serious. All right, so congratulations. The next thing on the closing agenda is to invite our colleagues from the Ghana Health Service who co-hosted this conference to make some closing remarks. And to do that, I would invite Dr. Samuel K. Boachiboatin, the Director PPME, to make some closing remarks.
Good afternoon. Good afternoon. I'm doing this on behalf of leadership, notably the Director General of the Ghana Health Service. So once again, good afternoon, colleagues, distinguished professors, esteemed guests, friends from countries near and afar, distinguished ladies and gentlemen, and acknowledge all under the sound of my voice. As we bring the Health Systems Innovation Conference 2025 to a close, it is with immense gratitude that I stand here on behalf of the Director General of the Ghana Health Service, Professor Samuel Kaba Korea, and for that matter, the entire GHS leadership and staff, to express our deepest appreciation to each and every one of you for your active participation, insightful contributions, and shared commitment to advancing evidence-based innovations to strengthen health systems in Africa. The Ghana Health Service is particularly proud to have co-hosted this important convening with the Regional Institute for Population Studies, the director, my good senior brother, Professor Bauer, under the Sustaining the African Health Initiative Committee of Practice, with support from the Doris Dukes Foundation. Together, we have created a space where early career scholars, as was alluded to just a moment ago, could engage with experienced professionals, where local solutions were shared alongside global best practices, and where implementation science was brought closer to policy and practice. Over the last 2 days, we have shared ideas, celebrated achievements, and explored innovative approaches to strengthen the health system across Africa. Through insightful plenary sessions and engaging para discussions, we have delved into themes such as digital health, universal health coverage, community health, quality improvement, efficient and effective resource mobilization, and healthcare financing, amongst many others. Some of the highlights for me include the use of innovative applications such as telemedicine and geospatial tools showcased by Ghana Health staff. I sat through a wonderful telemedicine presentation in the Volta region of Ghana, where one of the students of the mentors they declared for, and it was very brilliant. And we hope that maybe during the senior managers meeting, there will be the opportunity to showcase it. Insightful self-friendly careers from Ghana and beyond, addressing mental health, chronic disease management, and health system financing, and invaluable lessons learned from a decade of implementing the African Health Initiative on driving transformative change across our continent. One of the key highlights of this conference has been the emphasis on implementation research. By bridging the gap between research and practice, which was emphasized by my colleague director, Abmaku Boateng. Implementation research provides us with evidence-based strategies to address real-world challenges. It enables us not to identify what works, but also understand how and why it works in specific contexts. Through this approach, we can scale innovations more effectively and ensure they translate into improved health outcomes for the communities we do serve. The integration of implementation research in the health system is pivotal as we continue our journey towards resilient and equitable healthcare for all. Practically, as health practitioners and policymakers, we wish our colleagues in academia to work closely with us, especially in the area of health systems and operation research, to solve practical problems that bedevil the people we serve and pursue knowledge management together, Prof. This will free us as health practitioners to do what we know best. We go to the field, we sign papers, and concurrently be well published to remain relevant in the community of academia, nationally and globally. And some can also become professors. This conference has not only provided a platform for knowledge sharing, but also fostered capacity building, mentoring, and interdisciplinary collaboration, essential for advancing our shared goal of health for all. As we transition from dialogue to action, the Ghana Health Service remains committed to scaling up the innovative solutions and practices discussed here. With the momentum so generated, our next steps will involve pilot programs to implement key ideas, ongoing capacity building initiatives, and the creation of platforms to continue fostering this great collaboration. We send heartfelt thanks to the conference organizers, including the African Health Initiative Committee of Practice, conference presenters, and to the Doris Duke Foundation for their support. Together, we are charting a bold path towards resilient health systems. We also take this moment to express our deepest appreciation to RIPS, as aforementioned, our esteemed partner and collaborator. I think they deserve a round of applause, RIPS. We salute you, Prof. Bauer. RIPS has been instrumental in nurturing the African Health Initiative Committee of Practice, which Prof. alluded to when we were trying to remember Lola, and organizing this impactful conference. Their dedication to fostering interdisciplinary dialogue and capacity building have been vital in driving health systems innovation. Ghana Health Service is profoundly grateful for the continued collaboration with RIPS, and we look forward to deepening this partnership in the years ahead. As we return to our institutions, our countries of origins, and our communities, we do so emboldened by a simple truth. Transformation is not a dream. It is a deliberate choice. Let us choose to act. Let us scale what works. Let us deepen our partnership, mentor the next generation, and influence policy with evidence at every turn. Together, we are more than a community of practice. We are a force to reckon with, a force for change. And from this point forward, we march with purpose, united in our resolve as Africans to build stronger, smarter, and more compassionate health systems for generations to come. Indeed, we are generational thinkers. Let us keep this momentum alive. Aiko, and thank you very much.
Thank you, Dr. Wachiboaten. So at this point, I'll call on Dr. Pelche to say a few closing remarks on behalf of RIPS. Dr. Pelche headed the organizing committee for this conference.
Thank you, Director. I was heading it on his behalf. All right. So, since Director PPMED has already so eloquently summarized the conference highlights, what I'd like to do is just acknowledge some of the people that have made the conference possible, and then we'll talk a bit about what the AHI COP wants to do going forward. So at the Ghana Health Service, we really thank the DG, the Deputy DG, and then Director PPMED. We'll be grateful if you can be applauding them as I'm going through the acknowledgements. And then at the University of Ghana, we thank the Vice Chancellor, the Pro-VC ORID, Pro-VC ASA, Provost of our College, College of Humanities, and then the Public Affairs Directorate. We thank our keynote speaker, Dr. Wuno Williams. We thank the members of the Committee of Practice who came from UHAS and UDS. We have been collaborating with them on several AHI-supported projects, and we are really happy to see them. To the presenters, to the moderators, to the participants, administrators, finance, IT support, we thank all of you for making the conference a success. And we especially want to thank the early career researchers who have already been applauded, so I won't speak much about them, but just to encourage you to keep on and then hope to see you progressing through your careers. I won't go through the names, but we want to thank the external reviewers. So the scientific committee had support from external reviewers to review the papers, given the volume that we had, and we are grateful for their support. We also want to thank our poster judges for making the time to come and score the poster judges, and we thank our rapporteurs who will be instrumental in documenting all that has happened here for us to go forward with those findings. And then we also want to thank our subcommittee chairs. So the planning committee had several subcommittees, and we really would want to appreciate their leadership in making sure that all their planning was successful. So thank you to our subcommittee chairs. And then finally, I would like, if the planning committee members are here, just to stand up so that we can really give you a good round of applause for all your hard work. Planning committee members. Thank you very much. I think some of them are not here, but their names are in the program and then up here as well. Okay, great. Thank you all. In terms of the Africa Health Initiative Committee of Practice, so I think you've heard the focus is really to build, a pipeline of implementation researchers to strengthen health systems in Sub-Saharan Africa. And we are doing that through a series of things, but mainly through capacity building, leadership development, convening such as this one, and then dissemination. So this conference is actually quite nice because it cuts across all the 4 things that we want to do. We do have a lot of activities. Some of the things we've done so far to have webinars to help people to translate research findings to diverse audiences. We have training workshops. We are even having one tomorrow on advocacy in action. We give limited research grants. We put out a call early in the year. We funded 3 research projects that are ongoing. We have a mentorship program under our leadership development arm. And so when people are recommended by their supervisors or their employers as potential mentors, their names can be submitted and we would consider them for the mentorship program. Some of the mentees are here, so if you want to find out a bit more, you can ask them how the mentorship program is going. We also have dissemination events to share the findings of AHI-supported projects, and then we also have conferences like this one. So just to let you know, in terms of the community of practice, going forward, we really want to amplify the impact of this conference. So apart from the conference reports, we want to document the lessons learned, in simple, non-technical language that we can share with policymakers and practitioners. We also want to have a newsletter. So we'll be reaching out to presenters. If you are interested in contributing to these learning newsletters, we'd be really happy to have your contribution so that what has happened here can go beyond the walls of this auditorium. Apart from that, please look out for our next call for research grants. We would also have a short course on health system strengthening later on in the year, likely in August, so please look out for that advert as well. We will be conducting a training on systematic reviews for people who have research ideas that want to produce a systematic review on a health system strengthening related topic that is of interest to the project, and then we'll continue with our capacity building webinars. So please just note our website, because that's where all the calls for funding and applications will be, so that you can apply and then you can be part of what we are doing at the Secretariat. And then finally, we really would love your feedback. This is the first time we are organizing this conference. We are really pleased by the response we got, the number of submissions, the interest in the conference, and the feedback we've gotten informally so far. But we would really be grateful if you could take your time to fill out this feedback form. The link is up, so is the QR code, and we'll also share it via email later. And the information will really help us to reflect on the conference and what we want to do going forward when we are organizing an HSIC conference in the future. So before I go, I think I see more of the planning committee members. Please, can you please stand up again so that we can really thank and acknowledge all of you for what has been a good work done. Okay. Oh, okay, all right. I hear you are being invited up for a group photo. So please, can we make it snappy? Whilst people are scanning and filling the evaluation form, planning committee members, please come up for a group photo. I think this is even the last.
Okay, thank you very much, Dr. Che. We are going to try to see if we can, continue with this activity. So we will try to see whether we can raise money to organize another one probably next year. So look out for, any activity that we'll be advertising. We'll be reporting to our donors, and hopefully they can continue to support us to do this. Let me thank the planning committee members. You would all agree with me that they did a very good job. This was not an easy thing to do. We started this very early in the year. We wanted to do this last year, but towards the end of the year, everybody was busy, especially our colleagues from Ghana ISSER Service, whom we wanted to make sure that we do this as a joint program. And so we had to push it to the beginning of this year. And when the year began, there were a lot of activities, so we had a very short period to plan this. But once we started, I made sure that nobody slept. Everybody worked around the clock. And today we saw the product of this. So thank you all. And we'll call on you anytime we have some more of these activities. So finally, let me call on Miss Edith Balobi to say a closing prayer. And after the closing prayer, we will have some announcements from the MC.
Please, can we rise as we pray? Our Heavenly Father, we come before you with hearts full of gratitude as we conclude this conference. We thank you for your wisdom, inspiration, and connections that you have been shared throughout our time together. Father, we pray for your grace, for the lessons learned to go a long way in furtherance of a stronger health system in Africa and Sub-Sahara in a whole. Father, we thank you for your journey mercies. We know that you have already granted us our journey mercies as we depart from here. Take each and everybody home safely. Those who are traveling, Lord, they are in your hand by flight, everywhere, whatever thing we do. Lord, we thank you for guiding us throughout. We bless your holy name as we come to an end. In Jesus' mighty name, amen.
All right, so please, we are not done. There are some announcements that the MC will be making. The one thing that I wanted to say, and I had discussed this with my scientific committee chair and a few others, including the organizing committee, we might, and we'll reach out to those of you who have made presentations. We are thinking of having a special edition from this conference. So those of you who will be interested in taking the work that you have done into publication, we'll reach out to you. We will probably have some negotiations with some of the BMC journals and see whether we can reach an agreement for them to publish the proceedings of this conference. So we will reach out to you. Thank you.
Thank you very much. All too soon, we have come to the end of our 2-day